live microphone. Yeah. And with this little green light, it's perfect.
Good morning, everybody. Good morning. Welcome to PSV's 5th Annual Education Day. My name is Neha Atale. I've been a nurse practitioner with PSV for the last 7 years, and I'm going to be the moderator for today's conference. We started this event about 5 years ago as a way to try to improve collaboration between the primary care providers and the specialists. And we now have over 25 nurse practitioners and physician's assistants at PSV. We have not, due to COVID, had this in person for 3 years. So we're excited to see some of you here in person, and then we have a lot more people joining virtually today. We have a great lineup of speakers, and we're going to get started with some introductory remarks by Dr. Laurel Blakemore. Dr. Blakemore earned her bachelor's degree from the University of Michigan and graduated from medical school at the University of Alabama. She returned to the University of Michigan to complete her residency in orthopedic surgery, followed by a fellowship in pediatric orthopedics at Case Western University. She continues to be clinically active, caring for children with spinal conditions as well as general pediatric orthopedic conditions. She participates in international study groups focusing on pediatric spinal deformity and continues to contribute to areas of research to improve the orthopedic care of children. She joined PSV as our Chief Executive Officer in October of 2020 and has been instrumental in leading the organization and also establishing orthopedic surgery as one of the inaugural divisions at PSV. Dr. Blakemore.
So, thank you. And I really just wanted to take a couple minutes at the start of this conference to thank everybody for doing this. I've been in a couple different medical centers in my career, and I think this is a really unique and wonderful program that our mid-levels have put together, and we're really proud of them and really grateful for the role that the mid-levels play in our specialty care at PSV. They are really key to what we do to take care of kids, and their hard work is part of why we've been successful doing that. So really, I'm here to say thank you. I also, because of the changes that are happening at PSV this year, want to sort of see if there are any questions that we can address briefly, and if not, let you know that if you do have questions about how this is going, either internally or in the broader community in Northern Virginia, or about how it's going to affect patient care, or how the logistics are working. The logistics are a little bit of a work in progress. In brief, PSV is jointly supported and led by these two organizations, right? Children's National and Inova Fairfax Children's Hospital. those two organizations support us because we are pediatric care and specialty care. It can't really exist in and of itself successfully, but it can be a really successful thing when it's supported by a healthcare system like ours. So the two healthcare systems have jointly and equally supported PSV during its growth, and we really grew quite a bit. But going forward, they really re-looked this year at what the PSV provides for them for their visions and how can they align their visions. There was sort of a lot of talk about how the visions weren't necessarily aligned. People felt that in the community. And the result is that they're making some changes. And so they're, as you know, they're moving some specialties into one of the parent organizations, and the specialties where they felt like there was really already an existing strong clinical or research collaboration, or the specialty required the support of both systems jointly, are going to remain. So the ASC is going to remain, orthopedics, neurology, hem-onc, pulmonary, I'm missing somebody, psychology, and GI, sorry, and the other specialties, as you know, are going to be transitioning to one of the other parent. So there's in large part they're going to be in the same building or at Willow Oaks at Inova, the new Inova Children's Building. So we'll be close in proximity, and I think the communication that we've established as a group is going to remain tight because we've operated as a family all this time. And we'll continue to do so. What we really want to do most of all is make sure that the care for patients, if you're referring patients or if you have patients you want to refer within specialties, remains intact and seamless. So that's the number one focus for all three organizations as they work on this transition. And we're going to continue to strive to do that. It's actually an opportunity in some ways to redo our call center, which is, I'm sure everybody knows, has been imperfect. There's a lot of opportunities for making that better. So we're going to take this opportunity for change and with renewed support expressed by both parents to leverage that and say, okay, well, then we're going to take that support and move forward and build what can be really fabulous for what remains within PSV. So does anybody online out in Zoom world or here have any particular questions? Because if not, I can make sure that you guys get my email. You can email me or contact me or contact anybody else on our team. And we really want to make sure everybody feels like there is an open line of communication for questions about this. Okay, yeah, or you can put them in the chat and I can hang around for a minute. I don't want to cut into Sam's time too much. We have some really great talks lined up today, including for my home team, orthopedics, as well as neurosurgery and some of the others. So we're excited to hear the talks. I wish I could say we have a management committee with just that group this morning, so I have to run to that. But again, I think it's going to be a fabulous program. So no chat. Okay, so if you need my email or anything, just contact our organizing team and they can get it to you. And again, I want to thank you guys and hope you enjoy the program today.
Thanks, Dr. Blakemore. All right, so before we dive in, I just have a few housekeeping comments. For those of you here in person, if you could leave your masks on while you're in the auditorium. We're not allowed to have food in here, but we will be serving lunch later. So when we go outside, everyone can remove their masks and eat out there. There's bathrooms just out this door and to your right. If you can hold your questions until after the speakers are finished, they will leave time to take questions after. And if you are joining us virtually, you can type in your questions into the chat window, and then we'll try to get to all of those after the speakers are done. After this is over, you should have gotten an email with a survey, and that's how you'll be able to claim your CME credits. So let's go ahead and get started with our first speaker today, who is Samantha Leahy. Samantha is a physician's assistant who has been working in pediatric orthopedics for almost 6 years. She has worked in pediatric medicine for 15 years. She focuses on gait abnormalities in clubfoot.
Good morning. Thank you so much. I'm learning how to use this little tool. How do I go forward that way? Excellent. Okay, so we are going to be talking about pediatric alignment and gait today. Because orthopedics is by nature just about motion. I am not going to be standing here for some of it. If I move around, hopefully that won't be an issue for people at home, but it'll be easier when we're talking about the exam and how we assess gait and what is normal and abnormal. Disclosures, I don't have any. Okay, so our objectives today are to discuss the difference between normal and basic physiologic gait and alignment. And we want everyone to recognize what is normal, and this way you can talk about what is abnormal. As Dr. Blakemore discussed, there are changes happening in pediatric orthopedics at PSV and in PSV in general. But what that means for us specifically is what we've noticed in the community is that we have the primary care team who wants to refer to peds ortho, but they can't get their patients in who are acutely ill or have had a new injury because we are full of things, where our schedule is full of things that are otherwise normal. So my goal today is to show you what is normal. So those of you who are seeing patients on the front line when you're coming in through pediatrics, so you know what is normal, and hopefully you can take care of some of that at home, at your home facility, because we are only going to be seeing these normal patients, a few of them a month now. And so it's going to take months to get these patients in, and we're going to talk about why, and that's because these things are normal. And so we want to try and use our specialist time to be seeing things that are acute, that are time sensitive. Okay, I want you to become more knowledgeable about in-toeing, gait alignment, so bowing, knock knees, flat feet, toe walking, things that are very typically seen in children, and when you should be concerned, when the red flag should go off, and when you should pick up the phone and say, I'm out of my league, I need some help. So we're going to talk about current treatments, debunked old myths, things that are just not good medicine anymore. So all of these things have changed with time, and as technology and our research is better, we now know that treatments are different now, and some things require treatment and a lot of things don't, and that's okay. So let's get started. Okay, so topics we're going to cover: in-toeing, bowing, knock knees, flat feet, toe walking. Okay, so in-toeing, this idea that when the children walk, it looks like that. If you're bowing or knock kneed, so genu varum, which is the bowing of the leg out this way, versus knock kneed, genu varum, which is this. Flat feet, you all know what that means, and toe walking. So anyone who's up on their toes but can get flat, and we'll talk about that, whether it's something that happens all the time or is sporadic. Okay, so let's talk about the important lower extremity exam. I'm going to move this way so you guys can see. Okay, so when we're talking about hip abduction, okay, so you've got the legs coming out this way or frogging out this way. Okay, flexion and rotation. This is important when we're talking about the hips, often when the children are prone. I'm a mom and I have 3 boys of my own, and I have a fantastic pediatrician. However, I've never seen them flip my kids onto their belly to do an exam. So we know that it's really important to do a hip exam when the children are prone, not only supine. It's important. You won't get an accurate exam unless you do it both directions. Knee range of motion, extension and flexion, your ankle range of motion. It's also important to talk about gait. Again, in orthopedics, if you're ever in our office, you will see children going up and down the halls all the time. And that's because taking 3 steps in the patient's room is not enough distance and not enough of an exam to know what their gait looks like. You will see kids in our office run all the way down the hall, touch the wall, run all the way back. I want to see them moving, because a couple of steps or them sitting on the table is not enough for us to get the accurate information that we need to know what kind of gait they're seeing. Also, walking versus running, it's different. You need to see both for it to be accurate. Okay, when we're talking about the lower extremity exam, we need to do what's called a standing leg alignment So you have something called a mechanical axis deviation, your MAD. What does that mean? When I draw a straight line from the center of the hip to the center of the ankle, that line should go through the center of the knee. That's your mechanical axis deviation. You want it to go through the center of the knee. If we're seeing where the legs are either bowing out or knocking in, that alignment is going to be off. It's not going to be straight. Now, our eyes often deceive us, and we'll talk about that. And that's why X-ray is important in this situation. Balance. We're going to talk about the Gauger exam. And if you don't know what that is, don't worry. I promise you'll know by the time you leave here today. What is a child's balance? Sometimes you'll hear parents say they trip a lot, or when they're running soccer, they can't keep up with the other kids. But is that a parent's perception, or is that what's happening? Are they not as fast as the other children, or is there truly an abnormality? Okay, coordination. Do you see a child using both legs and both arms equally? Do they have an interesting gait where one arm is up and one arm is down, or you have a foot up and a foot down? Is it symmetric? It matters. Okay, neuromuscular issues. We're going to talk about spasticity and clonus, the Gowers exam. I promise we'll talk about it all. And just because it really does make a difference. Okay, the truth. The majority of the time, what we see is normal, or at least a variation of normal. But I promise we'll talk about what normal is going to look like versus what is abnormal, so you'll know the difference. Most of the time, we do have to reassure families that things are normal, but that's okay. Okay, so torsional problems. Okay, so the lower extremity. So we're talking about in-toeing. The children walk like this. You can have two different reasons for this. You can see the picture. We have what's called internal tibial torsion. This is the tibias are rotated. You can also have where the femurs are rotated. You can have one or both. And so what you can see is that on exam, they're just walking. And we see that there's a reason that if they're running in this situation, they're going to be more likely to trip and fall. Metatarsus adductus can be the foot itself turning in, not based on the tibia or the femur. And these can be a combination of all of the above. So we'll talk about the exam so you know what is what. Okay, so the first thing that you need to know, internal tibial torsion and femoral anteversion are normal. Okay, oftentimes it's how a child is packaged in utero. And often when we see these families, we talk about how when you ask them, how long have you noticed this? And most of the parents say, since they started walking. And that's because it's always been that way. And that's okay. Sometimes we can have changes that go due to growth. We're going to talk about that. It's important to recognize that a child's overall health can also affect this. So a child who is having an issue with whether they're not getting enough nutrition, you can also have obesity. All of these things make a difference. Now, the vast majority of the time when we see it in kids, it is normal though. Okay, so the parent comes in and they say to you, I noticed that they're pigeon-toed, their feet turn in, they're tripping all the time. That's what they're going to come in as a complaint. First thing we're going to do is have a conversation. Was the child born full term? It matters. A child who is developing early, is premature, you're going to have more likely, you can have other risk factors, neuromuscular, cerebral palsy, things like that. A child who has had any complications with their birth, was it normal? A normal vaginal delivery versus a breech birth? Were there any complications with the pregnancy or delivery? Did the child need to go to the NICU afterward? All of these things matter because they can be indicative of a different issue, okay? When we're talking about firstborn, this matters when we're talking about hip dysplasia. Female, firstborn, breech birth, and family history. Those are questions you need to make sure you're asking every family, especially when we're talking about in-toeing or any hip concerns. Those are your risk factors for hip dysplasia. And that is one of those moments that if you're getting this information and they're like, oh yes, they were breech. Oh, did you ever get any imaging? No. Now we're going to worry about hips. And so when we're doing the exam, we're going to be looking at that as well. Okay, limping or leading with one leg. So a child who starts to walk who is limping is never, ever, ever, ever normal. Okay, we have had families who come in and their child is now 16, 18 months old, and you notice the child has a limp, and you ask, how long has this child been limping? And the family tells you they've always limped since they started walking. That should never be the case, ever. A child who starts walking who is limping needs an x-ray of those hips. That's hip dysplasia until you prove to me otherwise. So it's important. The hip exam is important, but sometimes hip exams aren't perfect, and we'll talk about that. But if you see a child who is limping from the first time they start walking, please get a hip exam and get an x-ray. What's important? Functional deficits. So sometimes with internal tibial torsion and femoral anteversion, I let the parents talk first. But then sometimes, depending on the age of the child, once we get to that early elementary school age, if you ask them, you know, Timmy, are you able to run and jump and play with all of your friends? And if they say, yeah, and they play soccer and they have no issues, then this is an issue where the parents are concerned of how it looks. I'm less concerned. I treat patients, not x-rays, okay? Developmental delay, this matters, okay? Sometimes our pediatricians and their APPs, even though they see something as abnormal, the parents sometimes don't get the message. And so sometimes you'll speak to a family and you recognize a delay. But when you ask them, they're like, no, everything's fine. Many a time I pick up the phone and I will call the pediatric office with the parents in the room. I'll say, give me a minute. I will call the pediatric office and they're like, oh no, we recognize that it's a delay. We've been talking to the family about it. So developmental delay, we will see differences in gait and pain. Again, internal tibial torsion should be painless. Okay. So how do you know where it's coming from? So you get all this history, you get some information from the family and you look at them and you say, all right, now how do I know what's happening? So we're going to start with take off shoes, take off socks, take off pants. If it's a child who is in a diaper, I'm going to take the diaper off too and hope that nobody pees on me that day. That happens too. Okay, so what I'm going to do if they're really little, if this is a child who's 2 and under, I'm going to have them initially sit on mom and dad's lap. And the first thing I'm going to do is have those knees adjusted so that they're facing up to the ceiling. Okay, imagine these are legs. Oftentimes they're sitting on mom and dad. And if these are, we'll call these my knees, they're kind of out this way. So the first thing I'm going to do is rotate so that those knees are straight out and they're pointing up to the ceiling. At that point, oftentimes what happens is what looked like legs that were turned, suddenly the legs look okay, but the feet overlap. This is internal tibial torsion, okay? Where the legs look okay, but if you covered the feet, the legs look okay, but then you look down and those feet are overlapping. You can see why this child is tripping and falling. This is internal tibial torsion, and it's normal. It's okay. Okay, so the next thing we're going to do is we're going to do hip abduction. We're going to spread those legs wide. That looks okay, great. Now I'm going to flip them over. Depending on how little this child is, if they're under a year, I can often do this on the parent's thighs. If it's a big child or a child who's older, we're going to do that on the bed. Now we're going to go prone. First thing I'm going to do is bend those legs up, and we're going to rotate those legs out first. It's important to know if that is symmetric. Now in this situation, you may even put a hand on the bottom to make sure that those hips stay flat to the table, so that when you do that arc of motion, you make sure it's symmetric. Even a small degree of difference matters in this situation because that can be hip dysplasia, okay? So you go out and in, okay? If you rotate out and you see those feet go all the way out and now they're touching the bed, they've come all the way out, then we're talking about femoral anteversion. And I'll show you a picture. Okay, 5-foot angle. This is when they're laying on their stomach and you put the foot up and you check the angle of the foot to the thigh. I promise I'll show you pictures on the next slide. We're looking at also the lateral border of the foot, making sure that the alignment is straight and normal. Foot progression angle when they're walking. So when they're walking, how how rotated are they? Okay, and the Gowers. Okay, does everybody in the room know what a Gowers exam is? You don't have to raise it. Just give me a thumbs up if you do and a thumbs down if you don't. Don't. Some don't, some do. Okay, I'm gonna take off my shoes for a second. Nope, we'll leave them on. Okay, a Gowers exam. Have the child down on the ground. Cross hands over their chest and aim to stand up without pain. Okay. Now you would think this is a pretty easy thing, but a child who has muscular dystrophy, a child who has cerebral palsy can't do that. What should be a pretty smooth motion ends up looking like this. Okay, it's extra steps. It's not a smooth motion. The Gowers matters. Every child that you're concerned for gait needs to have a Gowers exam, as long as they are big enough to do it themselves. Okay, here's the exam. I promised there were pictures. Okay, the exam where they're prone. These are hip exams. This matters. Making sure those hips, those legs are moving symmetrically, that matters, okay? The thigh foot, you can notice how on the thigh foot angle, that line should go between the second and third toe, okay? Internal rotation, by the way, yes, they're on their stomach. The legs coming out, this is known as internal rotation, even though to you it looks like it's external. It's the hip moving internally. Same thing, external, moving the other direction. And the lateral border, making sure that's nice and straight. Okay, femoral anteversion. Now we've moved up to the femur. A lot of times the families will say, they run funny. They run funny. But so it looks like this. They have this little egg feeder gait. Okay. And that's because their brain is very smart and knows that if my legs are straight ahead, I'm going to be more likely to trip and fall. So this is known as an egg beater gait. It's normal. Okay. Sometimes they'll talk about their kneecaps touching. The W sit is something parents will notice. More importantly, preschool teachers are obsessed with the W sit. So a child who sits when they're playing. Okay. The good news, femoral anteversion is also normal. And so we often have to tell families, please tell the preschool teacher not to panic. They don't have to make them change into crisscross applesauce. It's normal. It's okay. And of course, again, we're checking that hip rotation. Okay, so how do we handle this? If we're talking about little kids, we're talking about toddlers, you're going to see that they can trip, they can fall, but it's normal. There's nothing we need to do about it. If we observe when sitting on the exam table, you may notice the feet rotate in. If they also have the complaint of bowing, which we'll talk about in a minute, make sure that you are checking. Remember what I said, how sometimes those legs look rotated out and the parents think that it's a bowing of the leg. But when you adjust it so those knees are up to the ceiling, again, those legs correct. So even though what they're thinking is a bowing of the legs, a genuvarum, what they're really seeing is internal tibial torsion. Okay, imaging. In this situation, there's nothing to image unless there's a hip concern. And then at that point, we're doing an AP frog of the pelvis to make sure that there's no issue. You can also see with internal tibial torsion, they should never be leading with one side, okay? You want them walking straight, but if you notice that they're leading, you should also get an x-ray of those hips. My clicker stopped working. Hey guys, my clicker isn't working. Help. My clicker stopped working. Oh, thanks. All right. Okay, so treatment, internal tibial torsion and femoral anteversion, we're going to do nothing. Okay, about 45 years ago, we would put kids in special shoes, special bracing, physical therapy. There's a brilliant orthopedist who has now passed away. His name is Lynn Staley out of Seattle, who did all of this research, which shows none of these things work. So we have parents who come in and they say, I intoed as a kid and I wore special bracing. And it's like, I'm really sorry that you had to wear bracing, but we don't do that anymore because it doesn't work. So the good news is we do nothing. Kids will unwind between the ages of 8 and 10 though, okay? Which oftentimes we see these kids as early toddlers or preschoolers. And so when you tell parents you have to wait until they're 10 years old, some of them get really nervous about that, but it does correct. Surgical intervention. The only way to change this or to fix this is to literally cut the bone, rotate it, and plate it. There is nothing else. There's no special shoes, the physical therapy, none of that is going to work in this situation. So after 10, if this is really still an issue, which is very, very, very rare, and the families come in and they want to discuss it, then we have a very significant conversation of how much rotation they think they're going to get and whether surgical intervention is required. But it's very rare. Okay, fun facts. None of this stuff works. The braces, the shoes, PT, massage, the chiropractor in this situation. It just doesn't work. I tell families, save your money for college. It's a better use of your funds. W sitting is okay. I have written many a note to a preschool teacher saying, please leave their legs alone. If children maintain the in-towing after the age of 10, excuse me, Lynn Staley's research showed that what was statistically significant was kids who used the special shoes, special bracing, and physical therapy. It did not make them unwind any faster. The kids who had bracing had reported lower self-esteem, but the kids who maintain a little bit of torsion, whether femoral anteversion or internal tibial torsion, were better runners and jumpers in high school. So if you do maintain it, it is actually an athletic advantage when they get older. Sometimes that soothes parents. If surgery is something to be discussed, nobody should ever talk about it until after age 10. And again, it's a very rare thing for us to deal with that. This does not increase your risk for any kind of arthritis, back pain, knee pain, things of that nature. When do we operate in this situation? We have had kids who literally walk all the way like a duck, right? If they're walking like this all the time, that's different. Or if they're rotated so much that they can't walk and they're like this, or if there are developmental concerns. And therefore, there are other extenuating circumstances. When should I refer? So if you are concerned about hip issue, certainly, or if they're over 10, or there's some kind of functional issue, certainly we're always happy to see them. But if they fall into this other category where they're under 10, these are all things that we've talked about, please encourage families. This is going to get better with time. There's nothing we're going to do to treat this. And so they should wait it out. Concern for hip issues, always see us. Developmental delay, we have physical medicine here in-house. If you are not familiar with PM&R, I often say they are our orthopedic surgeon colleagues. They just don't do the surgical aspect of it. So if there's a concern developmentally, they're a good place to go if you're worried about gait or if they need some kind of bracing. Takeaway, reassure, reassure, reassure. It's okay, it's normal. The child is perfect just the way they are. The vast, vast, vast majority of them do get better on their own, and we don't need to do much about it. And again, save your money for college. Don't do PT, special shoes, things of that nature. Okay, bow legs, angular deformity. Now we're going to be talking about that mechanical axis that we talked about. First things first, bowing of the legs is physiologic. Our littlest kids up to age 2 are their most bowed. By 4, they're most knock-kneed, and at 6, it should be straight. So if the bowing continues into the 3rd and 4th year of life, that's odd. We should see that. If knock-knees continues past 6, that's odd. We should see that. Any kind of angular deformity after 6 is unusual. So if you're seeing that, that's a reason to definitely refer to us in ortho. Important factors. Kids with bowing of the legs, genu-varum, early walkers. So that 9-10 month, those really early walkers, sometimes you're talking to parents, I'm like, oh, they started walking at 9 months. As a mom, that exhausts me. But more importantly, it does increase your risk for genu-varum. I'm going to put this out there. You're all going to laugh, both here and at home. If your child if a child starts walking at 9 months, yes, there is an increased risk for genu-varum, but please don't knock them down. I had a parent, I'm not kidding you, just 2 weeks ago, who said the child started walking at 9 months, but the pediatrician told them to keep knocking them down until they got to 11 months to decrease the risk of genu-varum. Please don't do that. It's unnecessary. Obesity. So obesity is a problem in this country, especially in our children. It can affect their growth plates. It literally can make their growth plates sick, and it can affect the growth so that it is not happening symmetrically at the growth plate. It's very, very important. I know that obesity is a very hard topic to discuss. When we're talking to our parents, it's very, very important to talk to them about not only does it hurt their overall health, it can definitely affect growth. Breastfed and not vitamin D supplemented. Having low vitamin D can also affect the growth plates and can affect how growing is happening. So I know that we are always talking to families, fed is best, but if you're doing breast milk, fantastic. If we're breastfeeding babies, we definitely want that, but they have to supplement. It's really important. Our families who are using a formula, it's already vitamin D fortified, so it's not an issue. And family history. A lot of families will report that there was bowing. Okay, clinical exam. Once again, we're going to make sure that those knees are facing forward, making sure they're facing up to the ceiling, and we're looking at those legs. They should be symmetric. If they're under the age of 2, a little bit of bowing is physiologic, and again, normal. I'm not worried about that. But if we're getting over 4 and beyond, that bowing shouldn't be there. At that point, we need to get some x-rays and look at that mechanical access. Okay, again, we're going to talk about hips to ankles. We do a standing leg length alignment in the office so that we can measure literally to the millimeter, not only the distance from hips to ankles, but make sure what is the distance off the center from the knee. For x-rays, we never do it under the age of 2. The kids can't stand still enough, and bowing is physiologic at that age, so I'm not going to worry about it. But they also can't stand still long enough for us to get an accurate x-ray. After 2, we're going to worry about things like Blount's versus rickets. Again, we're going to talk about so Blount's disease, I'll show you an x-ray in a minute, is where it's severe bowing. We're going to see this predominantly in the African-American community, or in the Hispanic community now, although it's predominantly we're seeing in more of an African-American community. And after 6, anytime we see any kind of bowing for genu-varum, or if at that point we see genu-valgum, the knock knees, we want to do x-rays, because at that point we can talk about doing what's called a hemiepiphysiodesis. Think of it as like braces on the teeth. We can do a very small surgery with either a single screw or what looks like a plate that looks like a figure of 8. And like braces on the teeth, we can guide the growth straight. We want to harness that time of growth. This is not the time to wait until they've gone through their major growth. For boys, we have more time because they hit their big growth spurt a little later. For our young ladies, doing it sooner matters. We're seeing girls get their periods as really early at 10. So if this is a child who's already starting to develop and you're noticing genu-varum or genu-valgum, they need to see us soon, because we don't want to miss that time. If we can get this very tiny minor surgery in as they harness that major growth, as they hit their big growth spurt, it'll guide it right straight. It's easy and it's simple. Okay, the majority of these do self-correct, but if you notice beyond the ages that we talked about, you should have them see us. vitamin D supplementation, we can always test if there's a concern for rickets. It's really, really rare in this country. Children who are truly nutritionally deficient is kind of rare, especially if they're seeing a general pediatrician. Most of the time, failure to thrive or something else is going to pop up first. This is talking about just the same thing with Blount's. I want to show you Blount's versus rickets. So you can see how there's almost like this beaking for Blount's. So if there's true bowing, that's really significant. They have like this hip thrust along with how they're walking. We need an X-ray because our eyes often deceive us. So if there's any concern, if you're noticing any kind of bowing, whether it's through Blount's or if you're concerned the child is nutritionally deficient, we would definitely get an X-ray and we can see rickets or Blount's. Okay, flat feet. How many people themselves have flat feet? Anybody in the room? Okay. The vast majority of children with flat feet, this is not typically an issue, but the parents are really worried. Okay, it's typically genetic. Families, one parent or the other is like, oh, I also had flat feet. The good news is flat feet are typically asymptomatic. It doesn't really matter. Just FYI, children don't develop an arch until they're 5. And that's the start of an arch. So if we have all these little toddlers with all these, what I call Fred Flintstone feet, they're like flat, they're fat and flat, and they like run around. And the parents are like, they don't have an arch. They're not supposed to have one yet. It's okay. And they're running and they're jumping and they're playing. This is fun. So custom orthotics is a thing in this country. I often say, because I work at PSV, I make no extra money to sell you anything, but that's not always the case. Spending hundreds and hundreds of dollars on custom orthotics for children when they grow out of shoes very frequently. Not only is there no science behind it, but there's also, it doesn't create an arch, it doesn't do anything. For all the people who are here in the room and anyone at home who wants to play along, if you take your hand and you take your thumb and you push up in the middle of your hand, just push for 10, 15, 20 seconds. Very quickly, you're like, that hurts. Anybody agree? It hurts, right? So that's what you're doing. A child who has a flat foot, if you put them in an orthotic that has a very high arch, literally all day long, they're in a shoe that's pushing up on the flat aspect of their foot. Now, these are normally developing children. We are not talking about children with Down syndrome. We're not talking about children who have other issues. We're talking about a normal foot. To put them in an orthotic does nothing other than cause discomfort. So try not to do that. So why do we care? I'm fascinated. And I have to tell you that I think COVID made it worse because children were home with their parents all day and all these parents were doing was watching their children all day long. And they're like, my child has flat feet. But when you talk to the children, now that they're all back in school, you're like, do you run at PE? Yeah. Do you run at recess? Yeah. Do you climb and do all of these things? Yeah. And I'm wondering, is the concern? But all of these parents are worried about knees and knee pain, low back pain, things like that. Flat feet does not cause that. The fastest man on earth, does anyone know his name? Anyone in the room? His name is Usain Bolt. He has the flattest feet you have ever seen. He's the fastest man on earth. Flat feet, as long as they're flexible, it's okay. Okay, so you need their feet to be bare, which is always funny because we have kids running in the office down the hall with no shoes and no socks. You want to make sure you're looking at them both seated and standing. Also, I want to know if this is a child who says that they're having pain with running, where are they having pain on their foot? And what are they doing when they're having pain? Okay, so let's look at the exam. You can see up in the corner there, you can see how the ankles look like they're kind of collapsing a little bit on that first image. But then when you look at the second image, you notice how those heels slide right underneath them. This is a flexible flat foot and completely normal. We don't need to do anything to that foot. Okay, up here behind me, we're looking at that subtalar motion. We want to make sure that everything is nice and flexible. There's nothing rigid or stiff about it. Because if it's rigid or stiff, we're talking about some other things, and we'll get there. Okay, so we also want to talk about the flexibility. Sometimes we have kids who have never had an issue with their feet, but they're going through growth, and suddenly they're talking about what they call foot pain, but as it turns out, they're having pain here, right? This is your Achilles tendon. You have a growth plate, or they do. I no longer have any growth plates there, but they have a growth plate at the base of the heel. And if the Achilles tendon is very tight from growth, they can have pain there. That to me is not heel pain, that's Seaver's apophysitis. That's pain at the growth plate because it's too tight. So we want to know what we're talking about when we're talking about. Okay, so differential diagnosis here. Is it heel pain? Is it a Seaver's? Is there a navicular bone? So if there's a little bump on the side of the foot where your navicular is, sometimes kids will say that their shoe pushes on it, and so it's tender to palpation. We need to take an x-ray of that foot. One, is it an accessory navicular? Is it truly causing pain, or is it just pressure from a shoe that is maybe a little too tight on that foot? For an accessory navicular, the only way to get rid of it is to surgically remove it. So we'd have to have the conversation of whether that's really, is it painful enough that it bothers you that you're limping around? Or once we start talking, it's like, oh, you have an accessory navicular. The only way to get rid of that is surgery. Most kids are like, it doesn't hurt that much. Calcaneonavicular bone or a subtalar joint is rigid. You can have a coalition. There are, the bones in the foot are very interesting. They do move on their own. They move as a team, but they should never be rigidly fixed. So if you ask a child to go up on their toes, if they can't, if the child goes like this and they're like, I can't, it's because sometimes there's fixation there. Oftentimes what happens is this has always been the case. They've been like this since birth, but they have to reach a certain height and weight for them to have an issue with the foot. So it's usually starting around 9, 10, the kids get big enough. And some of our slimmer kids, it's a little bit later into their early adolescence. Suddenly it hurts when they're running, but they're an athletic kid. And you can't, and when you ask them to go up on their toes, they can't. Now that's a coalition, and that's a surgical intervention that we would have to deal with. All right, x-rays. If they're having pain or it's rigid, we're going to get standing x-rays, AP, lat, and oblique to make sure that we can see what's happening in the foot, make sure something odd isn't happening there. If they have a painless, flexible foot, I'm not going to do anything for that foot. I'm going to tell the parents, make sure that the child is wearing good tennis shoes when they're running around. Just a few weeks ago, I had a kid who told me he only has pain when he runs around in his flip-flops. Okay, let's maybe not run around in our flip-flops. But that's okay. His mom was concerned, so we saw it. If there's a concern for coalition, sometimes we do need to do a CT just for surgical preparation. Okay, these are just x-rays of what pes planus or flat foot looks like. So we can measure angles to see how flat the foot really is and if it's a concern. This is the tarsal coalition. I think the coalition is really cool. You can see the normal x-ray here. You can see how there's a clear space. And then here on the coalition, you can see how there's bridging callus there. It's usually not actual bone. It's usually some kind of cartilaginous bridge between the two bones. And so it's a fun surgery that we get to break that. On the subtalar, you can see the C sign. There. But again, the vast majority of these kids are a little bit older and they've never had foot pain before, and they're active, and now suddenly they're having pain, but they can't get up on their toes. Treatment is nothing. As long as they have a flexible foot and it's painless, I'm not going to worry about it. Again, we treat patients, not x-rays. So just because the foot is flat doesn't mean it needs to be reconstructed. Flat foot surgeries are very common, but it's a big deal to cut into a kid's foot for something that is otherwise painless. Okay. No special shoes or orthotics are indicated. If the child is having pain, we need to talk about wear, obviously. If a child has otherwise healthy, like has a flexible foot, but they're still an athlete, they're complaining of pain. If the parents want to do something, the most I will tell them to do is either go on Amazon, Target, Walmart, whatever, and they can go and get some like Dr. Scholl's kind of squishy inserts into the shoe. That's fine. If they're truly an athlete, if you've got, you know, your cross country kids or your track kids, kids who are really athletic and running around, we can encourage them to go to some of these other like sneaker stores where they can put you on a treadmill and actually watch your gait, and they can sell you some very expensive shoes. Some families like to do that, and that's okay. Pacers is one of the ones recommended here. It's a running store, but I always tell families, please don't spend a lot of money on these things. Kids go through shoes very, very quickly. Again, I'm a mom first, and to spend hundreds and hundreds of dollars on something that's going to last just a few months before you go into the next group of shoes seems crazy, and when it doesn't help. For kids who are growing kids, if they're having pain here at the heel, we're obviously going to talk about stretching. My favorite one is to have going to go on that. Just dip, right? So this way they stretch their tendon. So for gold standards, this is talking about, like, you know, if we're doing significant bony osteotomies and surgeries, we're not going to just treat a flat foot unless it's really rigid and it's really painful. And those are conversations we have with families, usually when the kids have already finished their growth. Okay, toe walking. Most toe walking is idiopathic, but let's talk about toe walking kind of right off the bat. Kids who toe walk fall into 3 categories. The first one are kids who are autistic. Kids who are autistic toe walk because they do it for sensory integration reasons, okay? So some of these kids who are autistic fall into the category of they do it because they're autistic, and some of them do it because they fall into the second category, which is there's a contracture. Kids who have a contracture, we have to do something about, and we'll talk about that. But the vast majority of kids who toe walk, they do it because they can, and it's a habit. It's not usually dangerous or concerning. We do have to screen for neuromuscular conditions like CP. Also, a child who suddenly has never been a toe walker before, but suddenly the mom's like, oh, only one side and we're toe walking, we're going to be worried about neurology and things like tethered cords and other neurologic conditions. Luckily, we have great colleagues that we can refer for that. But those kids may need more aggressive treatment, okay? And we have to find out what their neurologic condition is before we'll have to address the orthopedic condition. But the biggest factor is age. So the first thing I will have the kids do is, you know, the mom talks about how the child has been toe walking for years. First thing, take shoes and socks off, take a walk down the hall. Let's see what's happening. And a lot of times the child will come down flat. And I know, because the parents are here, that this is clearly not the way the child walks. And so the first thing I say is, I don't care how you walk. If you like to walk on your toes, you show me how you like to walk. And I want to see them walk all the way down the hall. And then they walk back. And I say, okay, now I want you to walk how mommy wants you to walk or how daddy wants you to walk, depending on who's there. And then very quickly, they can get themselves flat. This is where I know this is idiopathic. This is a habit, and I'm not going to worry about it. However, if this is a child who, when they start to walk, they either can't get flat or they get flat and they can put their heels down, they instantly stick their butt out. I know that they have a contracture here. So that's a concern. Those are the kids we actually have to intervene. Again, in this situation, birth history delays, speech and other cognitive delays are important to find out because we need to know kind of which pathway we're taking here. Is this an orthopedic issue? Is this a physical medicine issue? Is this a neurologic issue? So, okay, so we have your gastroc and you have your soleus. They both help with dorsal and plantar flexion here. So we check when the kids are both seated with the knee flexed as well as extended, so that we can see, does that foot come to neutral? So basically these kids are up on their toes, right? And when I try to get them flat, I should be able to get their foot flat to the ground or flat on my hand. If I can't do that, if I push up with all my might and that kid can't get his foot flat, I know we're talking about a contracture, okay? So then there are steps we have to take. So those kids, we're gonna talk about, first things first, we're gonna start with physical therapy, right? Go as simple as we can, most basic. We're gonna start with some physical therapy, see if we can get the child to buy in to work on their gait and to work on stretching. If that doesn't work, I allow them to go for that for a month, and then they come back and they see me. And if they still can't get their heel down, now we're going to talk about serial stretch casting. At this point, I'm going to have them lay on their stomach, and we're going to push down on that foot, and we're going to cast it. And so it's locked flat, and they're going to walk like that for a week. And every step they take is going to be a stretch. And initially, it's a little rough. And then they come back and see me in a week, and we're going to take that cast off, and we're going to push them flat again. Only we're going to stretch even more, and we're going to do that week by week, and it usually takes about 4 weeks. At that point, we should be flat. If we have gotten to that point, then they go back to PT, and hopefully they come back and they see me in a couple of weeks, and hopefully we're doing okay. If we've done stretch casting and we still haven't gotten flat, then it's time to talk about surgery. And at that point, we can talk about lengthening either the gastroc or the soleus, depending on, and sometimes both, depending on what we're dealing with. The vast majority of these kids who are idiopathic, though, it's their preferred way of walking. They're able to walk and they're able to jump. So as long as these are kids who don't have issues and they don't have a contracture, I'm not really going to worry about it. All right, when to refer. If they're really unable to dorsiflex past neutral, or at least to neutral, that's a problem, especially as our kids are getting older. Things are going to get tighter as they grow. We see kids as early as 6 months, which I always find funny. They're not walking yet, but parents are worried about toe walking. And we see kids all the way up into their teens who have always toe walked. And now suddenly they're tired of it and they need to talk about surgery at that point. It's important to know about developmental delay and spasticity. As I said, we would have to talk to some of our other colleagues. We talked about this. Kids who are under the age of 2, I'm not going to worry about it. I'm not going to put them in PT. This is a tough age to get kids to do any kind of therapy. So when we're talking about toe walking, it's just not worth it. They're not going to get anything out of it, and they're too little for it to make a difference. If they're 2 to 4 and it's flexible, I still tell parents, don't worry about it. Once the kids are in elementary school, I tell parents this is a good time if the kids are willing to buy in. You can do things like sticker charts and reward charts and stuff if they remember to go with their feet flat. But we don't really worry about it until they're older. I often tell families a story. One of our surgeons in the office, his son was always a toe walker. It drove his wife bananas. And he would tell her, his wife would say, you have to do something. He'd be like, I don't. And then one day the family went on vacation. They actually went to Europe. And by the end of the day, his son, who at that point had turned 10, at the end of the day said, Dad, my foot hurts. And his dad was like, I know. By the end of the trip to Europe, he wasn't a toe walker anymore. Because once you get big enough and tall enough, if I asked all the people in the room all day long, you need to walk, either in high heels or up on your toes, by the end of the day, you want to hurt me. And that's because we're all adult size. But these kids, they don't weigh anything. They're tiny. So it doesn't hurt them. They just think it's fun. But for those of us who are adult size, at the end of the day, I don't know about you, I very rarely wear heels because my feet ache at the end of the day. It's the same thing. So once they get big enough, tall enough, or they weigh enough, they stop, as long as they have a flexible foot. These are some of the stretches I showed you over there. We'd like to do Achilles stretches. That helps. The serial casting only if we have to, and then if that fails, we have to go to surgery. Okay. Questions? Yeah. Sure. Mm-hmm.
So I know you said
you could see. Yeah. So
No, I was just kidding. So I was wondering if he's holding it. Like, um, I think, but
It's only pain. It's only pain. No, if he's running, jumping, playing, he's 12 and doesn't have an issue, don't worry about it. Sure. Any questions? Yeah, anyone at home, if you have a question, please go ahead and put it in the chat. I'm happy to answer from there. Okay.
surgery.
During gastrocsoleus lengthening, we make a very small incision here. And so the gastroc lays just on top of the soleus. So you should be really careful. You start with one and you should be able to get enough length. You just gently cut it. If you have to do both, we can sever both. When we're talking about the Achilles tendon, that's different. That's a Z lengthening where you kind of literally make a cut that's more of a Z and you let it slide. You don't cut the whole thing. The only time we cut the actual Achilles tendon is if we're talking about clubfoot babies. So the Achilles is more of a Z slide, but the others we can actually cut. Anything else? Oh, Ehlers-Danlos. So Ehlers-Danlos is a overall issue. There are so many different types of Ehlers-Danlos. So to be honest, it depends. It depends on how severe. We have kids with Ehlers-Danlos who have significant issues, like when we're doing basic surgery on them, like the whole skin, everything is the elasticity is gone. So the answer is it depends. Any other questions? Are we good? Okay. Thanks, everybody.
Thank you, Samantha, for the great talk. The next speaker is going to be Peggy Ballstad. Peggy is the founder and director of the Spina Bifida program at Pediatric Specialists of Virginia. She served as the division director of pediatric neurosurgery from 2020 to 2022. She is the physician's assistant to Dr. Leon Moores, and together they are responsible for providing neurosurgical care to the pediatric population of Northern Virginia. Peggy has enjoyed over 19 years in the pediatric and adult neurosurgery in both the USA and Europe. Together with the ministers of health in Norway and Malawi, she helped to start the first neurosurgery program in the country of Malawi, which is still going strong today. She has also managed international cardiac and neuroscience clinical trials in India, Switzerland, Norway, Canada, and USA. Peggy earned her Bachelor's of Science at the University of Wisconsin and then completed her Master's of Science at Colorado State University. She then started her career in research as a cardiovascular physiologist and attended the Physician Associate program at Yale School of Medicine. Peggy?
Okay, thanks everybody. So like Neha said, I'm Peggy with Pediatric Neurosurgery, and I work together with Dr. Moores, who you see up here. And we mostly do neurologic brain and spine surgery. Although we're pediatrics, we still see we still see adults as well who have childhood conditions or genetic conditions that haven't been discovered until later, like tethered cord, spina bifida, things like that. So today we're going to talk about brain tumors, just kind of the basics of neurosurgery, where things that you would refer for, or things that you might want to know a little bit more about. I gave this talk about 5 years ago as well, so for some of you it may be a repeat. So brain tumors, we see lots of skull fractures and trauma, of course. One thing you guys refer a lot for is probably increasing head circumference and head shape. So we'll talk about that today too. We won't get to spina bifida, that's this picture right here. We won't get to that today. That's kind of a bigger talk for a separate time. So we'll start out with brain tumors. So symptoms, first of all, they're exceedingly rare. There's hardly ever brain tumors. I think it's like 1 per 200,000 kids. So it's not something that you really need to have in your differential when you're seeing these kiddos. But how we discover it is over time, they start to get more and more ataxic. They have frequent and persistent vomiting that starts to get worse with neurologic signs. Headaches are worse in the morning after they've been laying flat because the pressure is building up inside if they have an obstruction from the tumor. Vision changes, eyes changes, nystagmus. When they go see the eye doctor, they may have papilledema, which is indicating high pressure in the brain as well, and cranial nerve deficits. And obviously, if there's seizures or excessive drowsiness, coma, you would get a head CT. These kids start to get, when they have a brain tumor, they start to get very used to the high pressure in their brain because the tumor typically grows slowly. And so the kids seem fine and they do well and they do fine until they hit that point on the compliance curve where suddenly they just can't take it anymore. And that's when they'll develop symptoms. The protocol that we would do is if you suspect anything like that and you're seeing these kind of things and your gut's kind of telling you, you know what, something's really off here. This kid keeps coming back and the signs are as the ones that we just discussed, you just send them to the ER for a CAT scan. We'll see it right away, obviously. And then we'd admit them to hem-onc and then we come in. Before we do surgery, you may feel like, why aren't we doing surgery right away today, tomorrow? We first, before we open up a brain tumor, since we don't know what pathology it is, if it's like a benign pathology, like a juvenile pilocytic astrocytoma, or if it's a medulloblastoma, which is not benign, we want to first do all the scans before we would open that up. So we want to do a screening of the spine to look for drop metastasis. So although it may seem like you'd want to just take that out right away, you want to first get all your data and start that kid on Diamox, Decadron, to take the swelling down. That will actually help your surgery to be safer. But it's hard because families, and some providers who aren't in neurosurgery feel like, well, just take it out right away. But you always, first do no harm. You want to make sure that you've done everything, decrease the swelling, go slow. If the child totally crumps and is in the PICU, we can always put in an EVD to drain a lot of that fluid and a lot of that pressure, and they'll feel better and they stay safe. So if they're unstable and they have hydrocephalus from it creating the pressure, we can place an extraventricular drain at the bedside in the ICU. You don't really want the parents in the room while you're putting a hole in their kid's head. I did have one dad one time who said to their kid, he was 18, granted, and the kid hadn't gone to work that morning. And the dad was like, this is ridiculous. You're probably out last night. You're throwing up in the morning and you don't want to go to work. This is ridiculous. And then as I'm drilling the hole in the kid to put in the EVD, the dad goes, well, guess you needed to go to work today like you needed a hole in the head, huh, kid? And I was like, oh my gosh. And he looks at me, goes, too soon? I'm like, way too soon. Okay, because he's not even totally sedated because he was 18. But anyway, yes, you put a hole in their head to drain the fluid as a bridge to surgery. And then they follow up with the hemonc team as well. And we have a multidisciplinary team that works with all these patients and their families together, because it really is a big, impactful thing for a family. So here's a picture of one of our kiddos who, you know, continuously presented with occasional nausea, vomiting. It just was getting persistent, like you said. They went to the ER and they were discharged with GI follow-up because, you know, I mean, nausea, vomiting, yeah. And by the time the kid got to the GI doctor, they were noticing nystagmus. So there comes the neuroscience. So they're having now neuroscience. So GI actually sent them to the ER to get that head CT. And then, I mean, my laser pointer's not working, but this big thing should be there. So then we did what we talked about just now, where we started them on Decadron and Diamox to make the child more comfortable, to kind of decrease the fluid, and then got an MRI of the cervical, thoracic, and lumbar spine, and then took them to the OR for a section where Dr. Moore's there is saying, "What are you doing?" And I'm saying, "Look at the camera. We're going to take a picture." And he's like, "Wait, why are we taking a picture?" And then this is a nice picture with our microscope. We have a very big operating microscope that's fantastic. It's like looking, I mean, it's just so clear when you're looking through it. So you're kind of looking through it and operating, and the amount of detail that you get through that microscope is very helpful. So here's an example of the hydrocephalus from obstruction of a brain tumor. The brain tumor is at the bottom there in the cerebellum. You can see, here's, to orient you, here's the eyes. Right in the front, you can see the globe, and in the cerebellum, you see the tumor. All this extra fluid shouldn't be here, so big and bowing out. And then you can see the child has some transependymal flow in through the brain there. And then here's just a different slice. This was a sweet little 3-year-old. Neurology sent this to us. And I mean, she was fine. She was walking and talking and planning her birthday party, and everything was fine, but she was just, you know, a little punky and couldn't figure it out. Neuro got a scan. That's what they saw. She was such a doll. Unfortunately, the day we had to take her to surgery, it was her 4th birthday. So we got Dr. Morse to dress up like a cat, because the child likes cats, and so he should dress up like a cat and meow and do all the things to make this child happy before he opens her skull. And he did. You can see you probably can't see it, but we all have like whiskers drawn on our faces and are wearing cat ears. Even the anesthesiologist did it. So and I never thought he would do something like that because he's a little gruff, but he did. He complied, and we put a birthday hat on her and everything. And, you know, this picture is about 5 years ago. She's doing amazing. I mean, she's doing just fine. And by this point, I'm sure that they've totally forgotten that the child even had a brain tumor. She had a juvenile pilocytic astrocytoma, which is benign. And we did serial scans for a while, and now she can stop that. And she's got a good college essay. She'll be fine. And then there we are operating. This was supposed to be a video kind of demonstrating how tight the brain is when you open it and you've got such a big tumor, and how you want to be really patient before you start your surgery and just kind of like barely move it and gently suck out as much of the fluid, as much of the cerebrospinal fluid as you can to decrease the pressure before you start your surgery. And that's a technique that I hadn't seen used before I started working with Dr. Moore's. And I think that's really good. It provides a safer surgery, less compression of the brain while you're working with the brain and putting pressure on it with retractors, et cetera. But in this video, you could see that the brain is not, if the video doesn't work, you could see that the brain was very tight. And in this next video, you could see after we opened the dura and took some of the cerebrospinal fluid out, you could see that then the brain was suddenly pulsing as it should be. You want it to pulse. The other thing we do a lot of is head trauma. I must see at least 5 or 6 skull fractures per week. During pandemic, it was even more because kids were stir crazy and they're going out doing all sorts of crazy things. Oftentimes without helmets, and when parents were tired of the kids being in the house, so they were like, that's great, just go out. And even more frequently, we're not checking if these kids were wearing helmets. So lots of accidents, skull fractures, and lots of new parents drop their babies, or the babies roll off of changing tables, or they roll off of the bed onto a hardwood floor, or parents, grandparents, fall, or the baby falls up, or someone's putting their kid on their shoulders and then the kid bucks and falls off and they'll fracture their skull. It's honestly, it's no big deal. Like, I know that sounds weird, but it is really no big deal. And I'll tell you why. Ortho can tell you why. So I'll tell these parents, listen, if the humans couldn't be dropped as infants and hit their skulls, the human race would not have survived. So what happens is when you have a skull fracture, that bone's response to a fracture is to set down more bone. And so I'll tell the parents, it's even stronger now. So good job. And they feel a lot better. So in that portion, it's even stronger. Where you do get worried and where you take them to the ER is if they have a loss of consciousness, they have vomiting, dizziness, ataxia. And then, like I said, skull fractures, if they're displaced, especially right here, like last Friday, we did a displaced skull fracture because it was cosmetically deforming and there was some pneumocephalus inside where a tree branch had fallen and that could get more infected. So we did do surgery on that, but we maybe only have to do those surgeries a couple times a year. Usually they're non-displaced, no surgery, go home. If there's a little bit of bleeding in the brain, that's no big deal. It'll absorb in a couple weeks and they'll be fine. There's no need to rescan those kids even or do follow-up CT scans, exposure to radiation. You just don't need to. Very rarely, but we do see it, you get malignant hypertension. Very, very rarely. I'll give you an example. We had an 8-year-old male who presented to the ER with abdominal pain. When he was getting his x-ray, he slipped and fell on the concrete floor in the hospital and hit his head. No loss of consciousness, but he had a skull fracture. We usually admit them and observe them for a little while, especially if they have a small epidural hematoma, not a subdural. A subdural is kind of not that big of a deal, but an epidural hematoma, we want to watch carefully because that's more of an arterial bleeder and it can just suddenly expand and pulse. So you want to keep them in the hospital and observe it based on that CT scan of the head. So 6 hours later, he had a sudden intense headache, 10 out of 10. He lost consciousness and we got a stat CT and straight from the CT, we sent him to the OR for an emergency surgery. So the epidural hematoma, like I said, if it's arterial, it looks like this and it does not cross the suture lines of the skull. And we're worried about that. We want to monitor that. The subdural hematoma that you see on this side, not so worried unless there's midline shift. And this one I would send home. This one I want to keep in the hospital and watch. And because your goal is to get them immediately from that CT scanner, like fly down the hall on the gurney with the child, shave the head, get everybody assembled and get the skull open. So here's the skull before. Dr. Moores and I are opening it. We made a burr hole, that's the hole in the middle, and an incision with a saw all the way down to take off both sides of the skull. It's very rare that you would take off both sides of the skull. Usually you can take off one side of the skull, let the brain expand and swell, and then put them in the PICU and they'll be fine for a while. But in this case, like we could kind of see The brain was very, very dark, very black. Her pressures were very high. So we took off both sides of the skull to give this kid like the best chance, anything we could to save her. And you'll see that thin strip of skull in the middle on this picture. And then you see dura. It should be pink. It should not be black like that. And you see that it's black intense. And we made some fenestrations in the dura, as you can see here. And it was just still venous blood coming out. So she did not make it, unfortunately, and we knew her very well. Most of the kids, but she had fallen at home and not gone straight to a head CT. She had fallen a couple times at home, just onto the floor. And her brother had pushed her onto tile, but I think because she had fallen twice, that she got the malignant hypertension, and this just didn't work. Most of the kids it does work. We have about 6 kids that we follow where it's totally worked. They're fine. They're, they spent a while in the PICU. And then 3 months later, we put the skull flap back on. So the skull flap you can put in a bone freezer if your hospital has one. I did have an 18-year-old boy in Texas, however, where we did not have a bone freezer, and we had to put the skull flap in his abdomen. And when he woke up, he was so mad. He's like, "What's in my belly? Why is it so big and hard?" I'm like, "Oh, I had to put your skull in there just for safekeeping." I'm like, "You won't lose it." He's like, "Oh, it really hurts." But it didn't get infected. But I had to tell him multiple times, like, "No, you can't play basketball until we put your skull back on. So you got to wear a helmet." But those helmets look so stupid when you're 18. So we got the skull on him 3 months later, but I was very nervous until we got it back on. He did fine. He had fallen off of a roof. And again, it was, 30 minutes, get him to the OR. And he did great. No neurological deficits, most of the kids. All right, so we'll talk about something a little less dramatic. So increasing head circumference, you guys sent a lot of those to us, like, why is the head circumference increasing? The most common cause, honestly, is that the parents have big heads. The polite way to ask that is, do you guys wear a large cat size? What about your husband? Does he have a hard time finding hats? Typically, it's, excuse me, typically it's genetic. The other things we're worried about that are much more rare that we should be able to look at and see kind of from across the room when we see them is benign extraaxial fluid collections, hydrocephalus, and brain cysts. Those are the other reasons that you can get a head circumference that looks like this. So it's rising up off the charts. It's getting really high. I'm still not super worried. If I see a head circumference like this with a wide open fontanelle, I'll get a head ultrasound just to look, and that'll sometimes show benign extraaxial fluid collections, which is the CT scan here. Benign extraaxial fluid collections are no big deal. What's going to happen is that head circumference is going to start to jump around age 5 months. It'll track normally, and then at 5 months it crosses percentiles, and it keeps crossing percentiles until 12 to 18 months. And everybody gets kind of really excited and worried because the child also will have frontal bossing, where this front portion is bowing out. And that looks concerning, right? You've got frontal bossing, a head circumference, crossing percentiles. Definitely send them to us. But if you get the head ultrasound, you would see this benign extraaxial fluid collections. No one knows why they happen, but they disappear after age 2. And they're no big deal. They're not compressing the brain. They're not a problem. Resolves around age 2. Yeah. This is hydrocephalus, and that's a clinical diagnosis. So it's terrible. It's difficult for us when we see a radiology report that says hydrocephalus. We're like, that's not hydrocephalus. Hydrocephalus is a clinical diagnosis. Ventriculomegaly is what the radiologist is seeing, that the ventricles are very big and the ventricles are getting bigger. This is hydrocephalus. You're seeing clinical signs of frontal bossing, very thin paper like scalp, prominent scalp veins, and you need to see all of this. So if you just see prominent scalp veins, it's probably because a child is light skinned and you see their scalp veins. But if you see all of these things together, thin, translucent scalp, large open fontanelle at the top, maybe even in the back, they're irritable, they're not feeding well, they throw up, not spit up, they throw up, and it's persistent. We're still going to watch them a little bit. A shunt is not an emergency in a baby. Even if you see this, we're not going like within 30 minutes to the OR. We're going to schedule them for tomorrow, for the next day when we have a completely clean OR so the shunt doesn't get infected. So we have the A team there. Like it's not an emergency because those kids have a pop-off valve, right? They've got the fontanelle. Their head's just going to get bigger and bigger and bigger, which is a little scary and unsettling unless you see it all the time. Their head's going to get bigger and then we're going to divert that fluid and it's going to be fine. When you can't wake them up, that's concerning. That's like, let's go tonight and put the shunt in. This is a kid who came direct Cairo Dulles and then took a cab to Fairfax and was like, can you fix my baby? They had a myelomeningocele that in a different country they did not want to fix, and they said, we're sorry. So she had a huge open spinal cord on her back for 3 months and hydrocephalus that was getting worse and worse. And it was just such a pleasure to say, yes, we can fix this. Yes, tomorrow we will fix both. And she did great. She's wonderful. Slightly delayed and can't walk because that's what spina bifida sometimes does, but great quality of life. She's doing fine. I just want to explain shunts to you because sometimes before you know a lot about them, there's such a mystery, like where do they go and what do they do? When we do put in a shunt, it goes, we first drill and in the children, we don't even need to use a drill. The skull is so thin and kind of flaky that you can just like take a portion of the skull off. You don't really need the drill. And then you know anatomically where you are, and you pass a small silastic tube that looks like a tiny straw and has fenestrations at the end. You pass it through the brain, and when you get into the ventricle, you pull the stylus out, and a bunch of CSF just comes pouring out. And CSF is beautiful. It's clear. It's clean. We like to call it the champagne of all body fluids because it really is. So this clear fluid comes out. And then you tie that down and hook it up to a valve, a mechanical valve that sits here. So you've made your hole here, then you hook it up to the mechanical valve here, and you tunnel it under the skin. And then this is a little gruesome, but you use a large, like a guide, like a long metal instrument that's very sharp. It's about this long. It's got a T-handle on the end, and you shove that underneath the skin all the way down the neck, down the chest, and down to the belly. And you warn anesthesia that there's going to be a lot of chest compression because you've got this big long steel thing in them. And then you make a small incision here, and then you tunnel the tubing, the other end of the tubing, all the way down here, and you shove the rest in the peritoneum, making sure not to disturb the bowel because that would be really bad and that would infect it. And GI will not be happy with you. But we have never had that happen. But then you curl up the tubing in there, and this mechanical valve allows the CSF to regulate itself. It's not like gravity, just putting all the fluid into the belly. It's regulated by the pressure that the valve is saying you can have. We don't go lightly into putting those in simply because they get infected. It's a mechanical thing. It can malfunction. The tubing can snap in the neck, and you have to repair it and revise it. And that's hard on the whole family. But if the kid needs it, they need it. But unlike a lot of other institutions here, we don't jump to that. We make sure that they absolutely have to have it because a lot of times they can ride it out and not need it. This is a really good example though of one of our NICU babies who they said they were certain that she had, what is it called when they think there's no brain tissue? Is that anencephaly? What is anencephaly? Yeah, sorry. I mean, I should know that. So they thought she had anencephaly, no brain, and they gave this family, a terrible prognosis of there's no brain, it's not going to go. And that's really hard to tell, right? Because it does look like there's no brain. It is incredible. 2 years later, this is what expanded out of that when we put a shunt in. Like, this is the same patient. So I feel like it's always good to maybe give them a shot, but it's hard if you have a kid with anencephaly, like there's no brain. It is just water. But in this case, that's like a thin little ribbon of brain. She's running around, bossing her little siblings around now and everything. So that's how the shunts work. Here's another example of, this is one of our spina bifida babies. All these pictures are posted with permission from the parents directly, and they've signed waivers, so just FYI. You see the frontal bossing on this little one? This is before the shunt, and we knew she'd have a hard time controlling her CSF just because she was born with an open neural tube defect where all of the fluid is coming out and it's not regulated because her spine's open, right? So we used to, 20 years ago, we used to just fix the myelomeningocele, the spina bifida, as soon as they were born within a day or two, and put a shunt in right away in the same surgery. And what we're learning now is that that's not totally necessary. And the repeat surgeries that you would be doing were frequently on spina bifida children who had shunt malfunctions. The shunt gets infected, the shunt breaks, and they undergo so many surgeries that they end up getting allergic to latex because they're in the OR all the time. So some institutions, they are still doing a shunt right away, but what we're finding is if we wait to see if they really need it, only 50% of our spina bifida kids are needing that shunt, which is great. If you don't have to have foreign body in your body, that's better. So this was one that we waited until she was like 3 or 4 months old, but she started showing us, oh, he was right, I can just do this. She started showing us that she was maybe trending towards a shunt here, but then here we really noticed that, she's going to need some help. She's got the frontal bossing, prominent scalp veins. And then you see after the shunt, she has this huge sunken fontanelle. That's okay. And I like to warn the parents beforehand so that when the baby comes out of surgery, they're not alarmed, because this can look scary to the parents. Here's our sharp bones. But they do fine. It puffs out. That's just because we drained off a lot of CSF when we put the shunt in. This is her like 3 days later. So, yeah. Another reason for head circumference that can be crossing percentiles like that is our brain cysts. Super rare again, but we do see them. This right here is the brain cyst, and it's causing an obstruction in the ventricular flow of the brain CSF. And so these are huge. These are the lateral ventricles. They're really big. You can see bowing of this ventricle. It's big. This is the brain cyst. So similar presentation to hydrocephalus. This little one who you can't see, she's actually waving at me in the picture. Whenever you would say wave to Miss Peggy, she would be like, and she was so young, but she's got prominent scalp veins, frontal bossing. She was starting to have a downward gaze, increasing head circumference. So we saw them in the ER. The pediatrician sent them to the ER, and then we shunted her the next day to bypass this. And we also fenestrated the cyst so that and you take a portion of the wall of the cyst so that it doesn't grow back. She's doing great. And then head shape, that's always a weird thing, right? Like the baby's heads are shaped weird, and why is that? And we see a lot of families for that. We didn't have issues with head shape or anything until in the 90s when the back to sleep campaign started. Because most families before that and families in other parts of the world would say, would lay the babies on their belly so that they didn't aspirate. Because if the babies threw up, or spit up, they'd spit up and not swallow it or not aspirate it because they were prone. Well, then we started seeing, is there a link between SIDS and things in the crib and kids being on their stomach? So we started the back to sleep campaign. And as soon as that started, neurosurgery started seeing so many parents and grandparents in our offices saying, oh my gosh, I have never seen, what is wrong with this kid's brain and head? I've never seen a head like this. It's got to be terrible. And the reason is the baby's job for the first 3 to 4 months before they're rolling over is to lay on their back. And that flattens the back of the head. The other thing, remind your parents that when they hold the baby, especially if they're not nursing, they'll get flat on one side, because who doesn't love to feed a baby in just one arm? Like, I only like to feed a baby like this. Okay. Even if I was nursing, this side was just easier. We all have a preference. But with nursing, you're putting them on the other side as well, so the head shape gets a little bit better. They need to remind others that are feeding the kids to either use the boppy and have them on that. That's not as cozy. So try and, use the other arm. I've seen kids who have hydrocephalus as well, where their heads are getting really big, but the mom, they actually have anencephaly, but the mom is holding them a lot. And one child had the mom's arm shape in the back of his head because there wasn't much brain to push out that skull. And that child had anencephaly, mostly water instead of brain. And so there's no brain to push out the skull. That's a different kind of case. But what I'm trying to say is the brain is the driver of the skull's shape. And that's the most important thing to know. And that's how it'll make sense to you, is that the brain is the one molding the skull. It's not the other way around. And before I was in neurosurgery, I thought it was the other way around. Like if the skull is like this, I, for some reason, assumed that the sutures were kind of closed, but the sutures of the babies are not closed because our sutures are closed. So if you and I have an increase in our brain pressure, we're going to be unconscious in like 30 minutes. Or 30 few minutes. If the kids have an increase in brain pressure, their sutures of their skull are still open, so their head's just going to get big. And the other thing to remember is the skull is very, very thin in the infants, so thin, which is why we can flake it off instead of having to use a drill. So if we have to operate on one of you, we're going to use this huge drill. We're going to drill through a couple centimeters of bone to get there. With the babies, you don't need to do that. It's flaky, which means that when the brain grows, as it should, as you want it to, the brain pops that skull out into the beautiful shape it's meant to be, not the other way around. So I tell the parents, as soon as the baby's rolling over at night, the head shape is going to start to get better. So the head shape's going to get worse and worse and worse from birth. Beautiful head shape, right? Unless they were up against a hip in utero. Beautiful head shape is going to get worse and worse and worse. Month 2, month 3, it's going to be at its worst. That's when the parents are going to come in and say, and pediatricians usually say, got to see someone. I think this is craniosynostosis. But after they start rolling over at night, it'll slowly get better and better and better. So I tell the families, take a picture of the kids straight from the front, straight from the side, and straight from the back, and down from the top after bath time. So the hair is kind of wet down, and compare those pictures. And when you wake up at 2 o'clock in the morning, you're like, oh my God, do I need to see a specialist? Do I have to take them back? What's going on? Go to your data in that file of photos from every month or week, and you'll see it start to get worse until 3 or 4 months, and then better and better until they're sitting up at night. Until they're sitting up during the day. They're spending more time in a high chair. They're rolling over at night. Craniosynostosis, on the other hand, is when one or more of the sutures is closed, and this child's getting a deformation. They're going to have a progressive deformity. And that you want to refer to neurosurgery as early as possible, but that's going to look different. It's going to look like a big ridge here, and you walk in the room and you see this kid, they need to see someone. It should be obvious. It's cosmetic. I know in a lot of the literature and a lot of other lectures, it will say you can cause developmental delay and brain damage and all this. That's only if it's more than one suture. The brain wants to grow, so it's going to grow. It's just going to grow in the direction of least resistance. Oh, I talked about the back to sleep campaign and the positional molding. Some things that, let me just go back to that for a second. Some things that I'll tell the parents are, if they're in the car seat a lot, the infant car seat, and it's on one side, just put the car seat on the other side of the car, or if there's something interesting like a sibling or the window, switch things around so that they're wanting to look to the other side. Molding helmets are not necessary. I feel so bad when I see these kids in the grocery store that have like the molding helmets, because they're thinking that the skull is what molds the head. It's not. Remember, it's the brain. And the parents, the molding company is a cottage industry, and they make a lot of money from this, from kind of, I don't want to say preying on parents, but you go in there and you see that they take all these pictures that look really dramatic of your kid in this little bonnet, and it looks really bad, and they do a lot of angles and stuff. And parent, like, don't you want to do everything for your baby? You need this molding helmet. You've got to, get multiple molding helmets. There's like $3,000-$4,000 and you need multiple ones. They don't do a thing. There's been really good studies in the Netherlands that show they took kids with similar head shapes and they put half of them in molding helmets and the other half without them. At the end, they are comparable. So is it the molding helmet that does the work or the brain? It's the brain that naturally does the shaping and the work for that. But at the end, the helmet company can say, well, look, doesn't it look so much better? That's because of our helmet. So they're gonna win every time, right? Now, that said, if you have a CP kid or someone who has brain damage or a liquefied brain, or they've had a stroke, it's not going to work. They need a cranial molding helmet because that brain isn't going to push itself out. That brain is not there. So those kids need a helmet, but I can't get helmets for those kids because the company won't do them. So that's really a catch-22. That's a kind of a difficult situation. Oops. Craniosynostosis has multiple different, sutures that can close. It's not dangerous, like I said, unless two sutures are closed at the same time. But depending on the head shape, you'll get this pointy, a boat-like shape, or you'll get one eye coming forward and the other one going back. But the child will look very dysmorphic. Trust me, you will know. You will know at 6 weeks. When they come into the room, you will be like, and then you know to refer. If not, then it's plagiocephaly. The most important thing to remember is beauty is in the eye of the beholder on this. And since it doesn't affect brain growth and development, you don't have to do surgery. It's only if you think this child is going to be the source of ridicule when they're in 1st and 2nd grade, and people are going to say, you look funny, and make fun of them. That's why we do the surgery. The surgery is huge for this. It's either 2 surgeries that's minimally invasive, or it's one surgery that's even more invasive. There's a ton of blood loss with these surgeries, so you don't go lightly into it. And if the parents say, yeah, he's got a ridge here, but otherwise he looks fine, it's okay. I mean, like I said, beauty's in the eye of the beholder, unless you think it's really not looking typical and they're going to have secondary psychosocial issues from this. I wouldn't do surgery on it. When we do surgery for it, Dr. Moores and Dr. Baker, our pediatric plastic surgeon, and Dr. Jenny Chen, they all work together to reshape and mold. You basically have to break the skull. You have to incise here. And you might wonder, why do we do a sine wave scar? Like, were we just bored? And why wouldn't you just go ear to ear? The reason you don't make the incision ear to ear when you guys see it is because later, when they're older and they get out of the pool, that hair will flop forward or flop back, and it will always be noticeable because no hair will grow in the scar. So you want to make like a sine wave incision so that the hair will sit and lay better. It's all about the hair. So, and then they overcorrect initially, which freaked me out at first because I'm like, whoa, I feel like you made them look worse. But they have to grow into it. So it's overcorrected initially. Here's a good example. Do you see how this kid's, let me use this. Do you see how this little boy's head it's so thin and it's like he's got these huge temples here and he's getting a very triangular shape? That's going to get worse and worse. It's going to turn into that his head looks like a giant boat. There's an optimal time to do this surgery, but like I said, it's very, very morbid. So their eyes always swell shut after this for several days to a week. And I mean, that's confusing for the babies. It's painful. There's like I said, blood loss. The eyes swell shut from when we make the incision, we pull the whole skull all the way down to the eyeballs. And if I'm in the surgery, it's fine. But if I'm standing over there, yeah. But kids heal, they heal. So here's, still in the hospital, but healing. Eyes are starting to open. And then here, still with the scar at home, and then here later. So that's a good series of progression of how it looks. Okay. So the last thing we're going to talk about today is tethered cord. And this confused me about midway in my career. This confused me terribly because I always thought it was a radiologic diagnosis. I would get an MRI, and if it said no tethered cord, I thought, done. We would just, send them on their way. The problem is we say the conus is supposed to end at L1, L2. Why do we say that? Because we did a large study where the majority of people who didn't have symptoms, their conus ends at L1, 2. So we said, that's it. Everybody's conus should end at L1 or L2. But everybody's made a little differently. So if you're outside that norm and you have symptoms, but your conus ends at L1 or L2, you can still have symptoms. You're just not in that bell curve of everybody else. So you have to think about why we made those rules that the conus should end at L1, L2, or T12, L1. If it's a clinical diagnosis, not a radiographic diagnosis. If the child has progressive back pain, leg pain, bowel or bladder incontinence, that's progressive. That shouldn't be ignored just because the radiograph, the MRI says no tethered cord. You honestly don't see a tethered cord on. You don't see anything pulling when you look, usually, when you look at the MRI. We see it in surgery when we open and we cut that phylum and it flies back up, but that's on a normal MRI. So let me explain what it is. When you have these symptoms, you have a kid who's, let me go to the next slide. You have a kid who's around 5. They potty train at age 2 or 3. They're doing great. They're using the bathroom. Everything's fine. Then they have a growth spurt, which is usually around age 4 or 5, right? They shoot up, and again in adolescence. When those kids start complaining of back pain, first of all, kids don't complain of back pain. We complain of back pain. Kids don't complain of back pain. They just want to run and jump and play and do what they want to do. So if you have a kid around growth spurt age who's complaining of back pain, non-specific leg pain, they're not saying I have leg pain that goes straight from here over the top of my thigh and down, like in a radicular pattern of L4. They're saying, oh, my legs hurt. And they want you to rub their legs at night, or they're complaining that their legs hurt, or they're doing weird stuff like they walk on hot asphalt or without seeming to notice, or they have sores on the bottom of their feet when you're looking at them in the car seat or something. Those would be indications that they have sensory neuro changes from their cord being tethered. And then they get progressive bladder or bowel incontinence. So I'll speak about one patient. It's actually my own son, and I didn't catch it until like super late, and I feel bad about it, but that's because the neurosurgery community is very split. 50% of neurosurgeons in this country will say radiographic, if it's not tethered on MRI, then it's not tethered. And the other 50% will say it's a clinical diagnosis. So my son has malignant hyperthermia and can't have anesthesia. So it was a really big decision. I'm like, I don't want to do surgery for tethered cord, but gee, we've got this kid who's had a recent growth spurt. He walks around all the time without shoes and doesn't think like black asphalt's hot in the summer in Virginia. And just all these non-specific things, and then started having progressive urinary incontinence. And you have to get a really good history. You have to have the parents go back and ask babysitters, mom, dad, everyone, how is this urinary incontinence or bowel incontinence progressive? Or is it just, here or there with like the family moved or they got a dog or a new baby sister was born? Is it something related to that? Or is it truly progressive and the child's losing control? Because what happens is the spinal cord is kind of covered in this connective tissue that it's kind of like saran wrap, and it coalesces at the bottom at around L1. And that piece of connective tissue goes all the way down to the sacrum. If that's pulled too tight, that piece of connective tissue is pulling on the spinal cord like a paper finger trap. Remember those paper finger traps that you could get at the fair, like a long time ago? It just keeps pulling, and this causes micro strokes in the spinal cord because the venous outflow gets built up. It's creating microvascular strokes. And as these strokes go on, the symptoms get more and more progressive. And those kids will eventually lose bladder control, they lose bowel control, and they'll have weird sensation all over. We had all over their lower extremities. We had a 73-year-old woman come to us with a tethered cord, and her tethered cord was actually radiographic, so it was very easy. She said, I just thought it was normal that I, started losing bladder control around her 12-year-old growth spurt. And, she didn't talk to anybody really about it. And she always kind of walked with a limp. And she had a tethered cord all those years. But once that, those micro strokes happen, they can't be reversed. So when you do the surgery, you can't reverse what is already damaged, but you can prevent further damage. So that's why you do want to really pay attention to the signs and do it early, because further damage you won't get back. My son personally, I still had him in Taekwondo doing all sorts of things. And the turning point for me was when he was yellow belt testing. He's still young enough that I can tell this story. He'll hate me later, but he did one of the high kicks and lost bladder and bowel control. And, they wear white suits. And that was it for me. I'm like, oh, that cord is tethered. Because think about it, anatomically, you're kicking. The spinal cord's like, whoa, I'm not able to do that. Loss of control. And that was when we made the decision to just, get the surgery done. And then when he woke up, and this has happened with several of my patients who we've done tethered cords on, wake up and they say in the PICU, they're like, oh, my back feels so much better. Even after the Marcane's worn off, I'm like, really? You were in that much pain that you now notice it when it feels better after we cut you? Because after you have back surgery, it hurts, but it clearly doesn't hurt as bad as it did pre-op. And my own son said, I can feel it. I have to pee. And I thought, oh my gosh, you couldn't feel it this whole time. And here I was shaming you, that you don't want, that you're just playing too much. Go now. He's like, I don't have to. I'm like, yeah, you do. but they can't sense that their bladder is full. And that's when they have the loss of control. Now, I mean, it always can be behavioral, but when you put all those signs together, sensory changes, back pain, leg pain, bladder and bowel, you want to think tethered cord. Yeah, that's my example there. And then here's the tethered cord surgery. When you get in there, you can see that so we open and we have to open dura. You can see that little phylum, that's the piece of connective tissue, and you isolate it, you neuromonitor test it, and we try and trick the woman who's doing the neuromonitor testing. We'll like test a bunch of nerves and see what she says, that this is firing or that's firing. And then we put it on the connective tissue and we turn it up. And she'll say, no, I'm getting no signals, no signals. And that's when we know that that's what we can cut. A lot of times when we cut that, we'll see the spinal cord like fly back up into the canal. And that's when you know it was under tension. Oh, another sign that you can see, like on this MRI, see how big this bladder is? This is a huge bladder for a 5-year-old. There's no way this bladder should be that big. And then you want to see, did the child pee right before this MRI, or were they full or whatever? This kid peed right before MRI, but couldn't, had overflow incontinence. They peed right actually in the room of the scanner, where the scanner is, and then still had this full bladder on pictures without IV fluids. That's another sign. It's always a good idea to see urology and work things up to find out. And this is what I just talked about earlier. The spinal cord's effectively suffering strokes. In our opinion, it's a very low risk procedure for a lifetime of bladder and bowel control. That tip of the spinal cord is very high on real estate. The tip of the spinal cord controls, like I said, bladder, bowel, sexual function, and your leg function. So, and protective sensation on your feet. So it's high end real estate. In our opinion, it's like a 20-minute surgery. It's a very low risk for a high yield. So that's the recap: brain tumors, skull fractures, head circumference, head shape, craniosynostosis, and tethered cord. What do you guys want to talk more about? What do you have questions about? Mm-hmm. Yeah. Yeah, so if they complain of, think about the triad. If they complain of non-specific weird leg pain and there's back pain, then send them. Leg pain, back pain, and incontinence, just send them to us. And, and they might be doing something else like toe walking or walking funny. But those things together, if it's just incontinence without anything else, without leg pain, back pain, sensory changes, and complaints of that, like they're up at night, mom and dad need to rub their legs and stuff, then it's just in your guys' department. But if you're starting to hear neuro signs as well, then, and we're always happy to take a look, but it's pretty rare. Like we do like, how many per month? Maybe like 4 a month, maybe 3 a month. And I would say 1 or 2 a year, we don't have that satisfaction of, like, we cut it and it just kind of maybe creeps up a little. It doesn't snap up. But what the children describe after surgery and the parents describe after surgery, and we're not supposed to, and we don't guarantee this, but almost 10 out of 10 times, this is what they'll come back and say. Oh my gosh, they're suddenly meeting milestones. They're suddenly like running and playing. Oh, now he's walking. Now he's, and well, for the younger ones, we'll see things on MRI. So I shouldn't use the now they're walking explanation. But the preschoolers and the elementary kids would say, I haven't had an accident now in 3 weeks, which is really unusual for that family, or I haven't had an accident in months, or they're not complaining at night anymore. And then Dr. Morris will say, that's just because they don't want to go to the hospital and be cut again. I'm like, it's not a placebo. But yeah, good question. Yeah, good question. So if the shunt is placed in childhood for a reason of something else, do you remove the shunt later if they no longer need it? And the answer to that is a surprising no, because first do no harm. If the kid's not using the shunt and they don't need it, you don't know that until you take it away. So that you can look at their brain MRI, their brain scan, and it'll say they don't have ventriculomegaly, they don't have signs of hydrocephalus, and it looks like it's fine, we don't need it. But even if it's snapped in the neck, or you know that it's broken or not working, we would not go in to do a procedure to take it out, because you can infect them, you can cause damage. I mean, surgery has to be taken very seriously without inducing more harm. So you leave it. And that's hard because some parents are like, we just want it out because we want it out. You don't need to. I mean, you will find a surgeon who's happy to take it out because, people go into surgery because they love to do surgery. But a first do no harm kind of thing, leave it in. And some kids do outgrow the shunt. We have some kids who it's snapped in the neck and there's no symptoms. The shunt's not working, but the kid's fine. Leave them alone. That's really hard to say. So on the order, how often do the shunts get clogged or get infected or need a revision or break? Around 3 to 5%. And here's the thing, it may be nothing for one family, like the shunt never has an issue ever. In fact, we just revised a 25-year-old. They're saying in the OR, this must be like a new world record. Dr. Morris put the shunt in the NICU, and this kid came back as a 25-year-old. The mom sought him out again, was like, I'm only having Dr. Morris do it. And he had symptoms. After 25 years, suddenly his shunt broke at the mechanical place and he had symptoms. So he got another CAT scan at the emergency room and his ventricles were increasing and he had symptoms. So we fixed it. But how often does that happen? 3 to 5%, but some families, 10, 12, 15 shunt revisions, 20 shunt revisions. And if you're that family, that really stinks. And that's common to happen. I have seen either nothing happen, or I've seen poor families where we have had to do 5, 6, 7 shunt revisions because of infection, breakage. I saw one kid who I checked on him post-op and said, and Graham answered the phone. I'm like, how is he doing after the shunt placement? Oh, he's doing great. He's in his Johnny jump up. You guys know the Johnny jump up where you hang it in the doorway and it's on springs and the kids jump in it. It looks so much fun, doesn't it? He's in his Johnny jump up. He's having a great time. And a week later, he was lethargic. He wasn't feeling good. And we took him we got CAT scan and the whole shunt was curled up in his head, which is unbelievable. And Morris, who hadn't talked to the family, he was looking at the scan. He's like, how on earth is this possible? I mean, unless someone is repetitively rubbing right here, how can you get that shunt from the belly all the way up into the head? And I thought, oh my gosh, Grandma talked about the Johnny jump up. That strap, when they're in it, is like a kangaroo, right? It's like a kangaroo thing, and the strap comes all the way up here, goes up across the neck. He was in the Johnny jump up, and so that was repetitively taking it all the way up and curled the whole thing up under his skull. Anyway, he had to get revised and he did fine. But it is hard. What we tell those families who have to go through 6, 7, 8, 9, 15 shunt revisions, we tell them we will get this fixed. We will get this fixed. This won't be forever. But when you're that family in the hospital and you can't leave and your kid's got an EVD, it feels like it's forever. and the parents, especially of the infants and those small children, they have to stay in the hospital the whole time with them. Because if you leave a little kid alone in there, they pull everything out. At least my kid always did. But yeah, that's why we're hesitant to put them in. Want to make sure they really need it. Anything else in the chat? And so great question. So again, first do no harm. We're very particular about, we get a whole x-ray of the skull, the neck, and the abdomen. So if we can see a breakage, then we know where our problem is and we only fix the problem. So sometimes, so say for example, it's snapped here, then we'll go in here and fix it and we won't even touch the head. We'll just put a connector on and fix the connection. That way you haven't disturbed anything here. If it's a cyst and they've got an infection here, or if there's an infection, we'll take the whole thing out. Or we draw off fluid from the EVD or externalize the shunt if it's infected. And then they're on antibiotics. And as soon as we have clean CSF on our samples every day, that's not growing out of bacteria, then we re-internalize the shunt. Yeah. Really good question. So the shunt, nobody wants them, and the parents, and now there's so many parent forums with Facebook and Google and all this, and the parents talk amongst each other. So they're afraid before they have, the family has the shunt, they're afraid, like, oh my gosh, what's all going to happen? The truth is there is no restrictions, zero restrictions. Those kids can play sports, they can play football, they can skydive, they can scuba dive. And I use those examples for the parents so that they feel more confident. They can roller coaster, skydive if your mom says it's okay, scuba dive, no problem. They can be in the military. We would have to take it out if they want to be in the military and prove that it's not working. And we have done that before, but absolutely no restrictions whatsoever. The only restriction I've ever put on is the infants that are that age. And I've told parents, and I mean, there's no data on this other than the N of 1. I say, I did have that one patient with the Johnny jump up, just, why don't you just avoid those in that one kid? Anything else in the chat? Okay, well, thanks so much, you guys. I mean, it was fun to talk about neurosurgery. Thank you.
Thank you, Peggy. That was very interesting. We are going to take a short break now. So if you guys want to grab any coffee or anything, and we'll start back up again at 11:15. Thanks.
Thank you.
All right, everyone, we'll go ahead and get started again, try to keep things on time and get everyone out since it's a Friday. Our next speaker is going to be Lucy Drayson. Lucy is a pediatric genetic counselor at Pediatric Specialists of Virginia. She counsels patients in multiple genetic clinics at PSV, including the General Genetics Clinic, Autism Genetics Clinic, and Personalized Medicine Clinic. Lucy received her master's in genetic counseling from the University of Maryland in Baltimore and joined our team here in June of 2020.
Okay. So thank you. Today I'm going to talk about what we do in our clinic. So our approach to genetic testing, counseling, and review a couple reasons for referring to genetics. So overall, what I really want you all to take away from this today is to kind of understand what we do in our clinic, what is genetic counseling, so what I do, and the importance of seeing genetics. But to be able to understand what we do in our clinic, I first have to go all the way back to the basics and actually review genetics and all of those genetic tests that are available for us. So I'm going to start first with genetics, genetic tests, and then go into our clinic. So to start off, the basic concepts in genetics. So genetics 101, I'm sure this may look familiar to some of you. I'm going to start on the left. So the left is a picture of a chromosome, and chromosomes are thread-like structures located inside the nucleus, and they're made of protein and the DNA molecule. Humans have 23 pairs in total, and the 23rd pair is sex chromosome. So genetic males have one XY, and genetic males have two X's. And then inside the chromosome, actually this is, yeah, over here, this is the DNA. In this picture, it's this, but zoomed in. So this is a picture of the DNA molecule, which is made of two linked strands that wind around each other, just like a ladder, or what we call the double. The backbone is made of phosphate, alternating sugar groups, and attached to that are the base pairs. So we have adenine, thymine, cytosine, and guanine, and then bind together with those base pairs. So the T and overall, the DNA is what carries the genetic material, the genetic information. And then on the right is a picture of gene. Gene is actually a segment of that DNA that encodes information needed for a particular trait. So physical, biological. Humans have over 20,000 genes. And a gene, like in this picture, consists of exons that are inserted here and introns. So the thing to kind of remember for this picture is that exons are going to stay within the mRNA molecule and therefore be coded into protein versus on, can get kicked out. So overall, All of our cells, we have our genetic information, we have our DNA. That's like recipes for how we walk, talk, function, do everything. And it goes from DNA to mRNA to protein to function. If there's a variation in that DNA or sort of variant in the genetic information, that can lead to symptoms or features of a genetic condition. Because DNA is located in all of our cells, that also means that we can get that source of DNA from the sources. The main source that we do in the pediatric setting would be buccal swab, which is just like a cheek swab, saliva, and blood. So now that we collected the sample, what do we do with it? There are a lot of different types of genetic tests. On the left is the list of a general list of all the different genetic tests that we have. And the first kind of distinction to make between a screening and the diagnostic test. So newborn metabolic screening, carrier screening, all of those are screenings, meaning that they're not 100%. And the purpose of screening is to not necessarily provide a diagnosis, but to, like, out of the general population, manage to select individuals who are at a high risk, but to provide a diagnosis for the testing. So screening, not 100% versus a diagnostic test. The purpose of a diagnostic test is to be able to confirm or rule out certain conditions. Out of all of the list of these genetic tests, they're all optional. The one that may be an exception is the newborn metabolic screen. So all states do require the newborn screen, but some states do allow parents to refuse. In Virginia, parents are allowed to refuse a newborn screen on based on religious beliefs. Some states actually do not allow parents to refuse, so that would be the one exception. So I'm mainly going to focus on the second category, the clinical diagnostic genetic testing. In pediatric, what is the purpose of genetic testing? So really what we're trying to do is search for a genetic variation, or what we call now a variant. So that is something to keep in mind. We now call it a variant, not a mutation. That may be related to the proband, in this case, the child's clinical concerns or clinical diagnoses. So we're really trying to answer the why question. Why does a child that's in our clinic have XYZ symptoms? So overall, to look to see if there's a genetic etiology or genetic cause or an association. The one distinction to make here is that genetic testing doesn't diagnose clinical diagnoses. So for instance, genetic testing cannot diagnose autism. What we can do is, if we see a child with a diagnosis of autism, is proceed with genetic testing to try to understand if there's a genetic reason. So answering the why question. Regardless of the results, it doesn't take away those clinical concerns, those clinical symptoms like developmental delay or autism, but it also doesn't provide additional clinical concern. It can just be a guidance to what else can be going. And then there are multiple different scales of genomic variation. So go from chromosome, which are bigger variations, all the way down to sequencing, which are really tiny. So I'm going to go through a couple different genetic tests that we offer in our clinic, from kind of top scale all the way to the bottom. So to start off, the chromosome analysis, or what we also call the karyotype. So this looks at the entire DNA in the cell, so all of the genome. And overall, it answers what is the overall genome structure in the cell? So it's kind of like a snapshot picture of all of the genetic material, like up here. So it uses stained magenta as the right here. It can be used to identify the number of chromosomes, the size of the chromosomes, the sex chromosomes, and structural differences. We use it for so like Down syndrome. And one particular thing that karyotype can do is that it can detect balanced rearrangement. So like in this picture up here. So between chromosome A and B, the information got off about. So all the information is there, it's all balanced, but it's misplaced. The karyotype can detect. Then we have FISH. So FISH looks at a specific segment of DNA in the context of the whole genome. So for FISH, The one first barrier or first limitation that we have is that you need to have a probe. You need to know what you're looking for. You can't just order fish for anything. And there are numerous probes available, but that is something you have to be able to use. You have to have a probe available. But overall, it answers the question, is the segment of DNA that we are interested in present in the cell, and where is it? So a probe is a single-stranded segment over here like this, that matches what you're looking for, and it has a fluorescent dye. And so when you bind, it will flash or fluoresce like this. These two areas are correct. Finally, the microarray. So this is a very common test that we order in a pediatric setting. Overall, kind of the basics of the microarray is comparing the patient DNA in green over here to the control DNA in red. Each tested DNA fragment represents a specific location on a specific chromosome. And so compare both DNA through this plate, you then can look at the color at that. So yellow means the patient DNA and the control DNA is balanced, but then when it's green, more patient DNA compared to control DNA. And when it's red, it's the opposite. So more control DNA compared to the patient DNA. So this can pick up imbalances like loss or gain of genetic material. So this looks at copy number variant, deletion, duplication. So look at deletion, so this or duplication. Overall answers the, is there a genomic imbalance in the genome tested? We use this really commonly in a pediatric genetic setting. It is the first tier test for children with autism, developmental delay, intellectual disability. It can detect loyalty, but also some deletion syndromes like 22q2 and it can also detect other things like regions of homozygosity. So regions of homozygosity is when both copies of the chromosome from mom and from dad are identical, the identical genetic material, or uniparental, I did not draw uniparental disomy, where both chromosomes came from the same parent. I don't know what happened, but anyway, oh, okay, sorry. Is this better? Okay. But what the microarray can't do is detect balanced rearrangements. So that's when the karyotype comes to play. So because in a balanced rearrangement, everything is balanced, it won't be picked up in the microarray. Oh, it's gonna stay there the whole time. Okay. Well, there's art. Okay, so then finally, now we're going all the way down to that scale, down to sequencing. So this is called next generation sequencing. Many different sequencing platforms. I'm not going to go into too much detail about each platform, but really what I want to focus on is that sequencing is determining the exact order of the bases, so the ATGC, in a strand of DNA. So it's kind of reading the DNA like a book. Once all of those DNA fragments are read or sequenced, the lab has to kind of match them up like a jigsaw puzzle based on overall overlapping structures. So like down here to sort of construct a bigger piece of DNA fragment, like a whole gene. So to make sure we can be able to read an entire gene, its entire sequence. So this kind of test answers is there a sequencing mistake or error in the DNA segment analyzed? This can look at variants like this, but these are only a certain examples. There are numerous others that you can find online. But on the top left here, this is an insertion variant. So over in between the T and the C nucleotides, an A got added. And so it made all these amino acids different, which then makes the protein different. Missense, the A over here got swapped to a C. And so it made that one amino acid different. Deletion in between the C and the T here, this A got removed. So kind of the opposite of an insertion. And all of these amino acids got swapped again. And then nonsense mutation or nonsense variant is the C here got swapped to a T. And so this created what we call the stop codon, which makes the protein short. So these again are just some examples. There are more out there, but this is the type of thing that sequencing can identify. There are 4 major levels of sequencing in clinical genetics. So single gene, targeted panel, whole exome, and then whole genome. As you go down that list, you increase in complexity, but you also decrease in accuracy. You're kind of stretching out that sequencing. So targeted panel looks at certain genes, like in the turquoise color. So for the purpose of today, we're going to compare them to the seeds. Exome sequencing looks at the exons. So like I mentioned earlier in the talk, those are the areas that get coded. So we're going to compare that to a slice of the watermelon. It's about 1 to 2% of the entire thing. And then genome sequencing is really looking at the whole thing. So this time it's looking at the whole watermelon. So targeted gene panels, this type of test really focuses on genes that you wish to analyze. So labs nowadays can create pretty much any panel that you want to. They create panels which fit certain indication or feature. So seizures, obesity, polycystic kidney disease, CP, panels for everything nowadays. And if you can imagine, as you increase the number of genes, you also increase the number of potential unclear, uncertain results because you're really broadening that search. Versus with a narrow focus, you're able to kind of interpret those results based on what you're seeing in the patient. Then we have whole exome. So whole exome, again, focusing on those coding regions of the genome, 1 to 2%, so the slice of the watermelon. We have about 20,000 protein coding regions. 5,000 of those genes are associated with human disease. And trio is the most efficient. So trio is when we use the proband, child, and then compare it to both parents. So have the parents included in the analysis. This is the most efficient because it helps us filter out uninformative variants, so kind of just familial variants that are not actually clinically significant, that just run in the family. And then the data is filtered by phenotype, so phenotypic features. I mentioned this to kind of explain why our notes are really long in our clinic, because we ask about every body part, because we provide this to the lab for them to have all this information so that when they screen or filter through the genetic material, they know what to look for based on what we're seeing. Now, I know it's called whole exome, but it's not whole. It doesn't look at everything. There are limitations to exome. It's not looking at introns. Those parts that got kicked out aren't in the mRNA. Regulatory regions, large missing pieces or added pieces that the microarray could pick up, trinucleotide repeats, so like Fragile X syndrome. And it doesn't always include the mitochondrial DNA. Also, as we're going from panel to exome to genome, we're also increasing in potential price and potentially increasing in turnaround time. So then we have whole genome. Now we're looking at the whole thing, analyzing the entire genetic code of approximately 3 billion nucleotides of an individual's complete DNA sequence. This time it includes coding regions and non-coding regions, so really the whole thing. However, we are decreasing in accuracy and increasing in turnaround time and potential price. And again, even though it says whole, it's not looking at the whole thing. There are things that are missed. We don't have full coverage. There are areas that we just don't have great coverage or don't know how to look at. And it doesn't look at epigenetic modifications, such as methylation. There's also difficulties interpreting some of these variations. We don't really know much about those non-coding regions yet. We don't know much about the coding regions also. And so sometimes we may not quite understand how a variation is associated to human disease. When do we order exome genome? So in 2012, the American College of Medical Genetics came out with some guidelines that genome and exome should be part of the diagnostic journey for individuals with a phenotype or a family history strongly suggesting genetics, but the phenotype isn't specific enough, meaning that there's a lot going on, it's a complex history, and we don't have a perfect targeted test to really go for. Or an individual presenting with a defined genetic diagnosis, but a genetic disorder is known to have a high degree of genetic heterogeneity, meaning that a lot of genes can cause that. And so instead of doing one gene at a time, why don't we just do the whole? Or a patient or fetus presenting with a likely genetic disorder, but previous tests have failed to find an answer. So negative panel, we didn't find anything. Now we can move forward to a bigger test. And then in 2021, the American College of Medical Genetics came out with a new guideline, or more guidelines, saying that exome and genome should be part of the first or second tier test for patients with congenital anomalies, developmental delay, or intellectual disability. So we do order exomes quite a lot. To put all of the sequencing together, so panels versus exomes versus genomes. When do we order which? How do we make that decision? So there's a lot of things that we have to consider. We consider comprehensiveness, cost, coverage, type of variance. What is it looking at? Does it offer reanalysis, the interpretation of the results, and the possible secondary findings? So the benefits of a panel is that it can be really useful for individuals with a very specific phenotype or a very specific disease that you know exactly what you're looking for and you just want to confirm or rule it out. So those are great. Usually it is lower price, and I say usually, sometimes things happen, and it is a higher accuracy. It also doesn't have additional potential findings, so we are decreasing that unclear or possibility of unclear results or uncertainty, and decreasing or taking away the possibility of secondary findings, which I will go over what those are. However, whole exome or whole genome, the benefit of that is it could be efficient instead of doing one panel after another, kind of looking at the whole thing. It could also be really beneficial for individuals with non-specific phenotypes. So again, if they just have a really complex medical history, that there's just not a specific test that we can think of to do first. It does have reanalysis opportunities. So that means that if an exome or a genome is negative today, in a couple years, we could reach out to the lab and ask them, could we look at the data again? Could we compare based on new evidence, on new genes that we finally figured out what their function is, things like that. And the panel doesn't have that opportunity. But it has that additional secondary findings that families do have to make a decision about those. So there's a lot of things that we need to consider. And then also the cost. So as you go up the ladder, usually the cost increases as well, and the turnaround time. So whole genome right now, we're looking at a 6-month turnaround time clinical, which is really long, even for us. So there are a lot of things. Again, one big limitation that I do want to emphasize is whole exome and whole genome is not looking at everything. It does have limitations. I know it says whole, but it doesn't look at everything. The 3 other common pediatric genetic testing that I've mentioned a couple times that I wanted to bring up because they are limitations of exomes and genomes. So methylation. Methylation testing is looking at the methylation pattern in the DNA. So when you attach this methyl group to a gene, it silences that gene. We use this test for imprinting conditions like with Wiedemann, Prader-Willi, Angelman, etc. Trinucleotide repeat testing. So this is looking at the number of repeats in a particular locus of interest. So this picture here, it's showing the most common trinucleotide repeat we order in pediatric setting, Fragile X testing. I'm putting this here to really emphasize, again, if you order a whole exome sequencing, or if we order a whole exome sequencing for a child with autism, we're not screening them for Fragile X syndrome. And so we may be missing something. And then on the right, the mitochondrial DNA. So this is just, again, to remind everyone that the mitochondria has its own little circular DNA over here that contains 37 mitochondrial DNA genes. All of the previous tests that I mentioned, most of them focus on the nucleus, on the nuclear DNA. And so if mitochondrial conditions are something that is on our differential, we just have to make sure that this is included, because sometimes it's not. Okay, so I talked a lot about all these different tests. What test should we order? Ultimately, it really depends on what we're looking for. To detect chromosome aneuploidies, the karyotype of that chromosome analysis, or FISH. To detect copy number variants or aneuploidy as well, we can order microarray or FISH again for some of those really common microdeletion duplication syndromes. To detect single gene disorders, we would order sequencing and del-dup. To detect mitochondrial disorder, again, the mitogenome sequencing and nuclear DNA sequencing. For imprinting disorder, that methylation testing, and for repeat disorder, the repeat testing. One approach that we do use is it's always much better, or we try our best to always order the individual who is affected first. That will be the most informative. We also ultimately want to try and order the test that will give us an answer the first time, because we don't want to keep going. So we order the test, what can come back? A lot of things can come. So a lot of possible results can come back from genetic testing. To start on the left, it can come back negative. So negative means no variation was found, no variant identified. On a microarray, everything was balanced. On an exome, everything was sequenced or spelled the right way. However, a negative doesn't mean it's not genetic, because of those limitations that we talked about of knowledge and limitations of technology. So if we ordered a microarray, do we want to move forward and order an exome next because we only looked at those structural differences? Is there something else going on that we didn't look at? In addition to that, there are some genetic conditions that have clinical criteria. So like neurofibromatosis type 1 is a common one that we see in a clinic. Some individuals have a clinical diagnosis of neurofibromatosis type 1, but because NF1 is a complicated gene, sometimes they have a negative genetic test result. And that does not mean they don't have NF1. It just means that they have NF1, but we unfortunately haven't figured out the genetic cause yet in that gene based on the limitation. I bring that up because I think it's really hard for us and of course for families to grasp that they may still have that genetic diagnosis, but all of the reports and all of the evidence we give them or all of the tests we give them says negative. That can be really hard. We could offer more testing, like I said, keep going, keep searching. Or we could keep management and treatment based on the features, based on the symptoms. A positive means that we found a likely pathogenic or pathogenic variant, whether that is an extra piece or missing piece of genetic material or sequencing difference. This provides the family and the patient with a genetic diagnosis and a genetic etiology for their particular features or symptoms. Depending on what we find, we may provide them with additional screenings, additional recommendations. It gives them a diagnosis, it gives them an answer. May want to offer familial testing? Are there any other children that we need to test in the family? Things like that. And then in the middle, we have this, our favorite, a variant of uncertain significance. So this is the tricky one. A variant of uncertain significance is when we find a variation, whether that's a deletion, duplication, or again, a sequencing difference, that we, as of 2022, as of today, don't have enough evidence, don't have enough proof to say that that variation is making the genes or the area not work properly, therefore leads to symptoms. We don't have enough evidence to say that, but we also don't have enough evidence to say that it's just variation, normal human variation, and it's completely benign. So it goes into this uncertain category. What can we do? We do our own research. We look into the area, we look into the gene. Does it fit phenotype? Could it potentially explain it? But we just don't have enough evidence to kind of push it over the edge for proof. Or is it just not at all related? We could offer familial testing again. Are other family members that are affected with this variant of uncertain significance only, and the unaffected family members don't have it? Or is it just kind of everyone has it, there's no correlation? That sometimes can help us understand a little bit how these variant of uncertain significance, their relationship with human disease. And if it's on a microarray and we're not really convinced, we could keep searching if the family is motivated to do so. We could say, okay, this doesn't fit. Let's keep going. We don't think this is the answer. Let's move forward with a different test. And then we have these two unique type of results. So unexpected. Unexpected is, it's a variant that is not associated with the medical indication for why we did the test in the first place, and it's unintentionally identified. So really emphasis on the unintentional. We weren't looking for it. Families cannot opt out. It just, we found something else that is could be medically related. So like cancer, heart conditions, but not explaining why we did the test in the first place. It could also be things that are have family implications, like parental consanguinity, mispaternity. Those exomes are trios. We are including everyone in the test. But ultimately, really the thing to remember is the unexpected or unintentional, which is different from the ACMG secondary findings. So these, like I mentioned earlier, are very unique to the exome and genomes. And these are results that are in genes that are curated by the American College of Medical Genetics. There's about 80 now on the list, and they're associated with medically actionable conditions, meaning that you can take action. So for instance, some of them are adult onset cancer. So BRCA1, BRCA2, those are on the list. And if you find a positive result, you can take action, start having more mammograms, ultrasounds, things like that. The main difference between those and the unexpected is the ACMG secondary findings. Those are intentionally looked at because families can opt in or opt out. So families sign up for whether or not they want to find this information out. So those are really important differences between those two results. But they can also have familial implications because, again, we are including parents in the trio. And so we may identify something about a child and also their mother or father. So how do we talk about all of this with our patients? So I'm going to go through a little bit how our clinic works and the steps that we take. So first, what happens during a pediatric genetic consultation? So clinical genetics is a diagnostic evaluation where we have also genetic counseling. It includes clinical medical history, family history, so a pedigree, physical exam if the physician is part of the genetic consultation. When it's just the family meeting with just a genetic counselor, there's no physical exam. Pre-test genetic counseling, where I come in, and that includes review of basics of genetics that we just went over, review of the test and its implications. We won't talk about all of them, just select the one that we would order. Review of logistics, so sample collection, insurance coverages, all of those fun things. And then post-test genetic counseling. So returning of the results, is there follow-up needed? Do they need resources, support, research, all of that? But what is genetic counseling? So genetic counseling provides information and support for individuals who have or may be at risk of a genetic condition. We do that by interpreting the family and medical history for risk assessment, so for the condition occurrence and also recurrence risks. We educate families about inheritance, testing, management, prevention, resources, research, all of that. And of course, we counsel to promote informed choices about the testing, but also adaptation to the risk of the condition. Genetic counseling is ultimately a great opportunity for patient and families to engage, to ask questions about genetics, about genetic testing, about the condition if we found something, and a great opportunity for education for them to learn about those implications about what we just all talked about. It's great to set expectations for the visit and of course for that informed consent and helping them make that decision making. But there are challenges because, well, one of the challenges is level and amount of information. How much information is needed for a family to grasp and understand genetics and the genetic testing to make that informed decision and understand its implications for their child and for themselves. Genetics is really complicated, and so we have to kind of balance how much information is needed with how much will they understand and will they remember ultimately. And there are some psychosocial goals. Maybe what the family wanted out of this visit is not what we expected, and it's not what we necessarily were planning. And then, of course, ethical considerations. We are testing children. We are looking at children's genetic material, and it does have some ethical considerations. Pre-test counseling. So ultimately, pre-test counseling is the genetic counseling part before the test is ordered, and kind of the minimum list. It should include review of genetics, review of the test, review of those possible results that I just went through, logistics, insurance, sample collection, and then any questions. But there are kind of other points to consider. So psychosocial aspects, we could explore that diagnostic odyssey so far. How long have they been searching? How old is their child? Maybe it's an older kid and they've been really searching for years and they've gone through all of the tests. They've had exomes back in, or an exome back in 2017, and they're still searching. And explore the causal attribution and meaning of the diagnosis. We in pediatrics, sometimes we do see parents blaming themselves for a lot of these symptoms and kind of understanding what they believe cause symptoms or features and what a genetic diagnosis may mean to them. This could be really important for us as we guide them through the genetic test and help them make that decision. Talking about the potential benefits and risks and limitations of the test, especially when it comes to those results. Implications for family members. Again, we are testing the child, but everyone is in the family, and we may find something that could suggest there's something else or other family members have the same genetic condition. We could also really explore that alternative to testing. Again, genetic testing is completely optional. They don't have to do this. We could manage and treat based on symptoms and not go through this exercise of genetic testing. Setting expectations, so the outcomes and the likelihoods of those results, so the possible results, but also what is the likelihood of an incidental, of an unexpected, those secondary results, and what type of results may not be returned. Exome doesn't return carrier status, but panels will, those type of differences. And family goals. Parents are not always on the same page about what they want, and that can be really hard. Preparing for possible results. At PSV, we don't do this too much, the distinction between clinical and research-based testing, but it is good to know that there are differences. So when everything is still negative and we do want to offer them other opportunities out there, there is research-based testing. There are just differences with how and when they return results. And then possible implications of sponsored genetic testing. Sponsored testing is great. It makes testing much more accessible. It means that it's at no charge for the family, the seizure panel. But there may be some implications. It may involve research. It may lead to that result being shared with databases or shared with research, and family may not be interested in that. So those ethical considerations I mentioned. Unanticipated findings, so those unexpected results like consanguinity, mispaternity, adult onset conditions, they may come back in a genetic testing for children. And this is a risk, and some families do not want to take that risk, and that's okay. Also, testing children for adult onset genetic conditions, so this second bullet point is more the intentional part. It's what we call pre-symptomatic or predictive testing. This is not recommended. The National Society of Genetic Counseling encourages waiting for predictive genetic testing in minors for these adult onset conditions until they're old enough to kind of contribute to that conversation and weigh the benefits and risks. So ultimately to preserve their autonomy and right to an open future. They also recommend to meet with someone like me. Knowing about something about your future when you are currently unaffected does have risks. One of those risks is genetic discrimination. So there is a law in the US called Genetic Information Non-Discrimination Act, and it prohibits discrimination by health insurance and employers greater than 15 employees. So 15, not every employer, based on genetic information. What is genetic information? Pretty a vague term. That includes genetic testing results, relatives' genetic testing results, information about family history, and information about research participation. So we are protected, but there are limitations and there are exceptions. Big limitation is that it does not apply to life insurance, long-term care and disability, and it does not apply to members of the US military, some veterans, individuals using the Indian Health Service, and some federal employees. This is important because we live near DC, so to remember about these exceptions. In addition to that, this is the law that we have right now. I can't promise this law doesn't change. Laws change all the time. And so this is why it's really important for us to talk to families about the implications of genetic testing, but also risks. Yeah. So we ordered the test, results came back. Now what? The post-test genetic counseling. So this is us talking about these results with families. Couple points that we need to consider: reviewing the purpose of the test because it's been a while. We don't expect families to remember everything, that all the little details we talk about, and also reviewing those possible results to kind of replace it, help them familiarize again with the test. Review the implications for family members, review the genetic condition. If it came back positive, what does it mean for them? What does it mean for their child? The inheritance pattern, recessive, dominant, etc. Testing family members, plan next steps. So do we offer more testing? Is it negative? Do we keep going? Do we offer referral? And I put this up because I do want to mention or kind of talk a little bit about the many different reactions to results. Ultimately, a negative result for one family could mean something completely different for another family. A negative is not always good news. Some families are really surprised we found something, but other families are really surprised still that negative. We still didn't find anything. And same with disappointment. Some families have been going through this for decades and just really want an answer, and we still didn't find anything. Happiness and relief. Sometimes they're really happy we didn't find anything. Other times they're very relieved we got an answer. We can give them more information. They can connect with support groups. And then of course, some genetic diagnoses are really upsetting and really sad, and those are really hard conversations to have. Genetics is really valuable. Having a confirmed genetic diagnosis can highlight potential complications, other features, comorbidities. Is there any other body part that we need to look out for? Do an ultrasound of the kidneys. It can guide diagnostic studies or surveillance strategies, so referring to the right provider, ultimately tailoring care, just making sure we have the right doctors on their team. It can provide important prognostic information and family planning information, so recurrence risks for those parents, recurrence risks for the child themselves. Guide the IEP and the school services, support groups. There are a lot of support groups. There's a lot of resources in Northern Virginia, but sometimes they're very wide based on features or symptoms. Sometimes having a very specific diagnosis can help kind of narrow down that support group. And there are Facebook groups that can be really specific to a genetic diagnosis. And that can be really valuable for information for parents to be able to connect with other families and other parents with children with the same diagnosis. Ultimately, we can end that diagnostic odyssey. So that means no more testing, psychologically beneficial for the family and patient, no more searching. I wanted to list a couple of misconceptions that do come up occasionally in our clinic. So if it's genetic, there's nothing you can do, so who cares? That's not true. There is a lot we can do. Sometimes the information can be really helpful. We can provide a lot of information about risks, and also for some, knowledge is power, and having that information can be really empowering. Unless there's a cure, treatment doesn't matter. Again, I don't agree with that. I think treatment can be really important, and there may not be a cure, but treatment and management could prolong life. It could improve the quality of life. And genetic therapy is on the rise. Ultimately, we never know what we find. We may identify something that there may be a clinical trial out there. Only reason to do genetic testing is for reproductive purposes. Yes, that is an important part of it, but it's not everything. And then genetic consultation equals genetic testing. This is, again, me emphasizing that genetic testing is completely optional. They can come see us. We can have a full visit with them. They don't have to do the testing. They can say, we're not ready yet, we'll call you later. That is completely okay. Genetic testing is a costly, lengthy fishing expedition. We've come a long way in the last couple of years. It's still relatively long to other tests, but it is much more accessible and much more affordable nowadays than it was a couple of years ago. And then genetic testing is a blood draw. Not always. Actually, most of the time, it's just a cheek swab. So something to make some families happy. So finally, when to send patients our way. I did want to mention that this is really specific to pediatric genetic clinic. I listed a couple of resources for other clinics that Inova has for under genetics. So we see kids for a lot of indications. This is a flyer from NIMAC Genetics, if anyone wants to go on that website. And, you know, the common indications that we see, so to start, neurodevelopmental or neurological, we see kids for speech delay, developmental delay, learning difficulties, intellectual disability, from movement conditions, so seizures, ataxia, spasticity, growth, so failure to thrive, short stature, or growing too much, anything that's off the growth chart, essentially. So overgrowth or hemihyperplasia, so one side is bigger than the other. Physical features for non-familial facial features or dysmorphic features. And also for physical features, so skeletal dysplasia, bone differences, multiple fractures, skin findings like cafe au lait spots, so that's part of neurofibromatosis. Anything that just looks different. Digestive and feeding issues, so that's along the same as growth, so failure to thrive again. Behavior, autism, aggressive behavior, vision, or eye differences, so vision concerns, but also eye structural differences. And then hearing loss, we see heart defects or any other congenital anomalies. We do see kids for cleft palate or polydactyly, syndactyly, club feet, things like that. And then just in general, complicated medical issues. So if there's just a lot or multiple of these, we see those kids. When do we see individuals for family history? So I wanted to show a couple examples. Family history of a carrier of a known genetic condition. So over here, Jane Doe, both of her parents are carriers of congenital adrenal hyperplasia. We could see Jane Doe to do testing for congenital adrenal hyperplasia. And then a family history of a known genetic variant. So over here, we have Jane Doe. She has a strong family history of seizures, and her brother has a known pathogenic variant in SCN1A. We could see Jane Doe and target test just that SCN1A. What I will say about this part is when you refer patients for family history of genetic conditions or family history of a known genetic variant, to make sure that as much information is provided. Because ultimately, we want to make sure we're ordering the right test. And so if we didn't know about the SCN1A variant, we just need that guidance to know exactly what we're looking for, and also to make sure that the lab is able to detect that particular variant or spelling difference. Up on the left, this is also to talk a little bit about how we need to find or determine which is the best person in the family to test first. So again, we like to test the individual who's affected first. So over here, John Doe, 17, his mother has polycystic kidney disease. Ultimately, we want to test his mother first. The reason for that is because of something called uninformative negative. So if we saw John Doe and we tested him for PKD and he came back negative, we wouldn't know if he was negative because he did not inherit what his mom has, or is he negative because what's in the family is unidentifiable by genetic testing as of today. And is he still at risk? We wouldn't be able to tell this family if we just tested John Doe first. If we tested his mom first, found a variant, then we could go ahead and test John Doe. And this is also a reminder that we do see adults. John Doe's mom could be referred to us. I did want to just list this as a resource. So the ACMG practice guideline, there is a paper with a lot of tables about a lot of other indications that you could refer to genetics. That's available. A couple referral considerations. So first, discussing the referral with the family. I think it can be really important to review the primary reason for the referral. So whether that's what you see on exam or what type of condition, or if there's a particular condition you're concerned for, that can be really helpful for the family, but also really helpful for us when we get that call to schedule them appropriately. Sometimes it can be really hard to triage patients if they don't quite know why they're being referred. But also setting expectations for their visit with us. So kind of giving them a brief overview of what our visit is like, and that genetic testing isn't always genetic consultation isn't always genetic testing. This is a big one because they may not be interested in genetic testing, but also we may not have any genetic testing to offer. They may come with a particular indication with particular features or symptoms that we just don't have a test available for them at this time, and kind of letting them know that sometimes genetic testing isn't available and that may not be necessarily included. But ultimately, reach out to us if you have questions about the reason for referral, mainly to make sure that we're putting them in the right clinic. We may have a better clinic for them. I'll list a couple afterwards, but we may be able to help by email. And for the abnormal newborn screens as well, we may be able to help by phone, and families may not have to wait a couple months to see us. Discussing the value of a genetic consultation, the implications, the benefits could be helpful for the family making that decision, or that decision to move forward with genetic referral. And again, we see adults. I listed 2 resources here. NIMAC has great resources for providers, but also for patients and families. So if patients have a lot of questions about their referral, there's a lot of good resources on that website, good flyers. And then find a genetic counselor. Of course, we're here, but if you weren't in Northern Virginia and you needed to find a different one, that website lists all the genetic counselors in the zip code that you search for. So in summary, there are many different testing, many different types of genetic tests. They all have their own set of limitations, and there's not one genetic test that can do it all. Genetic counseling is an important part of the genetic consultation. It's can provide information for the family, can help them make that informed decision. And a genetic diagnosis can have benefits and implications for patients and families. And lastly, there are a lot of indications for referrals to pediatric genetics. And then, as promised, here are some other clinics at ANOVA that will see other types of indications. So for cardiac concerns, ANOVA does have a cardiogenetics team. They have genetic counselors part of that team as well. Personal family history or personal history of cancer genetic counseling at ANOVA. Prenatal or preconception questions, so carrier status, things like that. There is the ANOVA Antenatal Center and adult onset conditions. So not anything but cancer for adult onset. So Huntington, for instance, there is an adult genetics clinic at ANOVA as well. And thank you. Sorry, I went over time. I apologize. Long. Any questions? Oh. Mm-hmm. You do the skeletal dysplasia free panel? Okay. That's a good question. How many do you see a month? Okay, so we definitely have the bandwidth to see them and talk about the testing. The reason why I'm thinking of that is because that panel is really big. And it gets a lot of the US's, those uncertain results, which are hard for us to understand. So I always, for parents, it can be even harder to grasp. So yeah, I think we could definitely see them. So we have, that was not enough time to talk about it, but part of the pediatric genetics clinic at a PSV future ANOVA. We have general genetics, but then also what we call personalized medicine, which is if a specialist has a really particular panel in mind or condition in mind, they can refer directly to a genetic counselor like me to see, and that visit is telemed and it's just panel, talking about the panel, family history, clinical, but it's just shorter and also a lot shorter wait time. Yeah. I would refer and then we could send the kid at home too. Yeah, but I'm happy to do that. I think if you have a particular test in mind, that's what we're here for. I agree. It is a free test. And I think sometimes if you send us a message with that referral, we may have something else in mind that may be a better first step. Because the skeletal dysplasia can be really specific to skeletal dysplasias. And so if it's not something that if we have something else in mind, we may suggest a different test, kind of talk to you about it and see if you are okay with it. Yeah. Mm-hmm. Oh, CP. Yeah.
We want to make sure there's not
Mm-hmm.
you bring up the discussion in charge of people. What do you feel? On your schedule?
Yeah, I think it's the same. Yeah, I think there's a lot of research in CP and genetics, and I think we're kind of discovering that there's a lot more genetic association than initially thought. I know that the CP panel is in VTAE that has a free one. Is that the one? Okay. I know they have all of the sponsored tests, you have to meet criteria. And I can't remember what their criteria is, but if a patient fits it, I think it's worth that conversation about genetic testing, and we're happy to see them talk panel. Yeah. Yeah. So again, I think, here's my email. We have Epic, for if you have, again, like a specific panel in mind, messaging me directly or emailing me could be the easier path, just so that it doesn't go through kind of the call center and that whole step, to get them on my schedule sooner, or genetic counseling scheduled sooner for a particular, that could be a way forward. So
use Epic message all. For the reanalysis. So we have been saying to families 1 to 2 years. I think 2 years is usually better. We ultimately want to make sure there's enough research to kind of build up that case. Or patients change. And so if we're seeing a patient at 2 years old and they're presenting with XYZ symptoms, but then 6 months later, they have a completely different presentation, we may want to do that reanalysis a little sooner because again, it's phenotype driven. And so if there's something really drastically different in the presentation, they may not pick it up. Yeah. So we usually say if new concerns arise or 1 to 2 years. Second time, kind of depends. Actually, recently, I will say we're getting a lot of referrals or patients on our schedule that had an exome 2017, 2018. But that's a while, so I'm hoping we can find something now. But yeah, sometimes we also move from exome to gene just to see if there's anything else. But only one lab is offering genome right now, clinically, and again, 6 months. It's a long time. So sometimes by the time I call parents out, they forget who I am. It's the whole thing. So yeah.
Children have one.
Mhm.
Okay. Let's try.
Yeah. So
Because he's fairly good. There's some.
yeah.
Right?
Yeah.
Yeah. You know, it's so, I mean, you see that parents are straight. Want to offer stuff. And how often do you think that? What we something.
Yeah, I think it really depends on family motivation.
Yeah.
We have some families that just really, they're motivated. They even say when you do genetic testing the first time, they're like, we want to participate in research. We want it all. We want to make sure. But we do actually refer to one research group at Children's quite a lot. If it's a negative exome or negative genome, we send them over there. But it kind of depends on the family motivation. I don't know how long they've been doing their study. So I haven't heard back from families with a result, but that's where it kind of the difference between research-based testing and clinical testing kind of differs. They can take a lot longer and they don't have to disclose all types of. So sometimes it can take a longer time. Yeah. Yes. So short answer is yes, it's faster to get on a genetic counselor schedule right now, but it is really dedicated for referrals that have very particular thing in mind. So currently I'm seeing patients referred by neurology for the seizure panel, or actually sometimes the CP panel, or nephrology for the PKD panel. So really specific indications. If anything is found or if any uncertainty is found and I'm not too sure, I have them schedule a follow-up with the geneticist and me to kind of review everything. Or if during clinical indication, I notice, okay, yes, they have seizures, but they also have all of these delays. If this is negative, we should probably look a little bit more broad. Then I have them follow up as well. Yeah. Yeah, so I think if it's something that really in particular in mind, it may be a bit of a trial and error. So if you have anyone in mind or any patient in mind, yeah. And so I will say the one of the limitations of genetic counseling is that it's telemed, and it's also, I don't do a physical exam. So sometimes if it's more of a physical difference, having that physical exam can be really beneficial, which I can't do. So, yeah.
Anything else? Anything on the chat? Okay, cool. Thank you. Sorry it took longer. Right.
Right. Thanks, Lucy. That's great. So we're gonna break for lunch. We're gonna be serving lunch out there to be consumed outside of the auditorium. And then we're gonna start back again at 1 p.m. with our physician speakers. So see you back then.
I have one.
Is somebody from the organizing team on?
Oh.
All right, everyone, we're going to go ahead and get started with our afternoon portion. Our next speaker is Dr. Shalini Khurana. She completed her fellowship at the University of Chicago, and since that time, she has been working in the DMV area for the past 8 years. She has a special interest in autism spectrum disorder and teaching. She participates in Children's National Echo Autism Program on the Expert Hub team, and she is the medical director of the Developmental Pediatrics Program at PSV. Oh, I think you're muted. And she is going to be presenting virtually. So to everyone on Zoom and in the audience, you can just look up at the screen.
Can you guys hear me now? Right, I'm gonna hope that's a yes. Thank you, Carisha. All right, thank you very much. Welcome back from your lunch. So it's a pleasure to be with you guys today. I'm going to talk with you about how developmental pediatrics and general pediatrics can work together. So we love seeing your patients, and we're also happy to support you in caring for them. I'm going to talk about how to refer and when to refer, and how to support your patients during that waiting period before they get to see the specialist. And we'll spend a little bit more time talking about how you can manage some of our most common diagnoses, the two most common being autism and ADHD. So developmental behavioral pediatrics and pediatrician care for children with a broad scope of referral needs. There's a lot of variability between providers. So DBPs are trained and mentored by professionals from many different medical, mental health specialties and allied fields, so that they're able to have a systems-based approach for complex developmental and behavioral problems. And developmental behavioral pediatric practice often evolves out of the community landscape and filling gaps in terms of what's needed in that care in that local area. But this also means that it can be confusing for referring providers trying to figure out who to refer to when. And so we overlap a lot with child and adolescent psychiatry, neurology, and child psychologists. But if we look at child and adolescent psychiatry, there's 10 times more psychiatrists compared to developmental behavioral pediatricians in the United States. They tend to have expertise in mental health disorders such as psychosis, suicidality, severe depression, anxiety, bipolar disorder, substance abuse, and conduct problems. And we end up often managing patients with neurodevelopmental disorders and psychiatric comorbidity, but we do also sometimes refer to our psychiatry colleagues. And we typically refer to and collaborate with neurology for specific neurological disorders such as epilepsy, cerebral palsy, or headaches. And then there's also a separate subspecialty called NDD, neurodevelopmental disabilities. And these providers have training in adult neurology, child neurology, and developmental behavioral pediatrics. But DBPs are trained to do some developmental testing and screening and some evidence-based behavioral interventions, but they frequently end up referring to psychologists for the psychoeducational or neuropsychological evaluations and also for behavioral interventions. So when you think of DBP, I'm sure that one of the first things that comes to your mind is the long wait times. And prior to the pandemic, the wait times were thought to be about 5 months on average, but at this point, they are even up to a year or more. They're estimated to be 700 developmental pediatricians in the country to see the 25% of children in the country that have behavioral, developmental, and learning problems. I want to give you an idea of what our department looks like at PSV. So we have 4 providers at this time. There's myself, 2 nurse practitioners, and a psychologist. All 4 are doing new evaluations. And this begins with a visit for history. This may be in person or by telemedicine. Based on that visit, which includes history and some examination or observation and play, conversation, the patient may be given a diagnosis if it's clear and appropriate. And if not, further visits are going to be recommended to review data such as previous testing, school evaluations, IEPs and rating scales, and possibly to complete some more testing ourselves. If there is testing, the majority of those visits are going to be done by our psychologist. Our psychologist is doing diagnostic assessments rather than kind of updated yearly monitoring for our patients. So because of the shortage in developmental pediatrics, relative to the number of patients with those needs, it's impossible for us to see them all. So developmental behavioral pediatricians become necessary when there's a greater severity or complexity, such as multiple co-occurring problems. And general pediatricians, by necessity, have to care for children with mild and moderate developmental behavioral needs. So we know that it can be tough, and we're happy to support you when you need us. We want to get care to all of the children that need them. And so if we support our primary care colleagues to the point where we're not needed, that's even okay with us. We know how important the medical home is. And developmental pediatrics actually grew out of general pediatrics, and some of our testing measures were designed to be used in primary care. So we want to help you manage those mild to moderate needs, initiate interventions while patients wait for evaluations, help access the community resources and educational resources, and also to make some of those developmental behavioral pediatric diagnoses when they really are clear. So we're going to talk about things that we will hope will be helpful for all the patients you see today, but the examples we're going to use are from our two most common diagnoses. So we'll start with ADHD. So we want you to refer your complex ADHD cases. That means the kids who are younger than 4, or greater than 12 at the time of the initial presentation of symptoms. And also those with coexisting and complicating factors. So this may mean you need clarification around those diagnoses. Could be situations where there's inadequate response to the treatments, or there are moderate to severe impairments or chronic medical conditions and genetic disorders, or complicated psychosocial factors that make the picture a little bit cloudier or make the approach not as clear. So I'm sure you're all managing some ADHD in the primary care setting. So this is a quick overview, but basically the way we diagnose ADHD is the same way you do in your office. We are going to be using rating scales such as the Vanderbilt scales or the ADHD rating scales for preschool age kids. And we like to have multiple settings represented. So usually it's home and school. We make sure that we are not missing contributing problems, which can also often mimic ADHD. These can also include sleep problems, issues with discipline versus expectations and whether they're appropriate or not, psychosocial changes, oppositional defiant disorder, conduct disorder, mood and anxiety, and learning problems. Now, keep in mind that if a patient has no history of ADHD symptoms during childhood, but develops inattentiveness and poor concentration only after the onset of depression or mania, then it's the affective disorder that is most likely primary. And patients who have adolescent onset oppositional defiant disorder or conduct disorder are often described as impulsive or inattentive even earlier on, but they don't necessarily meet the full criteria for ADHD, or they had few ADHD symptoms in childhood. And when thinking about mood, keep in mind that patients can have dysphoria or low self-esteem. This can be secondary to the frustration of living with ADHD. So in these situations, the dysphoria is related specifically to those ADHD symptoms, and there's an absence of that pervasive depression with neurovegetative signs or suicidal ideation. Now, diagnosing preschoolers can be trickier, and we'll talk about this a little bit more with our next slide. So when we are making the diagnosis and treatment plan, we also want to assess the impact at home, at school, and in community settings, including whether there is risk to safety. We then also design the treatment plan based on the age and the impact and needs. So to do that, we utilize evidence-based parent behavior management and medications. We also try to get school evaluations for IEP and 504 plans that can be made for the ADHD itself or for any related learning, social, and behavioral needs. Sometimes we end up referring to other related therapies such as social skills, occupational therapy, and speech therapy. So medications are part of ADHD management, and they are effective. So keep in mind that with the preschoolers that they may need lower doses of stimulants, and we will often do very careful titration with small changes. If a patient on medication has been symptom-free for at least a year, then you should inquire with the patient and the family whether they think it's really beneficial. And signs that it may not be needed include not having to adjust the dose despite growth, or not having difficulty with symptoms if medication doses are missed, or when there are drug holidays. Low stress times, such as vacations, are good times to do the trials off of medication, but parents should assign some cognitively demanding tasks like reading or some math problems or something just to really test it out. So the complex ADHD is the kids who are younger than 4 age of diagnosis, but that preschool age is still pretty tricky, I think. Again, we are going to apply the DSM-5 criteria. We use age-appropriate rating scales, and we assess behavior and impairments in multiple settings, sometimes even using videos if needed. Parent behavior training and the school-based behavioral intervention. This is actually really first line for treatment of ADHD in this age group, and it can be used with or without a diagnosis of ADHD. And we do encourage using it before the diagnosis is made. It can be helpful in understanding the nature of the symptoms and in terms of how they respond to the behavior training. They generally include positive reinforcement, ignoring low-level provocation, and providing clear, consistent, and constructive consequences for undesired behavior. There are a number of evidence-based programs, and many are available online, and we'll provide you with some of the names of these. One of the common ones we like to use is parent-child interaction therapy, or PCIT, which is evidence-based for kids aged 2 to 7 years. It's for situations where you have emotional and behavioral disorders, and it places emphasis on improving the quality of the parent-child interaction and changing that parent-child interaction pattern. When it comes to the medications, we often need them because parent behavior management training isn't sufficient in 80% of the time. So I think about medications when there's a safety concern and when the child has trouble engaging in or benefiting from these interventions because of their ADHD symptoms. You should consider it when they have moderate to severe dysfunction. And the severity criteria are having symptoms that have persisted for at least 9 months, having dysfunction in multiple settings, like school and childcare and home, and also the dysfunction that hasn't responded to the parent training. Now, amphetamine preparations are the ones that are approved by the FDA for this 3 to 5 year age range, but this approval reflects laxity of the approval criteria at the time it was pursued. So methylphenidate is actually the medication that has evidence for preschool use and tends to have fewer side effects. Immediate release preparation dosing is recommended for the smaller children. We also use immediate release alpha-2 agonists, such as clonidine and guanfacine. These can be helpful when there is severe irritability and oppositionality going along with the ADHD symptoms. We would be very ginger in our dosing and titration. Sometimes we're cutting these pills into quarters, which can be difficult for parents because they're small and crumbly. But we are really trying to avoid having any precipitous hypotension. These medications can also be compounded. So when we evaluate the children with complex ADHD, we are thinking about when to treat the coexisting condition versus the ADHD. Also, the pharmacological versus non-pharmacological treatment options. And ultimately, we want to get to the point where we are doing maintenance monitoring. That includes visits every 3 to 4 months with inquiry about symptoms, also rating scales for parents and teachers, and then annual screening for comorbidities and substance use and high-risk behavior screening as well. In our practice, once our patients are on stable doses, we are often sending them back to their medical home for monitoring and periodic dose adjustments. But as I mentioned before, we are still available for consultation. And so we can definitely help out when questions arise. There is also a VMAP consultation service that you guys are going to hear about from Julia Richardson later on today. And they have a few different programs that can be helpful. So beyond ADHD, you're going to come across questions about patients' development and behavior that you would like help with. Now, these could be questions about the diagnoses, such as whether they have one of these or not. Also, whether there are any subtle developmental differences that you need to monitor and how to monitor, how to manage complicated patients with comorbidities, and whether a different approach intervention is needed, particularly if they have failed some of the interventions that you've tried already. So no matter what the question, our collective goal is to get our patients support that they need to be successful as soon as possible. So we want to move them towards the diagnoses and supports they need as efficiently as possible. So when they come to our clinic, we are focusing on the intervention, right? The services that they need to increase their skills, and also getting them an accurate diagnosis to help them access those services and to inform our understanding of their learning needs and help them get a positive concept of themselves. And sometimes you may be waiting for more than 6 months for an initial visit with a specialist, and even longer to get to the point of having the diagnosis determined. So intervention should start before they see a specialist. And it can. This can be through the county and also through the insurance. We lean towards more intensive services earlier on. We really want to capitalize on the neuroplasticity in the early ages, but we want to do as much as the child and the family can manage. And then importantly, as always, we want to make sure that we are providing caregiver support for the families. We also can get ABA therapy for children who don't have autism diagnoses if they have Virginia Medicaid. And then when there are situations where the autism is clear, they're meeting the diagnostic criteria, but you're not comfortable because you haven't had practice maybe making that diagnosis, we're able to support you on that as well. We'll talk a little bit more about how we can do that at the end of the talk. And when you have them go for these interventions, the evaluations they get are going to be helpful in a number of ways. It's going to inform the interventions and goals. It also is going to help the parents in understanding their children better. And sometimes we have parents who aren't really at a place where they're ready to accept diagnoses or their child's differences. So hearing and seeing what these specialists and the interventionists are seeing can be helpful in moving them towards acceptance. They also actually can be helpful to us as specialists when we get to the point where we're seeing the child, because we have some of their interventions and we can see the response to intervention. We can see also how they've done on standardized testing measures. These are some of the parent groups that we'll refer to often. This is the Parent Training Information Center for Virginia. There are also parent-to-parent networks where parents mentor each other. There are condition-specific support and advocacy groups, and then there's also parent navigation available in some settings. So the county-based services include early intervention and child find. Both of them are going to have multidisciplinary evaluations, and they're going to give you developmental levels in all the developmental domains. Child Find will test the pre-academic skills and look at social emotional functioning and behavior. And you will get a plan out of that, right? So early intervention will create an IFSP, an individualized family services plan, and the schools were going to create an IEP. And that IEP is going to be coded under something, which is kind of the school's way of making a diagnosis, or their own, they may not call it a diagnosis, however. For when you're requesting an IEP to be created or an evaluation to be done in the school system, we recommend that there is a written letter that is signed and dated that it gets sent to the school, because that sets up the timeline where they have 60 days to complete the process. I want to talk about some of the common private interventions we recommend as well. So we will recommend speech language therapy. They can work on the core language, the receptive and expressive language, also the pragmatic and social language, or the higher order language, which looks at organization, inferencing, flexibility, and problem solving using language. We will refer to speech pathologists for AAC evaluations as well. Sometimes kids are getting them through school, but it's helpful to have an outside evaluation at times, because parents may not always feel like the device they get from the school is meeting their child's needs. And then also with the private evaluation, they can get a device for home through their insurance. We do send people to speech pathologists for feeding, particularly when we have concerns about the oral motor skills. Feeding can also be addressed by occupational therapy. That's particularly helpful when we think there's a sensory part of it. And then ABA therapy can also work on this, especially if it seems like it's much more of a behavioral rigidity. Occupational therapy will also work on the fine and gross motor coordination, the sensory processing overall, and sensory regulatory skills. So they have a curricula that can help kids who are at a language level of 4 and up with understanding their arousal levels and managing their own responses, their emotional behavioral responses. In terms of behavioral interventions, the one we recommend most often, particularly in autism, is ABA therapy, but it's not the only situation where ABA therapy can be effective. The intensive ABA therapy is considered to be 25+ hours per week. They can work on challenging behaviors, things like requesting, foundational social communication skills, play, flexibility, the self-care skills, including toileting and feeding, and safety behavior. If you have children who have trouble crossing the road safely, or parents are really nervous about maintaining their safety, this is a really good reason to get ABA therapy. We talked a little bit about the parent behavior trainings already. So they're not typically autism specific. And then the parent-child interaction therapy we also mentioned briefly. This has a modification for autism. And it is evidence-based as well. So, and if you don't have an autism diagnosis, you can do ABA therapy. If they have Virginia Medicaid, they also can do these parent behavior trainings and the PCIT. So I want to talk about the screening that you can do for autism. But before getting into our cases, I want to share with you a system for thinking about how to triage these diagnostic questions. So this is our green, yellow, red system. And first we have, we're going to do a green case basically. So our green cases are these waiting room diagnoses. That's what people would call them at times, right? They're these unambiguous autism traits that are visible and consistent with autism spectrum, and your history is clearly meeting all the autism criteria. So in these situations, a primary care provider can diagnose it, ideally with some kind of structured instrument, and then also refer for a full assessment. Then after that, you get the yellow cases. These are less pronounced autism traits, and they have a more complex differential. In these situations, the primary care provider should express the concerns for possible autism, but also refer for those interventions and the full assessment. Then you've got the red cases where it's really very complicated history and differential, and these should just go directly to a group that's going to do a full autism assessment. It's our first case. So the first one is Riley. He is a 24-month-old who comes for his well child check, and his parent completes the MCHAT RF, which is the most current version of the MCHAT, and includes follow-up questions, and actually is a little shorter and easier to complete than the previous versions. This places him in the high risk range for autism. So you decide to get more information to help understand Riley's risk for autism and to better guide the family. And in doing that, you're thinking about those red flags for autism that you've learned about. So you ask if he's pointing and when he started, and they say yes, sometimes. And he started at 18 months. How does he usually let them know what he wants? He takes their hands, leads them, puts the hands on what he wants. We call that using someone's hand as a tool. And when you ask if he's sharing interests, he's not going to share interests. And with regards to this core language, he's not using any words spontaneously and meaningfully, not using any flexible and spontaneous two-word phrases. And he is not at any language regression. So overall, these do support the concerns for autism highlighted by that MCHAT. There are language delays. There sounds like there's inconsistent or infrequent use of his gestures and no initiation of joint attention. So then you ask questions to determine how the needs are really affecting the child and the family day to day. What's most important to the family at home? So they say that it's meltdowns. They're having them several times a day. They can't always understand the reason for the meltdown. They're lasting 20 minutes or more and include head banging. And when you ask what they want help with, they say getting him to speak and addressing the tantrums. So when we look at these meltdowns, they seem a little different than our typical 2-year-old tantrum. They're such high frequency, intensity, duration, and unclear triggers makes you think about inflexibility behind them, a higher level of inflexibility, and then also that self-injury. So finding out then what the caregiver concerns and priorities are afterward actually helps you to make the diagnostic process and intervention meaningful to them. So now you've shared the results of the MCHAT and the concerns, discuss the targets that you have for the interventions. So you think about how to pursue that diagnostic evaluation. When evaluating a child with autism, it's important, or sorry, for autism, it's important to consider the development in terms of cognitive domain, language, adaptive, motor, sensory processing, and also hearing and vision. And you want to do this with a qualified autism diagnostician, and you want to make sure to also rule out hearing loss. So the next steps for this guy are that you refer to early intervention, which is going to include the audiology assessment, and then the private speech therapy in addition. And if you can, because depending on the insurance, for ABA therapy, and they can work on the self-injurious behavior, the communication, and the play skills. Also to one of those family support organizations and to the autism diagnostician. And of course, that autism diagnostic evaluation has a long wait time. So while you wait, you can use level 2 screening and testing for autism. On the bottom of the screen, there's a picture of the kit we use for the STAT, the screening tool for autism in toddlers. This is a level 2 test. It takes about 20-ish minutes to do. There is an online training, has some costs associated with it. It's very helpful, it's easy. It's fun, actually, too. You get to do something different, I think, when you get to play with the kids. And then on the top right side of the screen, you can see the CSBS, the Communication Symbolic Behavior Scale. This is available free. This version is free online for 6 to 24-month-olds. And this can just help to highlight when there are early communication, social communication differences. You want to also make sure you're assessing for comorbidities and then monitoring for the child's safety. We know that kids with disabilities are at increased risk for abuse. And then we also know that children with autism have a higher risk of a number of other medical and psychosocial comorbidities and vulnerabilities. So you plan to bring them back in 4 to 6 weeks. At that time, you want to see how they've done with the recommendations you've made already, but then you want to assess and treat any of the underlying medical issues and comorbidities. Very commonly, we see problems with sleep, eating, and constipation. So getting back to our red, yellow, and green schema, Riley's is a situation where the primary care provider could ideally diagnose with a structured instrument and refer for that comprehensive assessment. Receiving the diagnosis in the medical home actually will help move the family forward and allow them to access the services and interventions that they need. All right, so our second case is an 8-year-old girl. She has a previous diagnosis of ADHD combined type, currently being treated with a stimulant. And the parents actually come to you and say that they have concerns because she's having problems with her peers in school. So she becomes upset because she says that children are mean to her when she doesn't get her way. She locks herself in the bathroom and talk about how bad she was. Lunch, recess, and gym are the hardest parts of the day for her. She needed to actually be removed from her classroom so that she could learn one-on-one rather than in the small groups. At home, she actually has some disruptive behavior as well. She's aggressive, destructive, and she's eloped. She actually does this when she's upset because things have not gone as she's expected. So when you ask more, you find out they really didn't have a lot of concerns about her prior to this. There was some mild speech delay early on. And then they noticed some sensory processing issues and having a lot of meltdowns, but she did OT at 4 to 5 years of age and seemed to do better after that. So if we compare this case with our last one, it's different in that the parents here are the ones initiating this assessment because of their concerns, and also because Madison is older. She's got strong core language and cognitive abilities. Just like with our last case, you ask parents more questions to try to get a better sense of what the challenges and strengths are and the needs are. So you find out that currently in school, she's in the 3rd grade and she has an IEP. The goals include de-escalation, asking for a break when she needs it, and requesting help. The services they've given her include social skills groups. They mention meltdowns in school. The triggers they say are social problems and transitions. These are problematic just since she returned after being in school virtually. Her academic performance is actually good, average to above average. So hearing about the social skills and transitions issues have made you think about autism. And when you ask a little bit more about her social development, you find out that she's always had problems interpreting social cues. Children have told her she's mean and immature. You find out she was recently at a birthday party, a skating party. The kids are skating faster than she was, and she actually interpreted it as them doing so because they didn't like her. She was sad and withdrawn, and she started screaming and crying and had to leave the party. She, though, has good nonverbal communication skills when she is trying to convey something. She's generally good at initiating social interactions with others when she wants to, but not as good as responding. And her mother actually recalls that she used to have to use a different tone of voice to get her to respond to her name, and also would have to place objects right in front of her face just to get her attention. Sensory-wise, she always has a need for some contact with other people. So she's touching her parents or her peers, which can be more problematic with her peers. We talked about how she gets frustrated when things aren't going her way. And with play, she has some creativity in her play, but she's pretty rigid about how it's done and isn't flexible if someone wants to do something slightly different. She has a very strong interest in drawing and dragons, and a lot of it comes from the movie How to Train Your Dragon. When you ask the parents about what they need, they say they'd like help with social skills and addressing meltdowns at home and behavior at school. So in a situation like this, where you've got an older child who has good language skills, it's nice to ask questions of the child, right? So these are questions that you can use to evaluate understanding of emotion and relationships. And you can use these in any child. And I would recommend doing this with kids that you're not concerned about as well, so that you get a sense of kind of the range of what's typical and what's not. So when you ask these questions, first you get these open-ended, rambling, disorganized, and just unclear responses, which is surprising given that core language and cognitive level. And her conversation kept coming back to dragons, right? So you asked her about what makes her happy, what makes her sad, how she gets along with other people at school and at home, and her part in those interactions. And I ask about friendships and what friendships mean, and loneliness. So in answering the questions, it became clear that her difficulties with peers affected her a lot. Her inflexibility was a part of these problems, and that she had difficulty seeing her effect on another person and then understanding their emotions. So at this age, typically we expect children to understand that back and forth quid pro quo of friendships, even if they have difficulty seeing another person's point of view at the same time as their own. Typically, they'll judge themselves just as much as they judge their friends. But Madison, on the other hand, has difficulty seeing another person's point of view, describing feelings and describing friendships and her role in it. There is a reference from the Psychology Today website that I'm going to provide you guys at the end that talks about understanding friendships at different ages and stages in childhood. So thinking back to what you've learned about screening, you remember that you can do a level 2 screener. So you pick the social communication questionnaire. So this can be done in the office. It takes just a few minutes to complete and score. There are about 40 questions, so it's not very long, and they just have to circle yes and no. This is a lifetime version, so it talks about the child's development from birth to the 4 to 5 range. And this is helpful in establishing a diagnosis. There's another version that can be used for tracking called the current version. Her score is elevated, which meant elevated risk for autism. So thinking about our green, yellow, and red system, I'm not sure where you would say that Madison falls. I think she falls in that yellow range. So the provider expresses the concerns of parents, thinks about interventions and referral options. So again, we want a multifaceted diagnostic assessment from a qualified autism diagnostician that looks at the various domains of development and also keeps in mind hearing and vision and sensory processing. Now, for her, it's a little different than the younger child. You refer to the IEP team for testing and then also for comprehensive psychological testing privately. In the meantime, she needs some help. So there are interventions that you can refer to. You can refer to social skills groups. And then there are also executive function trainings. The one we like to use for this age group is called Unstuck and On Target. There's actually an electronic online program that parents can use as well. And the Unstuck and On Target curriculum can be integrated into other therapies or into the IEP as well. And then there's the parent support organizations. And while waiting for that diagnostic evaluation, you bring them back in 4 to 6 weeks to follow up on those comorbidities we talked about before, and always monitoring safety and inquiring about progress with the school and the private evaluations you'd recommended. And then thinking about the language issues you noticed when she was answering those open-ended questions, you also refer her for speech and language evaluation that's going to focus on the higher order language. So I wanted to show you what we can do to help support you. You can always call us, but we also have our own Echo Autism program that Neha had mentioned in the beginning, and this is through Children's National. The goal is to improve autism knowledge for the primary care setting and to help our primary care providers learn how to diagnose and manage autism. So you get telementoring, and the expert hub team that's multidisciplinary. You get to learn from your colleagues, you get free CME credit, and it occurs for 1 hour twice a month. Our primary care ones are finished for now, but if you have any interest, I would still contact Chelsea Armour, who is coordinating for us. And if we have more primary care ones we're able to set up, we will let you know. These are the resources, some of the resources. So we have some information here about the rating scales that we use for ADHD, a little bit of basic information about behavior management training. This is the parent-child interaction therapy information. And then we are going to, I think, give you a link to a list of some community resources that you can provide to people who are waiting for evaluations. It includes the county-based services, some education materials, information on educational advocacy and support, those parent groups we talked about. There are algorithms and guidelines for ADHD and autism in the references. There's an article about friendships. Then also there's the Virginia Mental Health Access Program, that local program we mentioned that provides patient-specific consultation and case management, but also provides education for providers, including their own ECHO program. They have a guidebook, which is nice. And so I'm just kind of gave you that information there, and I'm sure you'll get more information on that at the end of the day. And our ECHO Autism isn't the only one. There are a number of them around the country. So they have different schedules. I think it's worth looking and seeing if there are any other ones that kind of strike your interest and work for you if you're interested. These are our references. It's my contact information if you have questions. I see that there is a question in the chat. The social communication questionnaire. So unfortunately, there is no good level 2 screener that is cost free. You know, you have your level 1 screeners like the MChat that are available online. The other one, the social communication questionnaire, there is a cost for, but I actually don't know what it is off the top of my head because I haven't been the one ordering them, but I can certainly, if you email me, I can give you the information about the website where you can look into the pricing and ordering. Right. Are there any other questions anybody has for me? Okay. Well, my contact information is here, and our department contact information is here as well. So please reach out to us and let me know if you need anything else. Thank you so much for having me.
Thank you so much, Dr. Corona.
Sure, thank you.
All right. So our next speaker is going to be Dr. Emily Way, who's a pediatric rheumatologist. Dr. Way is from a small town in upstate New York. She completed her undergrad at Penn State University and her medical degree from Penn State College of Medicine. She completed her residency in pediatrics at the Medical University of South Carolina, followed by fellowship in pediatric rheumatology at the Children's Hospital of Pittsburgh of UPMC. She has worked here at PSV for the last 7 years.
Just to pull up my screen. Is that okay? Good. Okay. All right. Hi guys. How are you? I don't know if I've met a lot of you. Let's just take the mask off. But yeah, so I'm one of the pediatric rheumatologists. There's like 2.5 of us at PSV. Once we shift over to Inova, there will be 2 of us, Dr. Abshaki and I. But I thought I'd just kind of talk about one of the most basic principles of pediatric rheumatology, which is mostly sort of how to evaluate a child with musculoskeletal pain, although of course, since I'm a rheumatologist, there's a little bit of a rheumatologic spin on it, but this is some good basic stuff that we deal with on a very regular basis. So here's some objectives. I usually frame this talk in a way that sort of tries to drive home the fact that when you see a child who has musculoskeletal pain, you don't actually always have to make a diagnosis. Sometimes it just helps to sort of have a direction to go. And you can accomplish a whole heck of a lot just with that. So I like to put it into sort of categories. So I'll talk to you about the categories. I also sort of like to drive home how you can figure out what category to put them in based on the history alone, a large majority of the time. And the categories that I'll talk to you about that I sort of tend to use on a very regular basis are either inflammatory, mechanical, or amplified. And so another objective would be to just sort of rule in or rule out joint pain due to arthritis, identify and treat children with joint pain due to hypermobility, and then be able to identify and treat children who have joint pain due to amplified pain, which is sort of the kid version of fibromyalgia. I wanted to start by making the point that, again, sort of putting a rheumatologic spin on things, the joint pain and musculoskeletal pain is by far the number one chief complaint that we get in rheumatology. But a teeny tiny percentage of those referrals end up actually having arthritis. And so there is a good amount of information and data out there that pain is actually not a very good predictor of arthritis. There is even a little bit of data that's a negative predictor of arthritis, although that's not that helpful. I thought that this was a kind of a nice study where basically it was just a retrospective chart review. It wasn't anything super complex, but it was a retrospective chart review that went on for a few years in Oakland at their children's hospital, where basically they just went back and reviewed some charts, and they were reviewed for the chief complaint. They looked at 414 charts. And basically they looked at these chief complaints here in table 2. So it's musculoskeletal pain, which was the number one chief complaint for their new referrals in rheumatology. This is the rheumatology clinic. Abnormal lab tests, joint swelling, fever, abnormal gait, rash, fatigue, morning stiffness, or other. So of the 226 children over these 3 years that they were looking at these charts who presented to the rheumatology clinic for the chief complaint with musculoskeletal pain, about half of them, 111. About half of those kids who presented with musculoskeletal pain only had musculoskeletal pain and no other symptoms or complaints. The other half of them did have additional complaints in addition to their musculoskeletal pain. So things like joint swelling, abnormal gait, fever, morning stiffness, fatigue, or abnormal lab tests. Of the ones that only had pain and did not have any accompanying symptoms, no other symptoms, only one of them ended up having a rheumatologic disease. So that was less than 1%, which ended up being a spondyloarthropathy. And then sort of looking at it from the end result. So of the children that they were looking at the charts of who did end up having juvenile arthritis, only 12 of those, which was 16%, even included pain as part of their chief complaints. 84% did not include pain at all in their complaint.
Bring some slide.
Oh, sure.
Okay.
Okay. Sorry, guys, on Zoom. I'm not all that technologically inclined. Anyway, so point being, 84% did not include pain at all in their chief complaint as the reason to come to rheumatology after they got diagnosed with arthritis. So in this particular instance, the musculoskeletal pain with or without other symptoms actually had a negative predictive value for arthritis. So anyway, so I just like to make that point that most of the time, if the only problem they have is pain, it actually is typically not going to be arthritis. But anyway, so like I said in the introduction and when I was talking about the objectives, these are the 3 categories that I use, I sort of need in my brain when I evaluate a child with musculoskeletal pain in order to figure out what direction to go in. Again, a lot of times I don't actually have a diagnosis for them, but at least I have a place to sort of put them in a direction to go in. And that helps much more than you might think. So the three categories that I like to use are either inflammatory, which basically means arthritis, mechanical, which is an enormous category that could have any number of things in it, such as hypermobility, some sort of injury, overuse, even like apophysitis, I would probably put in that category. It's like Osgood-Schlatter. And then amplified. So amplified pain is this sort of kid version of fibromyalgia that also has many other names, unfortunately. And depending on who you ask, a lot of people would tell you that the names are the same. Some people might tell you they're very different, but in rheumatology, we tend to sort of think about amplified pain. So the diagnosis of amplified musculoskeletal pain syndrome, or AMPS, is sort of another category in and of itself. And then within that category, you have fibromyalgia, you have reflex sympathetic dystrophy, complex regional pain syndrome, and everybody thinks about those words differently. And it's kind of annoying with the nomenclature, but they're all a very similar sort of concept. So first, we're going to talk about inflammatory musculoskeletal pain, because that is where I have the most expertise. So inflammatory musculoskeletal pain, again, basically meaning arthritis. So if you take nothing else away from this talk, and this is what we always do for like residents who come rotate with us and anybody else, just sort of remembering the characteristics of the pain in each category will help you on a regular basis. So the typical characteristics of kids who have arthritis is that the pain is worst when they wake up in the morning. A lot of times it's not terrible pain. Sometimes it can be, but most of the time it's just this sort of annoying, aching, sort of not terrible sort of pain. One other key is that it tends to improve through the day, and it improves with activity. So it's worse when they wake up, and then after, an hour or several hours, the pain starts to get better. And as the day progresses, they tend to feel better and better. And the more they move around, and the earlier in the day they move around, the better they feel. Another probably sort of just actually the hallmark feature of arthritis is stiffness. So a lot of times when you evaluate a child with pain, if they tell you about stiffness, that is oftentimes the more prominent symptom when they have arthritis. So the stiffness is typically also in the morning, and it's prolonged. So sometimes when I'm getting a history and I ask about stiffness, they'll say yes, and I say, how long does it last? And they basically say, until I crack my joints, then it goes away. So it's like a minute or two. That's not arthritis. Arthritis is prolonged morning stiffness. So usually at least 20 to 30 minutes, but oftentimes several hours, an hour, several hours up until lunchtime. And then swelling. So these are the hallmark features of arthritis. And again, the swelling is persistent. It does not usually come and go. It might have like good days and bad days. Like sometimes it's better than others, but it is there all the time. So again, sometimes when I'm getting a history and I ask about swelling, they'll say yes. But then if I ask, how long does it last for? How often do you see it? They'll say like once or twice a month, and it lasts a couple hours. And that's not arthritis. Arthritis, typically the joints are just always swollen until you diagnose and treat it. And then, of course, you do a physical exam. So you're looking for swelling and effusions. Limited range of motion is a big, huge one that sometimes gets missed a little bit. But limited range of motion and swelling are probably the biggest features that we look for on exam. But when we talk about inflammatory joint pain, like I said, we're talking about arthritis for the most part. But it's helpful to remember that not all arthritis is from juvenile idiopathic arthritis. So the term JIA, again, that stands for juvenile idiopathic arthritis. We actually used to call it juvenile rheumatoid arthritis, or JRA, but we changed the name many years ago now, probably about 15 years ago, because we didn't want people to think that it was the same thing as rheumatoid arthritis. Even though the concept is the same, it's an autoimmune inflammatory arthritis, it does act a lot differently in children than it does in adults. So we changed the name, now it's JIA, but not everybody who has arthritis has JIA. So the differential is fairly broad. So you can have sort of periviral arthritis, meaning you have arthritis during a virus, like parvovirus would be a really common one to do that. You can have reactive arthritis, which typically means you get arthritis after you have a virus or bacteria, because that can happen after strep. It can happen during or after sexually transmitted diseases, GI infections. So reactive arthritis is common, even septic arthritis, of course, although that often looks much different. And then infectious arthritis like Lyme disease, that means that you actually have bacteria in your knee that's not, typically thought of as a septic arthritis. You can have arthritis from other autoimmune diseases that are not JIA, like lupus or vasculitis. And then malignancy. So unfortunately, I've had to be the one to diagnose cancer a couple of different times in my career because it actually presented with arthritis. And then the funny thing about diagnosing somebody with JIA is that it's actually not very complicated. So there is no blood test that you need to diagnose somebody with JIA. There is no biopsy results or imaging tests. It really just requires that you prove a child has arthritis under the age of 16. And a majority of the time we can do that in clinic just by a history and physical exam. Sometimes you need imaging, but a lot of times we can just do it with a history and physical exam. So once you have proven they have arthritis, whether you've done that with a history and physical exam or you've done it with like an MRI, if it's been there, if they've had symptoms for longer than 6 weeks and they have no other explanation such as cancer or Lyme disease, then they have JIA, and that's it. It's actually very simple. If we go back to that study that I referenced at the beginning, of the patients that were diagnosed with JIA, 3/4 of them reported joint swelling as part of their chief complaint. And of the majority that were not diagnosed with JIA, which was 338 patients, only 15% reported joint swelling as part of the chief complaint. So that's just sort of drives home the message that at least persistent joint swelling has a much stronger correlation with diagnosing arthritis than pain does. Okay, so in the realm of arthritis, so once I have gone through a history and done a physical exam and decided this really sounds like arthritis, I think this patient has arthritis. This is in the inflammatory category of joint pain. Then of course the next thing that we do is if you haven't already, look for the arthritis on exam and try to define it and prove it. We talked about how to do that to some extent. And then you have to do the part where you exclude the other possibilities. So blood testing for Lyme disease, if that makes sense. It doesn't always make sense. So if they have arthritis all through, tons of joints in their body and all the little joints in their fingers, that's not Lyme disease. But if you have like 1 or 2 larger joints like knee, then it does make sense to do Lyme testing. And again, infection, cancer. So we usually do blood testing when we're worried about arthritis, but it's not because we're going to find the diagnosis of JIA in the blood testing. It's really more to exclude other diagnoses like Lyme disease, to, just sort of characterize their inflammation, see how elevated their inflammatory markers are. We do some serologies like rheumatoid factors and CCPs and some other things, although those are not how we diagnose it. They're actually not helpful to diagnose it for the most part. And I'll talk to you a little bit about that, a little bit more about that in a minute. And then again, we just figure out how long it's been there. So once I've decided somebody has arthritis, we figure out how long it's been there, either by, symptoms or whenever, if somebody comes in with an MRI and it was done 2 months ago. If it's been there for longer than 6 weeks and we've excluded other causes, then we've diagnosed JIA. If it has not been 6 weeks yet, occasionally we diagnose somebody with arthritis, and let's say their symptoms have only been there for like 2 weeks, then we're still in the realm of this could be reactive arthritis, this could be some other things. So we either, do our workup to make sure it's not Lyme or whatever else, or we just kind of wait if we can. So if somebody is just, miserable and non-ambulatory, sometimes we'll do something like steroid or, scheduled NSAIDs or even a steroid injection. But technically we don't make the diagnosis until they've been longer than 6 weeks. And the reason that 6-week cutoff is there is because honestly, when somebody has arthritis, if it's only been there for a week or two, there is literally, for the most part, no way to know whether it's reactive or whether it's JIA. Sometimes you can just tell, if they're riddled with it all through their fingers and it's in tons of different joints, it's probably less likely to be something other than JIA. But like we get called from the ER, for instance, about kids who sound like they have arthritis because they're limping and their joint is swollen and, it's worse in the morning and it gets better through the day. And then they say, well, how do we know if it's JIA? I say, I don't know. I can't tell you. We just have to wait and see if it goes away. Because if it goes away, then we say it was probably something reactive. It was transient synovitis. But if it persists, then, for better or for worse, it'll probably take that long to get in to see us anyway in clinic. And so by that point, then we'll be able to say for sure whether it is or isn't JIA. Okay, so back to the part about labs. So I guess I'll try not to touch about the ANA or go off on the ANA too much, but the thing to remember about an ANA is that it is only actually helpful as a diagnostic tool with a few autoimmune diseases. Not many autoimmune diseases are actually diagnosed based on an ANA. So the ones that are lupus, Sjogren's syndrome, scleroderma, and mixed connective tissue disease. Those 4 diseases are really the only ones that can be diagnosed through ANA testing. You could argue that maybe you could add autoimmune hepatitis in there, but there actually are not very many autoimmune diseases that can be diagnosed through ANA testing. That's one problem with an ANA. So if you're just worried about plain old arthritis and the only symptom the patient has is in their joints, they don't have any other systemic symptoms of those diseases like fevers and rashes and lymphadenopathy and, you know, protein in their urine and all kinds of other stuff. If they just have joint problems, an ANA is not a helpful diagnostic tool. So that's one problem with it. The other problem with it is that, as y'all probably know, ANA testing is fairly sensitive. If it's negative, you can be pretty, you know, confident that that this patient doesn't have one of those diseases, but it's terribly nonspecific because it's positive in 20% of the whole population. Less than 1% of the population has one of those diseases. So when it's positive, about 95% of the time, it's a false positive. So that's why we hate ANAs, because they're just pretty useless almost all the time. We will get them once we've diagnosed JIA because it helps us know how often we need them to get their eyes screened for uveitis, but it is not helpful diagnostically. It's literally useful. Anyway, rheumatoid factor is sort of similar concept where basically it is not a helpful tool to diagnose JIA because 3 to 5% of patients with JIA will have a positive rheumatoid factor, whereas in the adult world, it's, you know, the huge majority of patients will have a positive rheumatoid factor when they have rheumatoid arthritis. But in children, of all patients who have juvenile arthritis, only about 3 to 5% of them will have a positive rheumatoid factor. So it is not a helpful tool to diagnose because you will miss the vast majority of patients with JIA. We do get it, again, once we've diagnosed somebody with JIA, we usually do get it because in the rare instance when it is positive, it does sort of portend a worse prognosis. It sometimes means we need to be a little more aggressive about treating it because it sort of means they're an adult, they have adult rheumatoid arthritis and presented young with it. But that's really its only use. And then SED rate and CRP, again, same thing. So it happens all the time that kids have terrible arthritis and totally normal SED rate and CRP, and vice versa. Sometimes they don't seem to have such terrible arthritis, or it's only 1 or 2 joints, but their SED rate and CRP are super high. So we do get them because we like to characterize the inflammation and sort of follow those numbers over time. Sometimes there will be a red flag in there. I mean, if I see somebody who has, you know, a CRP that's crazy high when they have arthritis, I mean, I might worry more about cancer or something like that, because we don't typically see CRPs that are crazy high. Every once in a while, we'll see a SED rate that's pretty high, but we don't usually see CRPs that are crazy high with just JIA. So again, just like looking for clues, trying to characterize all this, but not helpful diagnostically. So again, if you get a SED rate and CRP with somebody with joint pain and it's normal, then you say, okay, well, then you don't have arthritis, then you'll miss a bunch of kids too. Because really it's just not, there is no correlation between their SED rate and CRP and whether they have arthritis or how bad it is. And then a CBC is the same sort of concept. So we will do those just to look and make sure we're not missing something, but not really helpful from a diagnostic standpoint. Also viral titers, we see this a ton where, you know, like mono titers are done, parvo titers are done. We almost never get those when we are looking at somebody for arthritis or the possibility of arthritis, unless they have other symptoms that make us think that maybe it was mono or parvo or something. If they have a lot of viral symptoms or had a lot of viral symptoms, if there's something weird about the story that sounds like this is some kind of virus, then maybe we'll do it. But we don't do them for any other reason for the most part. And then the strep titers. So that's another thing that we almost never get, again, unless there is a history to suggest that it's necessary. So, you know, there is such a thing as post-strep reactive arthritis. So arthritis that happens as a reactive process after a strep infection. But first of all, it's really uncommon. And you know, the infectious disease doctors will tell you that these titers, ASO and DNase-B, are very commonly high in school-age children for no good reason. Like, you know, they're just sort of constantly getting exposed to strep. They had strep months and months ago, and so their titers rose, but after they were treated, they just never seemed to come back down. That stuff happens. So we see these numbers kind of elevated all the time. You know, I think most labs, depending on the age, will say that, like, for instance, for an ASO, normal is less than, let's say, like 200 or 250. And we see it all the time where they're like 600. And it almost never means anything. So if it's 6,000, I might be a little bit more excited about it. But these numbers are not helpful unless somebody says I had strep throat, or like I had a sore throat with a fever. I didn't really feel like getting checked out by the doctor, so I never went. And then, you know, 2 weeks later, I started having my joint pain. Then maybe it might be helpful. But without that kind of history, we don't usually get those labs. Lyme testing, do it a lot, although still not every time that we're looking at arthritis in a new patient. So Lyme arthritis typically likes one joint, which is typically a knee. So anytime somebody has monoarticular arthritis in one knee, we will always get a Lyme test. Even if it's both knees, I'll usually get a Lyme test. There is such a thing as Lyme in other joints. You know, I've seen it in a wrist, I've seen it in an elbow. So I have a pretty low threshold to get Lyme, but I don't do it always. So again, usually if it's affecting a bunch of fingers, I don't do it because Lyme does not do that. Or sometimes if a parent begs me for it or something, I'll just do it because as long as you know how to interpret the test results, then it's not usually a terrible idea to get a Lyme test. But the problem is a lot of people, we've seen it all the time where somebody will get it and then sort of get confused by the results and then say you do have Lyme disease or treat it, but it's actually not Lyme disease. So as long as you feel comfortable interpreting the result, it's not a terrible idea to get a Lyme test. Okay, so that's inflammatory musculoskeletal pain. So we'll move on to the next category, which is mechanical. So the typical patterns and characteristics of mechanical musculoskeletal pain, basically all of the opposite from inflammatory musculoskeletal pain. So typically, as opposed to inflammatory arthritis, mechanical is usually worse later in the day. So they wake up feeling okay, but as the day goes on, they start having their pain. It usually sort of starts out fine and it will either progressively get worse as the day progresses, depending on what the problem is, or it will, they'll be okay, but then they have to do PE or they do their sport or they went to an amusement park or something where that required a lot of activity, and that's when their pain started. So typically, as opposed to inflammatory arthritis pain, this pain gets worse with activity and better with rest. So again, swelling, sometimes they'll report it, but typically it's either transient or mild, or, it's just they've seen it once or twice, but not usually. Now, if they tore their ACL or something, then they may have persistent swelling, but the characteristics of their pain will likely be otherwise different. It won't be worse when they wake up in the morning. There won't be all that persistent, prolonged morning stiffness. So it's not that everybody who has a swollen joint that stays swollen has arthritis, but most of the time, with the exception of some really significant structural problems in the knee, typically they either don't have swelling or it's transient and mild. A lot of times they sort of tell you things like it hurts when I do this, it hurts when I do that, like when I squat, when I bend, when I sit in this position. So they will tell you a specific thing that will make it hurt, whereas most kids with arthritis, there's not a specific thing. It's just sort of morning in general. And then same thing with stiffness. So usually they'll say no stiffness, but if they say yes, then you have to ask them how long, because again, a lot of kids will say like, well, once I'm out of bed, once I take a step or two, then the stiffness is gone. And I think, they sort of feel that like we all do, like when you're first getting out of bed and you just have that kind of generalized body stiffness, but it resolves within a minute or so. That's not what we worry about. It's the prolonged stuff. So basically, as you can see from this list, all of these features are opposite of features with inflammatory arthritis pain. So just a few things that we will often see in rheumatology clinics. So things like patellofemoral syndrome, Osgood-Schlatter's. We do find some osteochondritis lesions sometimes, which is what you're seeing in the imaging there, that sort of scooped out area is an osteochondritis dissecans lesion. So that's hard to diagnose by history or exam, but MRIs, we see that in MRIs very often. Ankle sprains, overuse, and then we see tons of hypermobility. That's not really our, I guess, diagnosis. So like we get a lot of referrals for hypermobility, which is not quite what we are sort of trained in doing, but we end up, when we get the referrals for pain, we end up finding that they are very hypermobile. That's pretty common. So, and it makes a little bit of sense with hypermobility that if your joints sort of slip and slide and stretch more than they should when you're using them, that can cause some micro traumas and just some generalized pain with all the stretching and slipping and sliding. So hypermobility arthralgias is something that we see fairly common in all age groups. So talking a little bit more about hypermobility, since we see it so often, there are a lot of diagnoses in theory that could lead to hypermobility, like Ehlers-Danlos is kind of the one that's so in vogue right now. We get a lot of referrals for this, although it's not really our disease. So we do our best. Like when somebody gets referred to me for Ehlers-Danlos, like I just sort of pull up the criteria on Google and I just sort of go through it as I'm looking at them. We don't really have any actual training in Ehlers-Danlos syndrome, but because we see so much hypermobility, we've sort of gotten used to looking at those criteria and kind of helping figure out whether they have it or not, which most people don't. So the diagnosis part of it is something that most people actually could do. You just sort of pull up the criteria on Google and look through it, and you just do an exam and history taking. But there's other things. There's Marfan, there's Stickler syndrome, even Down syndrome can make kids really hypermobile. So there's all kinds of reasons, but actually the most common thing is just what we call benign hypermobility syndrome. So there really is no diagnosis per se. There's no underlying pathologic issue. It's just that they're just sort of made hypermobile. So that's the benign hypermobility syndrome. And, I also usually try to tell patients, a lot of patients really want that diagnosis, whether it's Ehlers-Danlos or something else, they really want that thing to sort of hold on to. But Ehlers-Danlos is a little strange because like if you look at the Beighton scoring system for Ehlers-Danlos, it's basically 1 point for being able to oppose each thumb to your forearm. It's 1 point for hyperextending each pinky beyond 90 degrees. It's 1 point for hyperextending each elbow beyond 10 degrees, 1 point for hyperextending each knee beyond 10 degrees, and then a point for being able to lay your hands flat on the floor when your knees are straight. But there's no ankle in that exam, there's no hip in that exam, there's no shoulder in that exam. So if you're crazy hypermobile in your hips and ankles, like to the extent that they're slipping out of place and sliding out of their socket, and it doesn't matter, you don't have Ehlers-Danlos unless the other joints that are actually on the Beighton score are hypermobile. So it's a little academic to like sort of label somebody as Ehlers-Danlos. Because if they're really hypermobile in other joints but don't have Ehlers-Danlos, it's all hypermobility. It's all like mushed together. And anyway, so we see a lot of people who just like want that diagnosis and they don't get the diagnosis, but they are really hypermobile. Anyway, so we see a ton of that. This is just a sort of diagram of the Beighton scoring system. So you can see the point system. So, and then the moves that you actually have to do. And again, anybody can actually do this. So sometimes we've actually gotten so many referrals for Ehlers-Danlos lately, and we don't have time to see them all that, I feel like, and actually the genetics department, I think I've heard that they actually won't see hypermobility anymore because they were getting so overwhelmed by all the referrals, and it's not a genetic diagnosis, at least for Ehlers-Danlos. So I think it would be good for for there to be some shared way of sort of diagnosing this, because again, all I do is pull up the criteria. So it'd be good to look into some of that and sort of see if practice it in clinic for people who see kids with pain. Because it's not actually such a hard thing to rule in or rule out with the criteria that they've put out. And patients usually appreciate it. But this is this is the physical exam part of diagnosing Ehlers-Danlos. This is just some more stuff about that. Anyway, so regarding hypermobility, so when we talk about non-Ehlers-Danlos, pathologic sort of reasons to have hypermobility, really just diagnosing benign hypermobility syndrome is otherwise just doing an exam and sort of knowing that somebody is hypermobile. So that's where, having done a lot of joint exams does help, but there is no diagnostic criteria for benign hypermobility syndrome. And these are the types of diagnoses where they'll often say yes, that they do see swelling when you ask them about swelling, but this is the one where they'll say, yeah, it's like every week or two, I see that something's swollen, it lasts an hour or two, and then it goes away, typically brought on by activity like their sport. Typically when somebody has joint pain from being hypermobile, at least to begin with, for the first, several years that they have this, the pain happens during activity. So if it's an athletic child or a child who does a sport, they'll tell you that it happens during that sport, but then not so much at rest. So it's during activity, not there at rest. What we kind of notice is that when they're having that much exposure to pain, they are at high risk of sort of developing the amplified pain that I'm going to talk to you about next. And there's theories about kids who are exposed to pain a lot, where the pain sort of centralizes and it becomes this whole other type of pain, which is the amplified pain. So we see amplified pain in kids who have hypermobility really commonly. The other thing that's a little bit tough about hypermobility is that there's no it's not a straight line between how flexible your joints are and how much pain you might be in. There's some people that will do all kinds of circus tricks and touch their feet to their ears, but then they have no joint pain at all. And then there's some kids who are like somewhat hypermobile, but not really that impressively, and they have tons of pain. So it's not really a straight line between how hypermobile they are and how much pain they may or may not have. And the other thing that we see a lot and that we sort of look for in most patients is when they're hypermobile, one of the most common places to be really hypermobile is in the feet and ankles. So we see what are called valgus deformities really commonly in the ankles. So when they sort of, obviously you have to have them stand up because a lot of these are not fixed deformities. So when they're on the exam table, you might not notice how flat their feet are, but when they stand up, suddenly their arch just totally disappears, and then their ankles hyperpronate really significantly. So in the bottom right picture, you can see somebody, I mean, that's not anything we do. You don't really need to draw lines in the back of the heels to be able to see it, but you can just sort of see that that the degree of angulation of the heel and ankle when somebody hyperpronates is sometimes very significant, and it can cause a lot of pain. So a lot of kids who have this these valgus deformities where they overpronate their ankles and have really flat feet, this can cause a lot of pain in the feet and ankles, but it can sometimes also cause pain higher up in like the knees or the hips or even the back. Again, not a straight line. So some kids have amazingly flat feet and valgus deformities with no pain, and then you see some kids who have, you know, somewhat flat feet and overpronating, but they have really severe pain. But we see that really, really commonly. So then we talk to them about arch support inserts in their shoes and all that sort of stuff. So again, these are things that we're not really trained in rheumatology, but we just, you know, we see it so often that we sort of learn how to help them with it. And so when it comes to mechanical pain, any of these different categories, of course, then treatment revolves around NSAIDs, physical therapy. So I think we keep physical therapists in business sometimes, because when I see a patient and I put them in the mechanical category, if I do have a specific diagnosis like patellofemoral syndrome or hypermobility, I send them to physical therapy. But sometimes you can put them in that category, and like if they have, let's say they have hip pain, but it's not inflammatory, I don't always actually have a diagnosis to give them. They may not be hypermobile. There's not like a structural thing that I can see, but they definitely have hip pain. It definitely falls into the mechanical category based on the characteristics. And then I send them to physical therapy and they get better. And the physical therapists are actually probably better than I am at sort of isolating exactly what the problem is and figuring out how to treat it. So, you know, I think sometimes I sort of try to take the pressure off of myself to actually give them a concrete diagnosis. But if rather than guess, you just sort of send them to physical therapy. And most patients are fine with that. If I do think there may be something more sort of isolatable that I can't exactly put my finger on, sometimes I'll refer them to orthopedics instead. But if it's just sort of some pain that really doesn't worry me for something, you know, operatable or highly structural, then I'll just send them to physical therapy, and a lot of times they get better. And again, using the shoe inserts. So we're going to talk about amplified pain. Okay. So again, the amplified musculoskeletal pain, or AMPS. So this is sort of that fibromyalgia type of category. So the typical characteristics of that, you'll see a lot of similarities in the features of this compared to the mechanical, but it's amplified. So a lot of times this pain will be very widespread. So it's not isolated to just a couple of joints or even joints at all. It's just very widespread. It's all the areas in between joints, muscle areas, soft tissue areas. Sometimes it can be more localized. That's actually usually a good thing when it's more localized, but when it's really widespread, that's sort of a tip off toward amplified pain. Another big thing is that it's really, really severe, very intense, and like out of proportion anything that sort of makes sense based on, you know, your exam or anything that they're telling you otherwise. It's just really severe. It can be like any sort of characteristic otherwise. So a lot of times they have something really specific to tell you, like it feels like somebody set a sword on fire and jammed it in my leg and twisted it 90 degrees. And you know, they have a lot of very vivid explanations for how their pain feels a lot of times. And then, you know, when you actually examine them, a lot of times they'll, or even somebody in history, like the mom will say, you know, I can't even touch them. It hurts so bad. You know, every time it hurts and I try to massage them, they scream, it hurts so bad when I try to touch them. They're just so sensitive to pain. There's so much hyperalgesia. This is usually also worse with activity, often worse later in the day, just like mechanical pain. They'll often, a lot of times, describe it, it's worse with the cold weather. Sometimes they'll tell you that there's some color changes associated with it, like it's a little bluish or a little dusky. Sometimes it's cool to touch or it feels cold. There's probably a couple different reasons for that. Sometimes it's because they're in so much pain, they just don't move the affected areas very much. And, if you're not really moving something, it tends to get a little dusky and cold to touch. But there probably is some reasons based on how the nervous system interacts with the blood vessels that does that too. They will often also describe a lot of other symptoms in addition to having body pain. They will have headaches, they'll have abdominal pain, sleep disturbance, etc. And then you start feeling the same symptoms when you're interviewing them, because it's just so overwhelming sometimes. And I think that's sort of a diagnostic clue also when you're getting the history and you start feeling the same way. It really can be very overwhelming for an examiner or for a provider to take a history from these kids and talk to these kids. It's just very overwhelming. So it's actually a fairly prevalent thing. So this one study says 2 to 6% of school-age children, although it's probably more than that. And this particular study out of Children's Hospital of Philadelphia says it comprises 7 to 15% of referrals to pediatric rheumatologists, which is probably about right. We tend to see it mostly in adolescent females, but we see it, sometimes I see it in even older elementary school ages, 9, 10, often see it in boys too. The terminology I sort of alluded to at the beginning can be very problematic. So like I said, we usually use the term amplified musculoskeletal pain syndrome, or AMPS, as like the category. And then within that category, there's all these different things you can call it. So juvenile fibromyalgia, reflex neurovascular dystrophy, myofascial pain syndrome, pain centralization syndrome, complex regional pain syndrome, reflex sympathetic dystrophy. I threw the term growing pains on there, not really because growing pains are part of this, but a lot of times it happens all the time when we're diagnosing somebody with amplified pain where, you get the history and they say, I've had pain for 10 years, ever since I was 4. Everybody always told me it was growing pain. And, it's sort of like, well, it probably wasn't wrong to say that. That was the most likely thing at the time. It was like it's a young child who is having some pain, so they get told it's growing pains. But not everything that is pain in a young child is growing pains. And so, I think that's what most kids get labeled with until it becomes something that's just more obviously not growing pains. So, again, they're not the same thing, but I just sort of threw that in there just because I would say at least half, if not more, of kids who I end up diagnosing with amplified pain sort of start the story with, I've had this pain for this long, and I always was told it was growing pain. So, again, not wrong. It wasn't wrong for anybody to call them that, but when you start seeing the same kid over and over and over again for pain, might be something to consider. This is just sort of breaking it up into what different terms might mean to different people, but it really isn't very important, to be honest. I wanted to sort of, I didn't have a slide on this, but in terms of like what is amplified pain, or even fibromyalgia, usually what I explain to people, to the child as well as to the parent, I usually make an analogy to something like anxiety or depression, because everybody knows about anxiety and depression. And especially this day and age, everybody knows that it happens even in children. But if you're like if you're too concrete of a thinker, it doesn't always make sense, right? Like some people have really severe anxiety, terrible depression, even though everything is great in their life, right? Like they don't have any terrible childhood traumas. Their family is nice and happy and, functional. Everything's fine. So like, why are you depressed and why are you anxious? It doesn't make sense. But it's because you don't have to have some sort of reason to have depression or anxiety. You don't have to have a trigger. Some people do, but you don't have to. And it's because it's a problem with the chemicals in your nervous system. These neurochemicals play tricks on your brain. They tell your brain to feel this way, even though there's not a problem in your tissue. It's not like if you MRI your brain when you have depression, you'll find inflammation or some other problem. You should have a normal MRI if you just have depression. So there is not like a cause of it, or there's not like a tissue cause of it. There's not an external cause of it. It is just a problem with the chemicals in your nervous system that we don't fully understand. So that's depression and anxiety. Amplified pain or fibromyalgia is a very analogous thing where somebody has these feelings of pain, even though there's nothing wrong with the tissues in their body. There is no inflammation anywhere. There's no injuries or structural problems. There's nothing wrong with the tissues in your body. So if you do every test, look with an MRI, you should not find anything because everything is totally healthy at the level of the tissue. You don't have to have any sort of historical trigger for it. It's just a neurochemical problem where the chemicals in your nervous system tell your brain to feel a lot of pain, even if there is absolutely no reason to. So usually people sort of get it when I frame it that way. And then, then you can sort of at least move on once they sort of get it. In terms of like sort of officially diagnosing it, there are theoretically some classification, but a lot of the classification relies on having tender points on exam. This is especially true in adults with fibromyalgia, although actually it's less true than it used to be. But maybe you remember with fibromyalgia in adults, there are these tender points. There's like 18 tender points on exam. And they have to have, I forget if it's 9 or 11 in the adult world in order to meet classification criteria for fibromyalgia. And in these particular classification criteria for kids, they were supposed to have 5 tender points on exam. And a lot of kids do have tender points on exam, but a lot of them don't. Some have no tender points on exam. It's really weird how some patients you could like blow on their skin and they're like jumping off the table in pain. And other kids, they tell you about all their pain, but then you try to find it on exam and there's no pain everywhere you push it. Doesn't really hurt them. They are just so affected by pain, but it doesn't come out when you push on them. So I don't really like using any classification criteria. I mean, at this point, it's sort of pattern recognition for me, but really it's just sort of tons of pain. Large workup has been totally normal. And the biggest thing usually is how it affects them. So kids who have amplified pain are usually terribly disabled by their pain. Occasionally they come in wheelchairs. They're unable to move or walk at all, but more typically they are functional, but much less functional than they previously were or should be. So they've quit their sport, they're missing tons of school, they're avoiding, either social activities or family activities. So they're really somewhat or majorly disabled by their pain. And that's usually the tip off that, they tell you about all their pain. You've looked for everything you think of and can't find anything. They're really, really disabled by their pain. That's usually the tip off for amplified pain. This is just driving that point home. I was talking about anxiety and depression as an analogy, but actually a lot of times this is comorbid with anxiety and depression for the same reasons. I mean, if it's all issues with chemicals in your nervous system, it's just like lots of other things in medicine where once you have one problem with those chemicals, you often have other problems. And the other thing is that it's not like you have one chemical for your left arm and one chemical for your right arm and one chemical for your back. It's all just chemicals that cause pain. And so a lot of times kids who have body pain from amplified musculoskeletal pain syndrome will also have headaches and abdominal pain because it's just all pain. So a lot of times the neurologists end up receiving them and diagnosing them when headaches are the most prominent symptom. A lot of times we will end up diagnosing them in rheumatology when body pain is their most prominent symptom, and a lot of times GI will end up diagnosing them when abdominal pain is the most prominent symptom. But it's all wrapped up together. This is just talking more about the nomenclature. The interesting thing is a lot of times, again, one of the challenges to amplified pain is that everybody is so different. But what we sometimes see is that actually the process starts with a more organic problem. Like I said, I sort of talked about it with hypermobility, where they have a lot of hypermobility, and at first they just have pain with activity related to being hypermobile. But the more exposure to pain they get over time, something seems to change with the chemicals in their nervous system, and then the pain centralizes and becomes something totally different. So we also see that with, like, let's say a broken ankle or a sprained ankle, some sort of more organic tissue injury, and they get immobilized for that injury, like a fracture or sprain or something. And then the injury heals and they come out of their immobilization, and suddenly the pain is much, much worse. And it sort of becomes this whole other type of pain, especially when it's localized to a similar area there. That's a common thing that happens with the more localized versions of this, like complex regional pain syndrome. So sometimes it does it does have a trigger. It does come from somewhere or start with a specific event. Although with the more sort of diffuse kind of fibromyalgia type of pain, that's not always true. Sometimes it's, a lot of times when I ask when a kid has like full body, just covered in pain, and you ask, they start the history and you ask them how long they've had pain for, they'll say, as long as I can remember, since I could walk, since I could talk, since I can remember feeling things, I've had pain. So everybody is really, really different, but it does sometimes happen where it comes from, there's like a trigger for it, like immobilization after an injury. When that happens, when it's more localized pain and it's triggered by something like immobilization after an injury, it does tend to have a much better prognosis and ability to sort of get better with physical therapy compared to the full body pain. This is just a picture. This is from when I was a fellow. So this patient's left leg, you can see the sort of the distal lower extremity is a little swollen looking. And in the side view, you can see the foot is actually quite swollen and sort of dusky purple. This child actually has complex regional pain syndrome or that version of amplified musculoskeletal pain syndrome where she had an injury at this point, I can't remember what it was, and was immobilized. And once the immobilization was removed, she just had ungodly, unbearable pain, could not bear weight or go anywhere or do anything. And she came into our clinic in a wheelchair, and this is how her leg looked. And of course, we did do some workup for it and look for blood clots and things like that. It's all normal. She had amplified pain, and this is really common in these localized versions of amplified pain to have swelling and discoloration. Again, partly because of probably the fact that you're not moving it in the blood pools, but also because there must be some way that the chemicals talk to the blood vessels that result in this. But it really can be pretty interesting how you feel the coldness and the swelling and the discoloration. To the extent that sometimes, we don't do a lot of bone scans anymore, but back when they did these more often, you would sometimes see decreased blood flow to the affected area. Like in this picture here, you can see the arrow is pointing to the leg that is affected, and there's decreased blood flow, even though all it is amplified pain syndrome. So anyway, let's see. So this is actually what I already talked about with growing pains, everybody in this room who takes care of kids has probably had some interactions with growing pains, or if you have your own children. So growing pains are classically where you have pain in the long bones in a young child, usually between like 3 and 8 or 10. And it's usually in the evening or even in the middle of the night while they're sleeping. And it's usually like these short little episodes, like they sort of tell you how bad it hurts, and then you either massage them or give them some ibuprofen, they fall back to sleep, and then it's totally fine. You don't see it again for a week or a month. But we see where it's not that story, it's just pain, and in a kid who is of a really young age, and it just seems like over time it just keeps getting worse and worse and worse, and then it becomes amplified pain. And it's not really that growing pains causes amplified pain. It probably just wasn't growing pains to begin with. So let's see, I think I'm gonna skip over some of this stuff. Treatment for amplified pain. So this is also just very dependent on who you talk to. In rheumatology, most of us have always been trained very significantly to not use any medicine to treat this pain. Not because we're mean, but because number one, medicine doesn't actually help very much. So pain medicine, actually, that's one of the diagnostic clues too, is that they tried all the pain medicine. They tried Tylenol and ibuprofen and Aleve and whatever else, and none of it helps. That's a clue. There are some FDA approved medicines in adults, but there are none for children with amplified pain. Occasionally, when somebody begs for something, we'll try some like muscle relaxants before bed, but even that is a really significant band-aid. Occasionally, amitriptyline before bed, things for sleep. I never use Neurontin, essentially ever, because when it comes to amplified pain, I don't think I've ever seen a child that it actually helped. Even if somebody felt like it helped for a short period of time, it was not a sustained benefit, or even if it helped, they had a lot of side effects. So a lot of people try Neurontin, but we don't. Opiates are like the worst idea in the world. That's a great way to get addicted to them. Really, in our world, the treatment is exercise. I have a whole another way of like telling patients about this, because if you just say, okay, you need to exercise, and they want to like kick you in the teeth. But so we use physical therapy as the main way to start the ball rolling with getting them to exercise. There are, it's not like, I mean, there's good ways to exercise and bad ways to exercise. When you have amplified pain, the kids need to push themselves through some amount of pain, but not so much pain that they then can't walk for a week, because then they won't walk. And then the less movement they have, the worse they'll feel, because generally the more they move, the better they feel, the less they move, the worse they'll feel. But we try to sort of give them the expectation that this is a very slow process. So in physical therapy, it may take months and months for the pain to really get to a point where you are feeling good. And that's okay, but you have to kind of continue. And then if you go to physical therapy twice a week, you have to make sure you're doing your exercise at home almost every day in between. Start really slow in physical therapy and gradually increase over time. Sometimes kids have to start in aqua therapy because they can't tolerate land therapy. The physical therapist will also help them learn desensitization techniques where they take like hair brushes and brush them over the affected areas, and terry cloth washcloths and things. That's more helpful when kids really do have all that skin sensitivity. That's very common with amplified pain. And then like the physical therapist sometimes use TENS units. That's a little controversial with amplified pain, but I don't usually feel like it's a harmful thing. So paraffin baths, whirlpool, all kinds of stuff that they can do with physical therapy. The physical therapists are miracle workers as far as I'm concerned. This is just a picture of a TENS unit. Again, a little controversial with amplified pain, but I have some kids who really, really like it, get a lot of benefit out of it. There's paraffin baths that they sometimes do in physical therapy. And then I usually sort of tell them that unfortunately, their physical therapy is their medicine. They have to take it almost every day. The more of it they skip, the worse they're going to feel. The more of it they take, the better they feel. I say, what if I had a medicine for you? And I told you, if you start taking it now, it's definitely going to help you, but it's not going to help. It's not going to start to really work for like 6 weeks. Most of them would take it. There is no such medicine, but there is physical therapy. So they have to start the physical therapy, really sort of become dedicated to it. And they might not start to notice that it helps for a while. And I usually tell them that they might notice their function improves before their pain improves. So they notice that they can do more even in the pain that they have, before they actually can say that their pain is improving. And that's fine. That's how it usually goes. They often benefit from counseling for stress management and relaxation techniques. And then at the end of the day, when it comes to evaluating a child with any kind of musculoskeletal pain, there are some red flags that make me want to look for other things or really be sure that I've got the right diagnosis. So fevers, a lot of people sort of feel like fevers happen with juvenile arthritis, and that's actually not the case. There's only one type of juvenile arthritis that should incorporate fevers, and that's systemic onset, which is usually a very dramatic sort of thing. So when kids are having fevers and they don't have systemic onset JIA, I do worry about cancer. Obviously, weight loss and night sweats. If they are completely unable to walk or bear weight at all, that's really unusual for JIA. They'll often limp, but they're able to bear weight to some extent. So if they're unable at any point to bear weight, that is typically not JIA. And so I'll look for other things, whether it's septic arthritis or cancer, or osteomyelitis or something else. And then, occasionally they might wake up with pain in the middle of the night, but actually not very much. So if they're doing that a lot, that also worries me. So these are some like red flags. That's it. Here's some references. Let's see. I'm sure there's a way I can see if there's any questions in the chat. Does anybody have any questions in the audience? Yeah. Yeah, we see that sometimes where somebody has had some version of amplified pain in the past, whether they were diagnosed with it or not, and then it gets better and then they're okay, okay for a while, and then it comes back either the same similar way or some totally different way. Excuse me. We do see that. I will say that for the really localized pain, like after a period of immobilization or something, once that resolves, we don't see it come back all that often, but it does sometimes happen. It definitely happens. So they are more prone to it, although we still don't see it that. Anybody? Yes, unfortunately, none of them accept Medicaid, but yes. So it's Children's Therapy Center and Fleming Therapy Services, I think it's called. So Children's Therapy Center has 4 locations, Springfield, Falls Church, Sterling, and Gainesville. And they most of those locations have a physical therapist who has gone to Children's Hospital of Philadelphia for training and treating amplified pain. And then at Fleming Physical Therapy, which is just one M, FLEMING, they have also physical therapists. There's one physical therapist there who actually had amplified pain when she was a child, so I love her. Yeah, so it's Children's Therapy Center and Fleming Therapy. I will say that for Medicaid patients, Jackson Clinics accepts Medicaid, and actually I have patients do great at Jackson Clinics. So we try to get them into Children's Therapy Center when we can, but when we can't, which is pretty often, they have great success in lots of other therapy centers also. So as long as they get somebody who feels comfortable treating it, then they usually do very well. Yeah. Mm. Right. Yeah. So, yeah, right. Well, it depends a little bit. So the question was, you know, should we get labs for kids with joint pain before they come to see you in rheumatology? It depends on the story, honestly. So if a kid just has pain and that's it, I think getting basic labs is helpful, like basically CBC, CMP, ESR, CRP. Yeah, so I actually think that's pretty reasonable. If I meet a child in my clinic who has pain and they've never ever had a blood test, I don't always do it, but I have a lower threshold. Number one, because usually by the time they're seeing me, they've seen a bunch of other doctors and a bunch of, you know, like they've told somebody their story a bunch of times. And if they've never had a blood test, a lot of times they really want the blood test just to sort of prove that they're okay. So I'll have a low threshold if there's any possibility it could be cancer or something else. So I'll have a low threshold to just do those, the CBC, CMP, ESR, CRP. Well, right. So unless it really smells to you like arthritis, so if it like follows all of those patterns that I described about the inflammatory pain, then I will also add an ANA only because of it helps me with the uveitis screen. And if then I don't poke them again for it. I would say if you are really unsure, then no. Because especially the ANA, because it comes back positive so much. And somebody, you know, people come really worried about it. And because it takes a while for them to come see us, they've been worrying for a month or something before they actually come see us. So, right. So it depends a little bit on your level of suspicion, I guess is what I'm trying to say. If your level of suspicion for something, you know, really real, some disease process, autoimmune or otherwise, then you can try to get those things. But if you are pretty low suspicion that it's going to be some disease process, then just a CBC, CMP, ESR, CRP. And if we find that and we meet them and we think that they actually do have arthritis, a lot of times if they've had that done, then so the other thing, once I've diagnosed somebody with JIA, I get an ANA, a rheumatoid factor, CCP antibody, and an HLA-V27. So those are the 4 that I will get after once I've diagnosed somebody. But a lot of times, let's say they come to me, they have JIA, like I diagnose them with JIA, and they've never had those blood tests. I actually don't always do it then, because let's say I'm going to put them on methotrexate. If I start them on methotrexate, they're going to need labs in 6 or 8 weeks. I'll just wait till then, you know, so you don't have to get them before you see me, because a lot of times they cause more problems than they're worth, and I'll get them anyway later. But for new patients, probably about 6 or 8 weeks, I would say. Yeah, there was over the summer, I think it was about 2 or 3 months. We are hoping to hire another rheumatologist before next summer. We'll see how well that goes, but it has been bad lately. So that's why I was talking about all the hypermobility stuff. Like we've been seeing so many referrals for hypermobility that we're starting to worry that we might have to say no to seeing patients with hypermobility because it's just not our disease. And really anybody can diagnose Ehlers-Danlos, and they're jamming up their schedules quite a bit. So we may have to be a little stricter, at least until we get another rheumatologist about who we end up seeing. Yeah. So I am very quick to start hemia. Probably a little quicker than Dr. Abshahi is, just maybe based on training and things. I have a really low threshold to start Humira in most patients. That was the question, is how quick are we to start Humira? I always tell patients Humira is my favorite medicine in the world to prescribe because it has, in most patients, essentially no side effects. It's crazy well tolerated, even though it's an injection. It's only once every 2 weeks. It's a very, very painless or low pain injection, and there's like no side effects. It works really quickly. It's not guaranteed. It's not like it works in every single patient, but when it works beautifully. It's so well tolerated and works quickly. And then they get to potentially lower their dose of methotrexate or get off of it if they're already on it. Sometimes I just skip methotrexate completely and go to Humira. It used to be the insurance companies were pickier about it, and they would require a 3-month trial of methotrexate before Humira. But they've been less picky about that over the years. So if I have any excuse to just go straight to Humira, I usually will. Or whatever their biologic, but usually Humira. Any other questions?
I like the I can refer
Mhm.
that they have physiologists all
And PT.
I don't know. When I that question, I kind of
Yeah, I think that's reasonable. I do the same thing actually. I am not a pain management doctor. I think a lot of people sort of for some reason think of us that way a little bit, but I don't know anything about pain medicine. I know about anti-inflammatories like, NSAIDs. I know lots and lots about those, but that's because I need them for inflammation. When it comes to just treating pain with medicine, I don't know much. So I try to avoid medicine because most of the time it's counterproductive in most patients with amplified pain anyway. There's lots of reasons why they might need it, but with amplified pain specifically, it's usually counterproductive. It's like a Band-Aid. They kind of rely on it. They keep getting mad that it's not working, and then they want other medicine, and it sort of snowballs. And usually the physical therapy is astronomically more effective than any medicine. So I usually really push hard to avoid any medicine with amplified pain. But other, like if either they just won't, let up without asking about it, or if they just, they're going to get it or want it or try it no matter what. I refer to the pain management clinic at Children's also, and they have a lot of experience in treating amplified pain. So it's, they see it, they are experienced in it. So it's not a bad thing. It's just that usually for at least an initial evaluation, they have to drive to DC. But if they're willing, it's usually a good experience for them. So yes, but pain medicine, free. we don't usually use it. Any other questions? Okay, I don't think there was actually any questions for me in the chat, so we're good. Thanks, guys. Oh. How long can Pete's cases be on NSAIDs for musculoskeletal safely, or how long is too long? That's a good question. There is no limit. I guess I would answer that question. So in fact, in rheumatology, there are some cases of arthritis, especially. There's some other diagnoses too, like CRMO, for instance, where sometimes we'll actually try to treat it with just NSAIDs before jumping to immunosuppressive medication. So I would say spondyloarthropathies and CRMO, sometimes we will try to treat with just scheduled NSAIDs so that we can try to spare them immunosuppressive medicine. And so I have patients who take scheduled NSAIDs every single day, and they're on it for years and years. And the biggest thing you worry about is stomach upset. So we try to just counsel them to, not take it on an empty stomach. Sometimes we'll add an antacid or something. But there really isn't there's no number for what's safe. Usually if somebody is on scheduled NSAIDs chronically, I will check blood and urine testing like twice a year to make sure there's no problem with their kidneys. But I don't think I've ever found one. Usually for all the years I've been doing this and all the NSAIDs I've prescribed and kids who are on them indefinitely, I've never seen a kid problem. Now, if you ask a nephrologist, obviously they will give you the opposite side of the coin. It's not like it never happens or doesn't happen, but so we do monitor for it. But it actually always intrigues me how some people are so nervous about the NSAIDs. when honestly it's really safe in kids who are otherwise healthy. We try not to use it. The plan is never to use it forever, but it's, you know, and if you think of it as like, well, it's either this or immunosuppressive medicine, there's a lot of ups, you know, pluses and minuses to both. And some people might argue that there's more risk to immunosuppressive therapy. So as long as you're monitoring their kidneys and everything else, then it's really not a big deal, actually. So I would just say indefinite. Indefinite as long as you're monitoring. Anything else? Okay. All right, guys. Thank you. Sure.
Thanks, Dr. White. That was very informative. So we are down to the last speaker of the day. Does anybody need a break, or you guys okay to just keep going? All right. So our last topic of the day is a very important one. The last speaker will be Julia Richardson. Julia is a licensed clinical social worker who works as the lead licensed mental health professional of the Virginia Mental Health Access Program, which is based out of the Inova Keller Center. She received a master's of social work from Virginia Commonwealth University and has a postgraduate therapy training that led her to specialize in the assessment and diagnosis of behavioral health problems in children and adolescents. She also has training in psychiatric crisis intervention for all ages.
Yes.
Hello, yes, you can hear me. I can hear it's working. I'm Julia Richardson. Thank you for introducing me, Neha. I'm a licensed clinical social worker, which means I'm a therapist. I'm really excited to be here to tell everybody about our program, which is the Virginia Mental Health Access Program. It's specifically for providers taking care of kids 0 to 21 through their 22nd birthday. So kids and young adults on anything behavioral health related. So that's a huge wide spectrum. So it's made specifically for you guys, or pediatricians, PAs, NPs, and anybody who works with young adults too. We do primarily serve primary care, so in that capacity, but also had a nephrologist, an oncologist, and an OBGYN call me in the last 6 months. So I will say that I will try to make it as accessible for everybody, because that's what our program is for everybody. So hopefully mental health isn't too much of a heavy topic for the end of the day, but I'm very excited to talk to you all about it, and I hope that it's useful for you. If you have any questions, just put them in the chat or stop me. I put a lot of information in slides, but I'm not into reading slides. I'd rather tell you about stuff. So if you like to read more detailed information, you can just look at my slides later, and I think we'll give them to you. So I don't have any disclosures to make other than I'm an Inova employee, despite working at VMAT. My objectives are that people would be able to articulate what Virginia Mental Health Access Program is, its goal, who it serves, that folks will know the 3 main services of VMAT and how to use our services, how to get a hold of them. That's my basic objective. So the reason that we exist is because there's a really big problem with behavioral health that's spilling over and being addressed in primary care and then also in specialty care. So there's just not enough of us, and the problem's growing. So in 2021, suicide is the second leading cause of death. Certain areas of the country, it's actually surpassed to be the leading cause of death for certain age ranges. So in certain counties around Colorado, which is really dire. It's really bad. So in 2019, before COVID even came to us, about 1 in 4 girls and 1 in 4 boys in our state seriously considered suicide in the last 12 months. So that means it's pretty bad. So if we kind of go up from considering suicide, about 1 in 3 high schoolers felt sad or hopeless almost every day for more than 2 weeks in a row. And about 12% of middle schoolers and high schoolers made a plan for how they might attempt suicide. This is all kind of going on in the background. If this feels like a drastic change from when you were training or your experience as a teenager, that's because it is. It's a definite increase in how often this is happening and the intensity and how quickly kids move from feeling down, depressed, to having plans. Then the pandemic didn't make anything better, as we all know. We found increase. This is for young people in the US 11 to 17, the increase in loneliness and isolation contributed to increases in anxiety, depression, really huge amounts, past trauma, coronavirus itself, and relationship problems. So it's all kind of makes sense. It's what we'd expect. And then AAP, the Virginia chapter, surveyed primary care providers, mostly pediatricians and those working in pediatric practices, and found that their anxiety and depression that they were seeing in their practices had gone up about 93%, almost doubled the amount of kids that they were seeing with that as a presenting thing. I know in our ED here, we were seeing more and more, and still are seeing more and more kids presenting for suicidal ideation than ever before. Across the state, it's really become an urgent thing. About a 54% increase in suicidality. This is just anecdotal, like just reporting back from pediatricians, but this is what they're all feeling. So there's an increase. And about 62% said they couldn't meet the need that they were seeing in their practices with the resources they had available. I'm guessing that if we surveyed people outside of pediatric primary care, it'd be even higher. And we know that everybody needs this support right now. Part of the reason that you all are seeing this out there in the world of medical care is because we don't have enough behavioral health people here. So even as more kids become aware and much more able to talk about mental health and ask for help, we just don't have the people to meet the need. So they're ending up in the ER in their primary care office or talking about this at their specialist's office. When we look at the map of where we have sufficient child and adolescent psychiatrists, there's only really 2 counties and a couple cities, and that one, Rappahannock, they've told me that they shouldn't be on that list up here because they had 2 people retire to their county who don't see kids. Kids in Rappahannock are seeing providers by telehealth. There's no child and adolescent psychiatrist seeing kids there. The reason I chose child and adolescent psychiatrists is because everybody else sort of mirrors this. The lack of licensed psychologists, social workers, counselors seeing kids. There's also a lack of capacity in just psychiatry in general, but this is child and adolescent psychiatry just seems the most stark. Looking at all those red counties, that's whole counties that do not have child and adolescent psychiatrists practicing within them. We know there's kids living there and there's providers seeing kids there. So they are still having to address those needs. This is why we need mental health access program. We need a program to help medical providers who are addressing behavioral health in their practices because they have to. And there isn't enough resource to directly provide care for all these kids. If we could just refer them all into behavioral health, that would be amazing. That's the old model. There used to be capacity for that. Now there just isn't. This is another survey done just after the start of COVID in July 2020 by the AAP Virginia chapter. And when they were really starting to make the case of why we definitely need the MAP program. So in summary, about 70% of Virginia localities are really designated shortage areas, but we feel that everywhere. In Northern Virginia, our shortage is that we don't have enough providers to take Medicaid for any behavioral service. And then we don't have enough providers who even take regular insurance like Anthem Blue Cross or Aetna or Cigna. The insurances that we think, oh, they should be able to get care that they need from a psychiatrist or therapist. It's like 2/3 of psychiatrists in our area do not take any insurances whatsoever. They're out of network completely, fee for service. And that ranges from like $400 or $500 for about 2 hours in a take session to like 280-ish. If so even middle class families or families that are fairly well to do can't afford expert care for their kids. So it's stressful for the community, but also for these families and kids. And then there's only about 14 child and adolescent psychiatrists per 100,000 kids in our state, which is really well below they should be at. And about 65% of pediatricians that they lack the mental health, behavioral health knowledge and skills that they need. So what actually happened was there was a practice in Northern Virginia, Dr. Sandy Chung, she's their CEO, called Trusted Doctors. They had a tragedy in their practice where they were treating a young person who had a psychiatrist who retired. And this patient was on multiple medications and primary care was not situated to adequately address it, couldn't continue some of these medications ethically, and the person had a crisis and killed somebody. And they were very bereft, of course. And so Dr. Chung was the chapter president of the Virginia AAP and looked around and said, hey, all these other states have this thing called a MAP program. where they have child adolescent psychiatrists and therapists available to help us. We could have used that. Like, we want one of those. How do we get one of those? And so then she got her head around it, found out about it, got HRSA grant, got grant money from Jenkins Family Foundation, from Fairfax County too. And then she was on a roll. This is how many other states have a MAP program. Most of these start with HRSA funding. You can see this is the Human Resources and Services Administration, right? Yes. And so ours is currently still under our 5 years of HRSA funding. The fully funded programs by the state means the state controls it entirely. They've funded out of their state budget. So what that means for you guys and for families and patients is you don't pay for anything. The taxpayers have paid for everything that I tell you about. Anything that we have is freely available to anybody, regardless of status, their insurance, where they live, doesn't matter, residency, doesn't matter. As long as they're being treated by a provider who's practicing licensed in Virginia, they'll care about. Or if the family's living in Virginia, we do get calls from providers who are working in DC or Maryland, but their family's living in Virginia and they want our help to get them to care. We're fully funded from state general funds, which was sort of a miracle happening right after COVID. We didn't know if we would get all of our money. We are currently fully funded to do everything I'll tell you about what we're going to do. So that's a lot of millions of dollars. These are our people that have assembled. This team is comprised of Medical Society of Virginia, Chung from AAP / trusted doctors who practice up here. DBHDS administers our state funds that come from a General Assembly, and Virginia Department of Health administers our HRSA funds. We have like multiple boxes, but it all comes together. Our two arms is provider education. That's where we like come out and talk to people. But we have official programs that offer CMEs, and this is for everybody, doesn't physicians, PAs, NPs. REACH is our 3-day intensive training on pediatric behavioral health. It's like 2 full days of intense training, and then 6 months of follow-up case consultation with one of the psychiatrists who trains you. The Project ECHO, I think you already heard Dr. Khurana talk about a little bit. They've applied this model throughout medical education for different things. It started out in New Mexico with nephrologists who got, I think, a little annoyed with answering the same questions, being asked the same questions day in, day out by primary care providers, and said, hey, can I have just a lunch hour, just train you guys every month, and you can come ask your questions. And they developed that into a model. It's called Project ECHO. So we do that based on primary care interacting with behavioral health in a pediatric young adult population. So we have different ones based around the state, and I've been involved in doing that since about 2018. That's really where we started, REACH and ECHO, and then opened the phone line for people who'd been doing training and were interested in getting consultation with the providers, the child and adolescent psychiatrists. QI projects we also have, and then our guidebook, Dr. Khurana talked about that. That includes decision-making flow charts for a primary care, like a non-behavioral health person to follow in terms of like, what are best practices, what are referrals, what should I consider as a differential when I'm seeing certain behavioral health signs or symptoms, and then our hub services. So what that looks like is each region of our state, and they broke us out into 5 different regions, has contracted or made partners with the different mental health serving agencies around the state, because they knew that our state is diverse and they want to reflect that. So all of us from our hub team come from, have practiced in, and live in our area. So when you call into us, you're talking to psychiatrists from Children's National, myself, and care navigators are from Inova. The central region has VCU, CHKD, Centra, VA, Mount Rogers, they're all together, but we're all in one big team. So each of these 5 regions has at any given time a psychiatrist, a therapist like myself who's licensed, and at least 1 care navigator for the whole state. We have 2 up here. So that's a lot of resources. These people are not seeing patients. Our psychiatrists aren't seeing patients while they're on our time for call. We're just waiting to talk to people to help them out. This is ideally how it works in theory. Ideally, everyone would have the education that they wanted or interested in to practice at the top of their scope as they define it. So they know how to recognize behavioral health as it comes into their office, whatever they usually see. They know when they can call us, and they know resources there are for families to access through our care navigation services. And then they can call, they can use our education if they're interested in that. And then they can use our call line. When we get a call from somebody, it's okay if they don't know what they want. We just tell them what we have to offer and what makes sense for their patient or family. This is our team up here in the Northern Hub. You can see all of our psychiatrists come from Children's. All the rest of us come from Inova. We work together. We do work with all the other hubs as well. So if we're really busy up here in the north, we take about half of the call volume, half of the work. The state comes just through the north just because of population. Also because we started first, doing this for 2 years now. So if we get busy, we use our hubs from the rest of the state too. So occasionally, like we're using the psychiatrists who aren't as busy in the eastern region or central or southwest, all working together. Right now we are at 863 providers registered. I always like to say it's whatever, because plenty of people call us who aren't registered. You don't need to be registered to use any of our services or call the line. That's just a measure that they really like. They like people to be registered before they call us, but we are happy to help anybody. You can always register later. We can get your details. The main reason we like providers to register is then we can stay in touch and tell you about what we've done with your patient or send you notes from the consultation. In total, we've done about 3,000 consultations through to the end of September in 2 years. And we've offered about 20,800 hours of training. Over the years, we've, at first we were doubling our rate of calls and consultations. Now we're increasing about 50% each year. It follows a seasonal pattern, just like everything in behavioral health. We're super busy in the spring and a little bit more in the fall. We have a lull in the summer. So we're getting busier and busier. We're hiring more and more people. We have that built into our budget to do that. So people are always asking me about capacity. Don't worry about capacity. We can handle it. If you need help, we're here to help. This is a bit more details about those education opportunities I was telling you about. You can read about them more online at our website down here. Click on. Everything is easier to remember. It's just a website, I think. The phone number isn't easy to remember. vmap.org has all of our information, how to contact us, phone number, emails, everything that you might need, information all about this. And I have that on a one-page link. It's just vmap.org. So this is a little bit more about our guidebook. I think it's really cool. If you download it as a PDF, you can search it. So you could even be like, melatonin. Uses of melatonin for sleep, melatonin with ADHD, melatonin for contraindications for melatonin. So you can search it. It's really cool. And it always has the same format for each of its chapters. It includes a clinical decision-making flow sheet, which can be really helpful if you're not sure what you're looking at or how to best go about working something up. There is a chapter, Dr. Corona talked about developmental. There's a chapter very similar to the flow sheet she showed for ADHD. So like clinical decision-making, what would you look for? What's the first line screening? What's the second? All of that's laid out for you, best practice and citations. This is generally what a consultation is. It means you call us and then we get you on the line with a psychiatrist. Our goal is within 30 minutes of you requesting it because they're often talking to other people, but sometimes, usually it's a little shorter than that, getting them on the line. And then we email the consult notes. If somebody's not sure if they want to talk to a psychiatrist, they don't know what they want, that's when I usually help them figure out what we have to offer and how it matches with what their patient needs. Our care navigation is the only time we work directly with families or patients if they're young adults. That's where their provider says, hey, they need help getting X. I'm pretty sure what they need, or if I don't know what they need, then I've done a consultation with a provider to get more sure of what I think I want to refer them for. And then we're going to need to help them get that. So it could be like they have the musculoskeletal pain and we're referring them to PT, but I think they also need some anxiety and depression treatment. Do you know anybody who works at the intersection of pain and functional medicine? Yes, absolutely. There's CBT for that. There's good CBT for pain management. It can be adapted. That's cognitive behavioral therapy that can be adapted developmentally for kids of different ages. So we're providing resources either directly to the physician, PA or NP in their office, or we're working both with them and the family to let them know, hey, this is what we're finding in the community. That's a tailored list. We don't have some magical database we're pulling from. We're going out there and finding stuff. And because we're doing this every day, we know wait lists, we know who's taking people. So we're taking into account their location, their preferences, cultural language, belief system, things that would be a barrier to them accessing care. And most importantly, best practice. How can we quickly get them to the best intervention so they'll get better? And so helping families advocate for their kids too. These days, it's a very rigorous process to get into behavioral health services. It's kind of like trying to buy a new car these days. I hear that there's a lot of demand and very little supply for buying cars. It's the same for behavioral health. There are a lot of people looking for services and very few providers. And unfortunately, that drives competition in a way that drives down competitiveness and drives up prices. So it's really hard for families. But there is a lot of expansion in the area too. A lot of new providers are coming, people moving to the area, and new services being open. It's awesome. We follow up with families if they want us to every 2 or 3 weeks until they're actually into the service. There's often wait lists. You heard about a year for Dr. Corona, couple months for other kinds of specialties, physical therapy. We work with all of that. We do PT and OT. We do substance use treatment, anything that can be related to anything behavioral health. So developmental, LGBTQ kids who need support and need access to gender affirming care, whole umbrella we work with. And then after they tell us they don't want our help anymore, or they're seen by the providers and happy with it, then we stop with them. But we keep the primary care provider or whatever provider started the case updated on the patient throughout. We usually use email, don't include any PHI in it. But if we find out new information from a family, we definitely call or let them know if it's an emergency. I like to talk a little bit about mental health levels of care briefly, because I think it helps people get an idea of a framework of what's out there, because it can be really intimidating to think about behavioral health. Like, oh gosh, I just know this one piece, and it just feels so nebulous, and like we're sort of making it up as we go. I know that feels that way when you're looking at it from physical medicine, but it's not really. There are insurance requirements and definitions of each level of care, and CPT codes that define each of these. I'm not expecting to teach anybody that, just to have this idea that there's something in there, there's levels of treatment. I think that we all know about like the bottom one. Everybody knows about weekly therapy. It's pretty well portrayed in the media. The patients know about it. Families generally know about that. It also includes family therapy. You know, parents can go to therapy even if their kid isn't, and weekly groups. So like, you know, a group about teen girls, group about bullying, group about anxiety, or substance use group. And I think we all know about this upper range too, of like 24-hour care, hospitalization, locked facility, kind of an idea. One flew over the cuckoo's nest, like you're in there, you're very ill. We don't know so much about these other middle things. And so I just wanted to highlight that there are these. And so if somebody is already in outpatient services and they're not making progress, they're either the same or worse, they need something more intensive. Otherwise, they're going to end up in a hospitalization. You don't need to know what that is, but just know that we can help with that. It'll be unique to whatever their diagnosis is, whatever's going on with them. The best practice may be different, but it will be something that involves more hours of treatment. Just like if they were getting worse for their physical medicine, we wouldn't just keep doing it and say, well, we'll wait to get hospitalized because you can't breathe or whatever. No, you're gonna increase the intensity of treatment, and you're gonna involve more team members to prevent that. And so we call this generally partial hospitalization program, which is like 20 or more hours a week, intensive outpatient. We have access to this for young adults and for teenagers and children in this area, with multiple programs that accept Medicaid, ways to get kids that are uninsured, undocumented, these services. They don't want anybody to think that there's some barrier that can't be overcome with this one. There's, of course, specific treatment for specific problems like eating disorders and substance use, or kids that have developmental disabilities and really intensive care that exists out there too. So I just made this because this is how I'm conceptualizing it, is like ideally, we would have the least amount of kids going up to hospitalization, the most amount of kids down here. But the problem is that if we don't get usage out of these middle ones, we end up with an hourglass. And that's what we've got right now. We've got a ton of kids who need hospitalization. We can't find enough beds, and we don't have enough utilization of these middle levels of care. That would prevent a lot of need for hospitalization later. So that's one of my big passions, getting everybody the right thing. We also find that if we don't get kids to the right level and evidence-based treatment, we burn up all of their hope for change, all of their effort with an ineffective treatment. And we've lost a lot of goodwill. Their view of behavioral health will forever be like, not great. So if we get them to the right level of care and it's going to be effective in a shorter period of time, then they're going, not only are they going to be better today, but they're going to have much more likelihood of seeking help in the future if there's somebody who needs help in the future, which we know that our kids that have anxiety and depression are likely as adults, it's not predictive, but they're likely as adults to maybe need some episodes of care. So we really want to make sure we're not burning through any of that goodwill, any of that hope for change, motivation, with an ineffective treatment. Now, remember what I said about the economy of therapy is such that it's driving down competition amongst therapists. That means that quality, in my perception, speaking for myself here, has not been the highest since COVID. Some kids cannot be adequately treated by telehealth, our little kids in particular. And all kids need to have a treatment plan and some sort of intervention that's targeted and monitored. If it's not effective, they need to be referred up to a higher level of care. And if they've achieved a plateau, then they need to be discharged. Unfortunately, we have therapists who are picking and choosing from their wait list and just taking the easy kids, so to speak, easy kids. So we have families calling and saying, well, I've told them like how desperate we are to get them a therapist and how she was in the hospital. And I'm like, oh, that's not a good sell. Because if I'm looking at a wait list of 30 kids as an outpatient therapist, I'm not picking them. And parents don't realize. So there's a lot of just know-how of the system and of how to best place these kids so that they're getting adequate care and just some savviness. And their care navigation team, I do some as well. We work really from a family-centered perspective where we hear from the families what their preferences are and what they've already tried. Families have already had ideas about what will work for their kid and their family. We want to honor that, kind of go with them. We also work from a really broad perspective of what can we help you with generally that will help your kid's mental health. And that's often like helping a family member with basic needs, like a housing referral, or they need information about immigration status, free legal help, different things, how to get an IEP at school. So we're often just a provider of information, keeping in mind that Psychology 101, Maslow's hierarchy of needs, that if we're hungry and don't feel safe, we can't worry about getting an appointment for our kid. So that's where we work from as well. We find that we get a lot of information from families that they were kind of hesitant disclosing to their provider. They often feel judged and feel uncertain about behavioral health care and didn't like really talk out their concerns. They just felt like they had to say, yes, I'll take my kid to a therapist. I like to do some text dumps. This is just if you're a reader, ignore if you're not a reader. This is more information on what exactly PHP and IOP are. If you had to talk it out with a family, you kind of keep these words handy or nearby. Just a text dump. Another one in a different order. Some examples of different kids who might need these levels of care to help give you an idea. We know someone needs inpatient if they cannot be safe on an outpatient basis. So either they are not able to make a safety plan or they're not able to follow one. They have the plan to hurt themselves or someone else, or they're so out of touch with reality that they cannot protect themselves. Hydration, eating, basic hygiene, going to the bathroom. Or their family isn't supportive enough to get them to their point. Because with kids and adolescents, you're always kind of working in a system with the family too. This kid could be in a different family safe, but in this one, not so much. And crisis stabilization unit is very underutilized option. That's for kids that don't really need a locked facility. Most of them are not usually locked. So their doors don't lock. I mean, they lock from the outside, lock people out, but they don't lock people in. And so this is for kids that are voluntary. They want to go somewhere to have a break from the home environment. They have nursing care and trained staff there all the time, monitoring them. And they can stay there for a little while. It's not as short-term and intense as a hospitalization, a psychiatric hospitalization. That's something good to note that exists, because you often hear kids that feel like, oh, I have to do something to hurt myself to get inpatient care. I need to get out of my house. It's like, don't need to do that. We can set you up somewhere else, a bit more comfortable and more appropriate for what you're presenting with. Partial hospitalization would be for a kid that has really serious depression, anxiety, eating disorder, and they're presenting with some level of risk and they need intensive treatment to be able to stay safe on an outpatient basis or make progress on their symptoms. So that might be somebody who has anorexia and bulimia and is binging and purging, but their vitals and everything looks stable. They've tried lower levels of care and they're still not able to maintain healthy eating. Their family isn't able to log their eating very well. They're still continuing to lose and gain weight or something. For a kid who's suicidal, it could be somebody who's still self-injuring, but has suicidal thoughts without a plan. These are pretty high-risk kids, but they don't need to be imminently in a hospital setting inpatient to treat them. They also don't have the space. These are kids that probably would have hospitalized 10 years ago, definitely 30 years ago. But now we don't have the space and hospitalizations are so short, but these are often kids who are also coming out of hospitalization, often to primary care without a plan, We get a lot of those calls from poor primary care providers who are like, oh, what do I do with my patient? They're just discharged from the hospital to me with a piece of paper and their only follow-up plan. I can't do this. And so we're there to help with that as well. So that's an example of a kid who may go to partial hospitalization. They also have young adult partial hospitalization programs. This is for young adults who are like in college age and they've had a really serious setback in their mental health. They may have had a manic episode, psychotic symptoms, really severe depression, a suicide attempt, and they can be safe at home with some support. Maybe they're back at their parents' house or living with a partner. They can be safe, but they do need a lot of treatment to stay that way. Usually a PHP program is about 3 weeks long-ish. Crisis stabilization is anywhere from a couple days to like 45 if it's a short-term residential program like Leland House we have here in Fairfax. Intensive outpatient program. Partial hospitalization used to be called day treatment. I should say that too. If you guys remembered what day treatment was, where you like kind of go in, it's a day program. I kind of like the name of that better. It feels more friendly. So sometimes I'll say that to family. It's just day treatment. They go, instead of going to school, they go to day treatment. It's also supposed to be all of the programming of an inpatient stay, but done on an outpatient basis. So psychiatrist leads the team. They can see their psychiatrist up to every day. These are all child and adolescent psychiatrists for our kid programs. They have therapists, they do family and group, all that. So intensive outpatient program is less than that. It's usually around 12 hours, although our eating disorder ones are much more. And some of our substance use or other ones are more or less depending. Keep in mind, all of these have CPT codes and insurance pre-authorizations. They're pretty strict about what level they are. You don't need to have any idea what those are. Just know that there's something in there and be able to give hope to somebody if you're giving a referral. They're usually done after school or after work hours for adults. So they're done in later afternoons and evenings, 3, 4, 5 days a week if it's an eating disorder. I think they actually do 6 days a week for eating disorder treatments. There's one of those at Dominion Hospital. So if you're thinking that somebody needs something more intensive than outpatient, this is for somebody who might be having thoughts of self-injury or suicide, but they're not doing it. They don't have a plan, maybe even homicidal ideation, infrequent thoughts, or that are bothering them, OCD, things like that. They're communicating with their family members, their loved one, their partner, but they really need help to stay on isolating, stay in treatment. And then intensive in-home therapy and ABA are both like, depending on the problem, the goal and everything, but they're kind of in that gap between about 5-ish and about 19, 20 hours a week, just in that range. It's very dependent on their diagnosis, their problem, and their goals. But just know that there's other stuff in there that could work on. I think Dr. Corona gave us really great examples of assisted communication. So if you have a person who's not very verbal, not speaking a lot, and having a lot of behavioral issues, you could get behavioral approach. So like an ABA person, or even a behavior tech kind of person to work with the family, as well as communication people, whether that is through the ABA person themselves or through speech therapy. Getting communication improved often really helps with aggression, people that are struggling to communicate, especially adolescents. So that could be like just an example of aggressive behaviors. There are, of course, on that lower level, I think we're much more familiar with those. But that's where the majority of evidence-based treatment lives, is down at this lower level. So problem population groups, once, twice a week groups. This is where you find most of CBT, cognitive behavioral therapy, dialectical behavioral therapy, trauma treatment. These upper levels are really focusing on safety and stability. And if they're using medications, getting those medications to start working. Unfortunately, psychiatric medications have a bit of a lead time. So we gotta keep them safe while they start working and then start adjusting to get the right mix for them. So there's higher up levels of care, like I would say IOP and above, are usually just about that basic functioning and resourcing the environment, getting whatever conflicts are going on stabilized so that they can be okay. And then these lower levels of care are really getting at the core beliefs, thought patterns, and unhealthy behaviors and addressing them at the root. So that's why it feels sometimes like evidence-based treatment is only informing higher levels of care. It's because they can be informing higher levels of care, but you can't do a full evidence-based treatment if somebody is very unsafe to themselves and others. Got to kind of stabilize that, and then we can work on that other stuff. It's kind of like life-threatening. Well, it's life-threatening comes first, and then we can kind of work down. So these are where most evidence-based treatment lies, is down at these lower levels. Questions so far? Let's see. Oh, I see some in the chat. So is a mental health access program associated with NAMI. So NAMI is a National Alliance on Mental Illness. It's a nonprofit that is run by families and individuals who identify as having mental health problems. And it's an awesome program. We have people who are deeply affiliated with NAMI Virginia who have advised we have a couple on our advisory boards. We are not officially part of the same thing. Virginia Mental Health Access Program is a state program with federal and state funding that is designed to provide service to prescribing providers in the state, whereas NAMI is a public education support program for citizens. Does that make sense? NAMI is really excellent at providing parent-to-parent education classes, parent-to-parent support groups. So parents of children and young adults with serious behavioral health issues. Yes, like Gigi said, very highly rated and very helpful for families who are struggling with a family member's mental health struggles of like, how do I help them? Very helpful. There was another question. No, maybe that's it. Okay. NAMI also does a lot of work on public education and decreasing stigma towards mental health, making sure that it's more accessible and talked about so that people don't feel as isolated and stigmatized. On all of these levels, running throughout the levels of care, crisis assessment intervention is available. So if you're ever like, someone else has just got to see this kid today, that's your feeling on exam or in a telehealth session, there are resources to refer them to where they can see a therapist who specializes in crisis intervention that day. Irregardless of Medicaid, insurance, undocumented, it doesn't matter. In Virginia, we all have community services boards. So you would find out which CSB or which locality your patient lives at, and then that would be their local community service board. They all have different hours and different procedures to do an emergency assessment, but there's some availability during business hours, Monday through Friday. And they have emergency ability to come out to the emergency rooms and do emergency assessments if somebody needs hospitalization. There's also, what do they call it now? Community regional response. They used to call it children's response, but now it's adults as well. It's called CR2, and their website is cr2crisis.com. It's a really good one. They have a bit of a confusing admissions checklist, I will say. It's in my experience working with them, making referrals. Sometimes they'll take a patient, sometimes it won't. So I'm always telling families, like, I need you to see someone today. That's my bottom line. It could be CR2 because CR2 comes out to families, which is awesome. Or REACH, if they have a developmental disability, there's a state program called REACH, REACH. It's a crisis line for children and adults with intellectual and developmental disabilities. So if somebody has a diagnosis of autism or has a Down syndrome or a genetic condition that causes intellectual disability, they can get specialized in the community crisis response through those numbers. And then the CR2 is for anybody that has a behavioral health crisis, and they can assess them at home, in the school, come out to wherever they are in the community. So that's a really great option if you're like, I think this kid is not okay, but I'm not sure enough to send them to the ER, but not sure enough that they need inpatient treatment to send them to the ER, because that can be a whole difficult process for kids too. Like, oh, they said something that made me feel uncomfortable. How about let's just agree to get you in front of somebody who specializes in this today? And that's a really great way to do that. Of course, if you're really not sure, do not pass go. Just to refer them to the emergency room. In this area, it's always best if you're referring someone to an emergency room for mental health to send them to one of the children's hospitals because they have specialized training and staff in assessing kids with mental health. I think like a third of the kids who come into the children's ED here have some sort of behavioral health thing going on, either in addition to what they're presenting with or as their primary presenting thing. So the Children's Hospital here, there's the Children's Hospital, Inova Children's Hospital in Leesburg, Loudoun, and then of course, DC, Children's National. In the name. So those are my preference if the family's going to go to an ED, to go somewhere for their children's ER. They just have much better care than going to like an urgent care or somewhere where they won't have psychiatric or mental health staff physically on site to advise them to make the process that much better. I also encourage you, if you're sending a patient to the emergency room or even the CSB or CR2, to do your due diligence just like you would if there was a medical emergency, a physical medicine emergency. Call over and ask to talk to the attending, tell them why you're sending them over, tell them specifically you're concerned, because sometimes what happens is the family gets there and they said, well, she was kind of mad and said she wanted to die. And you're like, actually, she said, I've been stockpiling Tylenol and my prescription gabapentin for 3 months, and tomorrow's the day. Like, the story that they get isn't always the details that they're looking for. Families will often say the most shocking thing or most distressing thing to them instead of like the most distressing thing clinically. So they might say, oh, you know, my teenager called me out of my name, called me a whole bunch of curse words. He's lucky he's still alive. But neglect to say that he's going to kill himself, and he has attempted for it in the past and had a hospitalization. So sometimes, you know, just keeping in mind that parents who have a kid in crisis are in crisis themselves. If they have any kind of connection with their child, they're pulled into crisis too. So they're not fully making sense. So just make sure if you send anyone to the ED, call over and say, here's my concern. I'm making sure that you know their name, why they're coming in, and the very basic bare bones of your concern, keeping in mind that HIPAA has an exception for emergency situations where you're very concerned about someone's safety, and you just document that in your record. Any concerns about that, you leave them in a room and call us. VMAP. That's what I like to do in particular. They say we're not a crisis line everywhere. We're not a crisis line, but we're available Monday through Friday, 9 to 4:30 is usually our last call, but we answer the phone until about 5. So during those times, we can definitely be a help. If there's somebody in your office, you're not sure what to do with them, you kind of want to run through like, what are my options here? So that's always available to us 24 hours a day. Here is our phone number. But I find that, I don't know about you guys, but I don't think people really do the whole memorizing the number thing anymore. Feels like we're going a little bit back to the 80s and 90s. So I tell people just go to vmap.org. There is a way to request us to call you at a certain time on vmap.org. So if you say, I know I'm going to see that one patient, and then I want Julia to call me at noon, so I think I'll need to talk to the psychiatrist after I see that one patient. This is going to be a good one. Then you can go ahead and get on our website before you even start your day and say, I'm going to need a call at 2 or whenever your charting time, whenever your lunchtime would be. So then we can call you and start that process. If you're very certain you just want care navigation for your family, you're like, I know exactly what's going on, have no need for a consultation. I have made a way of requesting that. You can call and I can email you the fact sheet to fax us a referral for care navigation only. So that would be like your patient who comes in and you find out about something unrelated. They've tried to get therapy for it. They experienced a trauma. They're looking for a trauma therapist who takes Medicaid, who works with kids that age, who can do play therapy, for example, or whatever trauma treatment might be indicated, and you just want help for the family to get that. Then you just call us and let me know. And we can either just take the demographics, even from like your nurse, your MA, or you can fax us the sheet. If you have an Inova email address, you can email it to me as well, because I have no email address and it's all encrypted. But other than that, fax is safest because of HIPAA. You want to make sure you're not emailing stuff unless you encrypt it. Keeping in mind, consultation for behavioral health is just like consultation for everything else. It is covered under HIPAA. You don't have to tell a patient or a family member or parent that you're seeking consultation with a psychiatrist or with me through VMAP. But families are usually really supportive of that idea. I'm usually pretty happy that you'll use that resource, and then helps guide them to someone else. Like, hey, you need more help than I can. Like, I want to lean into it, but at the same time, I want to set a boundary of like, this is how much we can do from primary care for my specialty area. And then follow up with them. So this is how you get a hold of us. I hope that you heard my objectives. VMAP's a federally and state-funded program providing education, consultation, care navigation to PCBs. We say we actually serve all prescribing providers in Virginia who work with kids or young adults up to 22nd birthday, but we just focus on primary care, but it's not exclusive to primary care. And we hope that you know we provide education, consultation, care navigation to families and to PCPs finding behavioral health resources and how to access us. You can call us. You can do the online request on our website, and then you could call me and get the fact sheet if you want to fax us a care navigation request. Questions for me? This is the one you wanted with websites. This is our main website, and then our impact report has a lot of cool data about what we did and how many we did. If you're interested in that stuff, it's there in the last year. And then our guidebook, which is really cool. It's like searchable and has all this clinical decision making flow sheets. And I think we'll be giving the slides, so great if you're interested. Okay, you can click on them. So our partners, and do you have any questions for me? Enjoy.
There's complexity and some problems with the communication device not have one kid in mind who uses a communication device who said like I want to talk to someone, I know I feel depressed. I can't tell you how much time I find someone to help them. And here medication. I've been going on because of the psychology today.
Mhm.
So then they live in and medicate and then because I did not know how else to help. I tried to get touch from therapists. And then I out my so that's why
That's what you did? Okay. Okay.
because I'm stuck on it. $200 after this. These are not, so I feel like, complex care and they're sometimes still aren't there, but during like a holiday. Sometimes the depression is worse and they feel out of doors. I mean, especially school started, I hear a lot.
Yeah.
It's not. You need to go to CPR, anyway, so I have that.
Those ones are easier. When you know they need to go to the ER, it's almost easier, right?
Yeah.
But when it's bad and you don't know. Mhm. Mhm.
Another so I could probably
Hmm?
okay, and say, I talk to some of my I feel better and look at them. They're
Yeah. And if you're not sure, if you're like, I have no idea what I could even offer them, just call us and then we'll tell you, and then you can tell them. You know? Well, we still would need you to tell us what you've seen, because the advantage to doing care navigation through a provider is that you've seen them.
Yeah.
Like you have some context for them, and you can also tell us their insurance and where they live and what you think they need. So we're not going blind into this. But for your kid who doesn't speak verbally, does he sign? You sign? Here's the communicator. Yeah. This person's able to communicate with you, right? Yeah. So they would be able to do any kind of therapy that they wanted to. Yeah, face-to-face therapy. Also typing. Yeah, you could also do telehealth. He could do telehealth potentially, where he could type with somebody and be with them and typing, like in Zoom. Yeah, we love hard cases. That's our favorite. Yes, especially like we have a huge equity focus in all of EMAP, and we really look at our data and see who we're serving. And especially for our kids who are Medicaid or undocumented, don't have insurance, or disadvantaged, multiply disadvantaged, we especially like taking those ones on and trying to be creative. There's a special set of funding called Children's Services Act. You may have heard of it from medical sides, that is administered through these multidisciplinary teams in each county. And there are ways to get kids something that they need, even if you can't find it like here. Generally, people who are accepting Medicaid aren't, oh, it's Thomas, I know. He's good. He trained where I used to work. Yeah. That's a really great way to go. The other thing you can do is if you're seeing a lot of a certain population, like if you see a lot of kids with comorbid physical pain. I know of people who do a lot of work with kids and adolescents who have physical health disorders. And so we can make a custom list for you, essentially for your practice, and with just the names of the insurances that somebody takes. I did one for a Korean speaking all the physicians of this one practice speak Korean and the providers, all of them speak Korean. And so they have a lot of Korean speaking families come in. And I was like, well, why don't I just make you a list? You know, you can just keep it in your office if this is a population you see a lot. Another list I made was for, oh yes, trauma therapists who take Medicaid and speak Spanish. Only a few of them in the state, but I made a list for it because there's a community health clinic that needed a list for that. So I can certainly make a list if there's a population you see a lot and you want like something to just have on hand. But in general, those tricky cases are ones that are best done, you know, through our care navigation, because that way we can have that two-way conversation with the family about like, this is what's out there. What are your choices? Empowering them to kind of understand how to navigate and advocate for their kid the best they can. But this is how we find stuff. We use psychology today. We also use a whole lot of other search ways to search for things. A lot of practices don't advertise their services because again, that demand is so high, they don't even need to have a website in there. It's really wild. Thank you for your question, Julie. I think I saw another one. Yeah. Yeah, one of our psychiatrists, back on my slide, Dr. Gandhi from Children's actually has an area of specialty with functional medicine and pain. And so she works with a lot of our kids that have conversion disorders. That's like if their arm stops working or they can't see properly because of the combination of their physical pain, their physical disorders, and their anxiety and psychological distress. So there are people out there who specialize in this stuff. Yeah, and there are therapists who do the CPT for pain management. So I know everybody had at least one patient come to mind as I talked about this. And it's okay to think, you know, that's water under the bridge. You didn't know about this at the time. So, you know, that's done for. Now you know we exist and you can use our help for patients in the future. But if you think of somebody who's still currently on your caseload that you're still seeing, absolutely call me, send me a message. Yeah, please do. And if you know exactly what you're looking for, like if you know, like Julie, if you know that you need therapy for your young man, you can even just put your MA on it or your office manager. It doesn't have to be yourself taking the time to call, because I know that can be a huge stressor, you know, taking that extra time out of your schedule. People are calling us on their days off or on lunch breaks and come. Yeah. So it looks like NAMI got a plug here. I think also I'll put CR2 in there too. It's a good one to know about. It's a community resource. You can get someone to come out into the community to see someone's kid. They're much more likely, parents are much more likely to go for that than taking them into a place. Fields. So community service boards are housed in government buildings, like usually by social services. And a lot of families, especially immigrant families, are not really going to want to go in there. They're going to say, oh man, they're going to ask me like where I live and for residency and stuff. They don't know that it doesn't matter. Fairfax County they're not going to call ICE or something on you. They don't really care, but it feels too governmenty. And then imagine you have even any element of paranoia. You're not going to go to a government building or send your info, right? So no way. So CR2 feels very accessible. Seeing a therapist feels much more accessible than potentially going into an ER or going to a government building for an assessment. So kind of feel out options with families, see what their objections would be. But if you ever need to like insist, then the emergency room or the community service board would be the way to go. CR2 sometimes will not take a case. They'll say, oh, you're not, you know, in crisis enough. Again, there's that miscommunication with families, because often they're taking the information for a parent who's communicating what's most distressing for them, not necessarily what's most clinically distressing or indicative of crisis. So imagine if you had to take a history and physical only on the phone through a parent. They might miss out like, you know, the most important stuff. And so that's what we see. Yeah, but please, oh, I should put us in there too. So you can click on it. Yes, they do all of what we consider Northern Virginia. So they do Arlington, Alexandria, Falls Church, and Fairfax. Prince William, Loudoun, Stafford, I think is their limit. Stafford and Fauquier are their limit. They do all the way out through Loudoun. And then you can still get those services in the other counties. They're just called something different. It's all by National Counseling Group, which is a company that has grants or contracts with the state. So they do mobile crisis in Fauquier County, Spotsylvania. They just call it something different there. It's a different phone number. But my region in northern region, you probably saw on the map, goes all the way from Orange, all the way up to Arlington, and then back down to Spotsylvania. Big area. We have people all over the state. So if there's something I don't know about, I check with my team too. So, if they're like in King George, like over by Fredericksburg or something, I know of some stuff, but we put our heads together if there's a family along the borders. Try to figure out what's possible for them. So that's my thing. I love to come to work every day and not know how I'm going to help somebody, but I rely on you guys to bring us these tough cases and to lean into their behavioral health, especially as it's affecting their physical health. That's why I think that's why the nephrologist was calling. Right. Yep. Patient was on declining, potentially life-saving medications, had a mental health diagnosis. Yeah, there's a lot of different reasons why someone call for consultation. And a lot of providers seem to think that our psychiatrists are going to encourage or really push them into prescribing for kids and really push their scope of practice out where they're not comfortable. And that's not the case. We're all about working with whoever, whatever your comfort level is. And if you want to grow, that's great. If you don't, that's fine too. We're just about reality. Reality is we're under a deluge and everybody needs help. So we want to make sure we're all accessible to everybody, whether or not they really want to be in this mental health realm or not. We all are. We do. We're going to get more people on our team. We have the funding. Thanks, Gigi. I just hired a new care navigator. So we have 2 full-time ones. And Millie, who's my first one, she's Latina and her Spanish is her first language. So she works a lot with our Spanish-speaking families to really understand the mental health system and to not feel so intimidated and othered by it culturally, making sure it feels like that people will be respectful and understanding. So they have a lot of concerns. Also imagine that you're going to send your kid to a therapist and you can't speak to that therapist. That would feel kind of weird, right? So we make sure that we try to get bilingual therapists for our bilingual families. And we can still do that even with Medicaid. It's a little trickier. We talk through pros and cons, like, is it more important to wait a little longer and get a bilingual therapist, or do telehealth and get a bilingual therapist, or is it more important for you that you start as soon as possible and then maybe make use of the Medicaid phone interpreter line? What people don't know, there's phone interpreter services for providers treating Medicaid patients. They can use phone interpreter. All these little things. We like to advocate for our kids. Like I said, we have a big equity focus. So thank you guys, especially Gigi, for giving us these great questions here. And I do hope to talk to you all on the line. I really love getting calls for everybody. Yeah, thank you.
Thank you so much, Julia. So with that, we're coming to a close here. Thank you guys so much for those of you who stuck with us, especially in person on a Friday afternoon, and for all of you guys who joined virtually. Like I said before, make sure you fill out that survey, and then that's how you'll claim your CMEs. And yeah, just wanted to say thanks to all the speakers. Thanks to Nova Fairfax for the use of the space. Thank you to Megan and Julie and Patty for, running all this. And then our PSV people out there who can't hear me, but Gabrielle and Carisha, thank you guys so much. And for those of you who need parking, we can validate your parking, I believe, before you leave if you park in the garage. And I hope everyone has a great weekend. Feel free to reach out to us because I think a lot of the speakers left their emails. And so we're always happy to hear from you if anyone has any questions later. Right. Thanks, guys.